Good morning, good afternoon, and good evening, wherever you are joining us from today. On behalf of OncoDaily, welcome to the World Melanoma Day Global Symposium. World Melanoma Day is not a day to celebrate, it is a day to commit to earlier detection, to better outcomes, and to ensuring that the advances happening in leading centers reach every patient, no matter where they live. Today, we have 12 hours of science, advances, perspectives, treatment choices and options, and future directions, brought to you by leading experts from across the globe. We meet at a remarkable moment, an era of new approvals, rapidly evolving standards of care that are shaping how we approach the disease at every stage. This is exactly the conversation we need to be having, and today we are having it together, brought to you by OncoDaily. We're fortunate to have exceptional leadership for this conference. Our chairs, Dr. Stephen O'Day, who is the Chief Medical Officer at the Genus and a pioneer of cancer immunotherapy, whose contribution to CDLA4 treatment have shaped the field for decades. And our co-chair, Dr. Barbara Ma, who is the Director of Cell Therapy for Solid Tumors at Weill Cornell Medicine in New York, a leading voice in melanoma, TIL therapy, and immune-oncology. It is now my pleasure to welcome Dr. Barbara Ma to open our scientific program with her lecture on advanced melanoma. Dr. Ma, the floor is yours.
Welcome, everyone, to the OncoDaily World Melanoma Day Global Symposium. My name is Barbara Ma, and I'm an assistant professor in cutaneous oncology and director of cell therapy for solid tumor at Weill Cornell Medicine. It is my great pleasure to be co-chairing this symposium with Dr. O'Day, and I'd like to sincerely thank OncoDaily for their invitation and their continued support of the melanoma community. Today, I'm going to be talking about advanced melanoma in 2026 and how we are evolving to have more personalized and adaptive treatment strategies. Melanoma is one of the most remarkable stories in modern oncology. It was transformative to go from one of the most deadly solid tumors into one where long-term survival is now realistic for many patients. If you look at this timeline, what's remarkable is not simply the number of approvals, it's how rapidly the field transformed. For many years, metastatic melanoma was considered a death sentence, one of the most treatment-resistant solid tumors, and historically, options were extremely limited. Chemotherapy produced relatively low response rates, with overall survival only on the matter of 5 to 9 months. And although high-dose IL-2 occasionally produced durable responses, it was associated with substantial toxicity and benefited only a small subset of patients. Then, over roughly the span of a decade, melanoma became the disease that helped redefine modern oncology. We saw the emergence of immune checkpoint blockade that's highlighted up in blue. Then targeted therapy, and these FDA-approved combinations are outlined here in orange. Then we saw the bispecific T-cell engager tebentafusp for uveal melanoma. And then eventually cell therapy with lifileucel tumor-infiltrating lymphocyte, FDA approved in February of 2024. Importantly, melanoma became the proof of concept that the immune system could generate durable cancer control. And many of the concepts that we now apply broadly across oncology were first established in melanoma, which means immune checkpoint inhibition, durable survival curves, combination immunotherapy, and increasingly adaptive treatment strategies. So in many ways, melanoma has not simply participated in the immunotherapy revolution, it helped lead it. One of the landmark advances was the development of immune checkpoint blockade, and trials such as Checkmate 67 fundamentally changed expectations for patients with advanced melanoma. So historically, the metastatic melanoma survival curves were pretty dismal, as all they had at the time was dacarbazine and Temodar. But with combination immune checkpoint blockade, we began to see something very different, a subset of patients remaining alive many years later. And you can see here that the tail end of these curves are pretty flat, showing that these are very durable. So I think one of the most important conceptual points is that the breakthrough was not simply improved response rates, it was durability. So the possibility that metastatic melanoma could, for some patients, become a long-term controllable disease fundamentally changed how oncologists thought about cancer therapy. And so today, durable remission and long-term survival are realistic possibilities for many patients with advanced melanoma. It means that they have the chance still for cure in stage 4. Now, the caveat is that not all patients benefit, and resistance to immunotherapy does remain a major challenge, but immune checkpoint blockade transformed the field because durable survival became possible. The field has continued evolving beyond the original CTLA-4 and PD-1 combinations. More recently, newer combinations are targeting LAG-3 as another immune checkpoint. So that is how relatlimab nivolumab has expanded the therapeutic landscape, and that was the Relativity 047 trial. So the rationale behind targeting LAG-3 is that LAG-3 is a cell surface molecule that is expressed on immune cells, including T cells, and negatively regulates T cell proliferation and effector T cell function. So LAG-3 and PD-1, they are distinct inhibitory immune checkpoints that are often co-expressed and contributing to tumor-mediated T cell exhaustion. In preclinical models, dual inhibition of LAG-3 and PD-1 showed synergistic anti-tumor activity, and it was through Relativity 047 that was the landmark phase 2/3 clinical trial that led to its approval. The goal is also not only deeper immune activation, but improved tolerability. And the treatment-related adverse events were noticeably lower in the relatlimab nivolumab trial compared to looking at the Checkmate 67. So a lot of the focus in terms of treatment options in melanoma is this balance between efficacy and toxicity. Since combination immunotherapy, while they can produce remarkably deep and durable responses, they can also produce significant immune-related toxicity. So increasingly, modern melanoma care involves not simply asking whether immunotherapy works, we clearly know it does, but rather which patients require more intensive immune activation and which patients may benefit from more tolerable approaches. So one of the most fascinating things about melanoma today is that we now have two highly effective but fundamentally different therapeutic strategies. And I like to think of it as the tortoise and the hare. So immunotherapy, analogous to the tortoise hare, they may sometimes take longer to work, but when it works, responses can be extraordinarily durable because the immune system develops memory. For targeted therapy, or in this case, the hare, they, in contrast, often produce very rapid responses. And that can be critically important for patients with symptomatic disease, rapidly progressive disease, or high disease burden. I often think of these as different therapeutic philosophies. Immunotherapy emphasizes durability and long-term immune control. Targeted therapy emphasizes rapid cytoreduction and immediate disease control. Importantly, both remain essential components of modern melanoma care. So we have effective therapy options. Now, the next question is, how do we sequence them? So fast forward to the DREAM-seq study. So this was a very important cooperative group study that looked at patients with BRAF V600 mutated melanoma, where they were randomized to either receiving immunotherapy with ipilimumab nivolumab first or targeted therapy with dabrafenib trametinib first. Patients stayed on these therapies for as long as they responded, and at the time of progression, they crossed over to the other therapy. So arm A and C is where they received the immunotherapy first, whereas arms B and D is where they received targeted therapy first. And as you can see, these Kaplan-Meier curves, the 2-year overall survival rate was in favor of ipi-nivo first, with a rate of 68.3% versus 54.1%. And fast forward to the 5-year overall survival rate, where the curve becomes even more separated in favor of ipi-nivo first at 63.3%. So this is what established that patients with BRAF mutated melanoma should be offered immunotherapy first. The optimal therapy depends not only on mutational status, but also on factors such as tumor kinetics, disease burden, brain metastases, patient comorbidities, and patient goals. This is part of the broader movement towards increasingly personalized melanoma care. We are no longer simply asking, what is the standard therapy? We are asking, what is the right therapy for this patient in this clinical context at this moment in time? So, for example, brain metastases may influence treatment intensity. Tumor kinetics matter greatly, whether disease is indolent or rapidly progressive. Mutational status influences the availability of targeted therapy, and patient comorbidities, including autoimmune disease, may influence tolerability. And importantly, patient goals matter. So, my general approach, taking into account these several factors, is that if they are BRAF mutated, indolent disease, then immunotherapy first. If they have symptomatic visceral crisis, then they also have a BRAF mutation, then that's where would offer targeted therapy first. If bulky and aggressive, then combination immunotherapy. If they are frail, have a borderline performance status, then would consider offering anti-PD-1 alone. In patients with autoimmune disease, this can be individualized. And if general, in my practice, if they have brain metastases, I do favor combination ipi-nivo. So increasingly, treatment decisions are individualized, and this is where movement towards personalization becomes even more important when we see immunotherapy and other treatments offered in the earlier settings, such as neoadjuvant setting. So, one of the most exciting developments in melanoma over the last several years has been the emergence of neoadjuvant immunotherapy. Historically, we thought about systemic therapy mainly in the metastatic setting or as adjuvant therapy after surgery. But increasingly, we are now treating more patients before surgery and seeing a chance at early cure. So, I do want to underscore the point, though, that neoadjuvant is not simply earlier therapy. The biology in the tumor may actually be fundamentally different. When the tumor remains in place, it may serve as a rich source of antigen exposure for the immune system. In other words, the intact tumor can potentially act as an immune training ground, priming and expanding tumor reactive T cells before surgery occurs. So that concept has translated into important clinical studies such as PRADO, SWOG 1801, and the NADINA trial, which reinforced this paradigm. The NADINA trial was the landmark phase 3 trial of neoadjuvant nivolumab and ipilimumab in resectable stage 3 melanoma. And what I really wanted to highlight from that paradigm is that neoadjuvant therapy gives us something that we previously did not have, which is a real-time biologic readout of treatment sensitivity. And this is where the field becomes especially exciting because historically melanoma treatment decisions were mainly static. We made decisions at baseline based on stage, mutational status, imaging, and clinical factors. And now increasingly, we may be entering an era where treatment intensity can be adapted based on how the tumor actually responds to therapy. So patients would get neoadjuvant therapy. In the case of the NADINA trial, it was 2 cycles of ipilimumab and nivolumab, followed by surgery. And if patients achieved a major pathologic response, and sometimes even a pathologic complete response, then there's actually consideration for whether we can safely de-escalate, and some patients could be on observation. However, if they have resistant disease or significant residual viable tumor, then they would be considered for adjuvant therapy. It is of note that perhaps that the patients with resistant disease that still have significant residual tumor after neoadjuvant immunotherapy, they may represent a particularly high-risk population that could benefit from treatment escalation, whether that could be alternative strategies such as cell therapy, such as TIL, or clinical trial enrollment. Could some patients require less surgery, less adjuvant therapy, less cumulative toxicity? Those are some of the questions that come up of interest. But ultimately, neoadjuvant therapy is increasingly functioning not only as a treatment, but also as a biologic decision platform. So to me, this represents one of the most important paradigm shifts in modern melanoma. We are moving away from a one-size-fits-all approach and towards adaptive immuno-oncology, where therapy intensity may eventually be personalized based on real-time biologic response. Despite all of these advances, significant challenges remain. For example, how do we optimize outcomes in patients with brain mets and leptomeningeal disease? This remains an area of significant need, where often patients with active brain mets or leptomeningeal disease are excluded from many clinical trials. How are some of the ways that we can try to manage this? And really, we will see some interesting lectures throughout today's symposium trying to answer some of these questions. Another challenge is immune-related toxicities. They require increasingly sophisticated multidisciplinary management, and there are many different approaches in trying to discover what are ways to spare steroids, especially since steroids can limit the efficacy of immunotherapy. So if there are ways to mitigate toxicities such that patients may restart treatment sooner and therefore benefit from therapy longer. A third challenge is resistance. Resistance remains one of the most central biologic problems in melanoma, and you will hear more about approaches for PD-1 resistant melanoma later today. And importantly, global access does remain an important area to highlight, because one of the striking realities is that many of these transformative therapies still are not equally accessible worldwide. And you'll hear some talks later today about how melanoma is treated in different parts of the world. So many of these important questions will be explored throughout today's symposium. So where is the field headed next? The next phase of melanoma care will likely become even more biologically informed and increasingly personalized. I think that cell therapies such as TIL, tumor-infiltrating lymphocyte therapy, represents perhaps one of the most personalized forms of immunotherapy developed thus far. Emerging biomarkers such as circulating tumor DNA may further refine how we monitor disease and tailor therapy over time. And other ways that we're looking at are adaptive treatment strategies to also allow for earlier intervention. So what's exciting is that melanoma continues to function as a leading platform for innovation in oncology, and many of the concepts being pioneered in melanoma today will likely continue influencing the broader future of cancer immunotherapy. So in closing, if there is one overarching theme in melanoma today, it is personalization. We're increasingly tailoring therapy based on tumor biology, disease kinetics, clinical context, and patient goals. Durable survival became possible with immune checkpoint blockade, letting us know that durability is a possibility even in stage 4 disease. Therapy selection increasingly requires nuanced biologic and clinical decision making. So, for example, if you have a BRAF mutation, it does offer targeted therapy as an option, but in general, immunotherapy should be offered first. Unless there are certain scenarios such as symptomatic brain mets or visceral crisis. Neoadjuvant immunotherapy is fundamentally changing melanoma from a disease where we select treatment once at baseline into a disease where treatment is dynamically adapted based on biologic response. And melanoma continues to shape the future of oncology, such as cell therapy strategies, including TIL, where TIL was the first cell therapy approved for any solid tumor, and melanoma is leading the way. So the progress we have seen over the past decade would once have seemed unimaginable, and yet many of the most exciting advances may still lie ahead. So thank you everyone for joining us virtually today. We have a truly outstanding lineup of speakers joining us from around the world, and we look forward to an excellent symposium. Norin.
Good morning. My name is Carlton Johnny. I'm one of the radiation oncologists at Cancer Care Manitoba, Winnipeg, Canada, and I thank the organizers for giving me this opportunity to speak about the role of radiation in melanoma. So I have titled my talk as Radiation in Melanoma, the Immunotherapy and Targeted Therapy Era from Palliation to Precision Ablation. For many years, radiation in melanoma was always an afterthought. It was labeled as radio-resistant, and radiation was used late, often for symptoms such as bleeding, bone pain, or whole brain radiation when they had brain mets. But that paradigm has changed completely. So the central message of this talk is that radiation is no longer a salvage option, but a partner with systemic therapy. So melanoma gets its reputation for radio-resistant tumor from the conventional fractionation era, where we used 1.8 to 2 gray per fraction. But we've learned that it's more dose per fraction dependent than actually anything else. So with SRS and SBRT, we're not only delivering more radiation, but radiation which is biologically distinct and different from what was known before. So the modern question is no longer, does radiation work in melanoma? The better question to ask is where, when, and how do we use radiation so that it supports the systemic treatments? To understand this, we need to know how radiation was used and how it was studied in melanoma. Melanoma has a low alpha beta ratio, which is around 0.6 to 2.5. So it's very efficient in repairing the sublethal damage that radiation causes. That means that the time duration between two fractions is more than enough for the tumor to repair its damage. This means radiation was tough or was hard to deliver to these patients because they were able to repair whatever damage that we were causing faster than the time it was taking to kill the tumor. But does this mean that they are absolutely radio-resistant? No. This means that they are resistant to radiation in the smaller dose per fraction. That's why when we use hypofractionation in SRS and SBRT, we kind of overwhelm the tumor's ability to repair itself, and we convert radiation from being a modest cytotoxic intervention to an ablative treatment. And at ablative doses above 10 to 15 gray, we are not only damaging the DNA, but we are also affecting the tumor vasculature. High-dose radiation activates the acid sphingomyelinase pathway in the endothelial cells, and it causes angiogenic cell death. So high-dose radiation does not follow the conventional DNA damage and cell death trajectory, but it operates in an entirely different highway. So in short, SBRT and SRS are not just stronger conventional radiations, they're biologically a different treatment that we're looking at. And coming to the immunotherapy era, radiation can induce immunogenic cell death. So when radiation affects the tumor cells, it releases neoantigens or the tumor antigens, which activate the antigen-presenting cells and which leads to priming of the CD8 T cells. So radiation can increase inflammatory cytokines, activate the immune system, and also in some situations upregulate PD-L1 expression. So in short, radiation acts like an in situ vaccine-like stimulus. One of the most important pathways that connects radiation with immunotherapy is the C-gas sting pathway. So when radiation affects the tumor cells, the DNA is damaged, and the double-stranded DNA comes into circulation, which activates the C-gas pathway, which in turn activates the STING pathway. So this one leads to a downstream immunogenic response, which primes the T cells, which causes an immunogenic response. Probably this is the mechanistic explanation of using a synergistic approach in treating melanoma with radiation and immunotherapy. So radiation creates the antigenic and inflammatory signal, but immunotherapy helps the signal from being shut down, or in some cases even amplify it. But the question is, how do we do it? And that's when we figured out that the dose and the fractionation matters. So moderate hypofractionation, which is in the ballpark of 8 gray times 3, may optimize the immune priming through activating the STING pathway. However, when we go beyond 12 to 15 gray, we've noticed that another pathway gets activated, which is called the Trex1. What it does is, in the previous slide, I showed you that the DNA, when it comes into circulation, it activates the immune system. But when this Trex pathway is activated, we've seen that the DNA which comes into circulation is degraded. So it's not able to activate the immune system. So we lose the immunogenic potential of radiation when we go beyond 12 to 15 gray. So that's why 8 gray times 3 is becoming one of the favorites of radiation oncologists. Not because it's superior, but it kind of is in the sweet spot where you get good tumor ablation at the same time you activate the immune system. Now, the reason all of this matters is because systemic therapy has come a long way in melanoma. The ipi-nivo combination has changed the way we look at melanoma treatment as of date. So we need to look at radiation operating in the context of long-term survivors and patients who are on ipi-nivo treatment. So every decision we take as radiation oncologists, we need to keep in mind about the local therapy decisions, how are you going to preserve the systemic therapy sequencing, quality of life, neurocognition, and what are the future options? So coming to the role of radiation in this situation, there are 3 distinct sites or 3 distinct states that I would call where we can use radiation. First is the true oligometastatic disease, where there are a limited number of metastases at presentation, and the concept is that you ablate all the known sites of tumor, you might produce a durable response. Second one is oligoprogression, where patients on systemic therapy, good response, couple of spots are acting up. So that's where we come in. The third one is consolidation. That is, you've had a good response with systemic therapy, and there might be residual sites of concern that can be treated with radiation. So the common theme is that radiation is no longer sitting in melanoma to treat symptoms. It is being strategically used to alter the natural course of the disease. In practice, oligoprogression is probably one of the most important uses of SBRT. And we usually see this in practice where one of our colleagues gives us a call saying a couple of spots are not responding or getting bigger. Could you help? So patient is doing well on immunotherapy, but some of these cytotoxic or immune-resistant clones might be growing. That's where the radiation comes into picture for consolidating. The concept is, if we ablate the progressing lesion, we may be able to keep the patient on the current systemic therapy and delay the need for a second line therapy. So SBRT is used in this context, and it's very helpful in delaying systemic therapy failure. Coming to one of the most asked questions of abscopal effect. It all started from a case report that was published in NEJM, where when we use radiation with ipilimumab, we see a response in the non-radiated disease sites. It was an important proof of principle, and we've been building clinical trials and studies based on that. But in clinic, the practical message that I use is that radiation can generate an immune priming effect, and the checkpoint inhibitors that we keep patients on may help in converting that priming effect into a clinically meaningful systemic activity. So does it work? Yes. Will it work for everybody? We don't know. So that brings us to the next concept of how do we sequence radiation with systemic therapy? We've got preclinical models suggesting that radiation followed by checkpoint inhibition is the best way to move forward. And biologically, it does make sense because radiation releases the antigens, causes inflammation, and changes the microenvironment where immunotherapy, when used in close proximity with the radiation, helps to amplify that response and give a sustained duration of treatment and effect. But when we look at targeted therapy, it's a little different from immunotherapy because the way they act are totally different. BRAF and MEK inhibitors could be potential radiosensitizers because they impair the tumor's ability to repair the DNA damage. So in that case, we need to be aware that when we combine them with radiation, you could also have higher normal tissue toxicity. This is especially important when we're treating sites like brain or mucosal surfaces, where when you combine SBRT with a checkpoint inhibitor with targeted therapy, you might notice higher side effects. Brain mets in melanoma has always been a topic of research, and historically, brain mets in melanoma often means poor prognosis with survival less than 6 months. Whole brain was usually used before, but now with ipi-nivo, long-term survivorship, we know that whole brain radiation can have a lot of neurocognitive effects. So for limited brain mets, focal SRS has largely replaced whole brain radiation. But in melanoma, brain mets treatment is not just local therapy problem, it's also a sanctuary site problem. So the modern decision is between, do you do upfront SRS or systemic therapy, or do you combine both? If you see here, this slide summarizes the outcomes of SRS alone versus SRS plus systemic therapy. So the main takeaway is that SRS and systemic therapy complement each other. They don't compete with each other. So SRS controls visible lesions, and systemic therapy treats microscopic intracranial disease. So the art over here is choosing between the right sequence and timing. This brings us to discussion around Checkmate 204. This changed the way we looked at melanoma with brain mets. So the combination treatment produces a higher intracranial response than what has been published in literature. So in carefully selected patients with small volume asymptomatic brain mets who do not require corticosteroids, probably upfront immunotherapy is the answer, and keeping them on MRI surveillance as possible. But if you're symptomatic, then we need to probably figure out how to sequence radiation with immunotherapy. When we talk about concurrent treatment, we need to define what we mean by that. Some studies define concurrent treatment as radiation and immunotherapy within 4 weeks, while others have a much more relaxed definition. The biological argument is that radiation should occur in close proximity with the duration or starting of the systemic therapy so that we can get maximal benefit of the immune priming effect of radiation. But we need to be aware that when we sequence radiation along with targeted therapy, it's a little different than immunotherapy because targeted therapy do have some radiosensitizing potential, as we saw before. So current literature increasingly supports the idea that concurrent or near concurrent radiation and systemic therapy produces better response than separating them out. Probably this is because of the biological synergy between the treatments and also patient selection. Patients who are well enough to receive both radiation and systemic therapy are often good performance status, are able to tolerate treatment. So there's definitely a bias there. But when we look at the meta-analysis and what's been published in literature, we see that there's little more than just selection bias. There could be a potential underlying biological rationale for combining both treatments and using them in a much more concurrent or a treat, or in a way where we get like the hangover effect from radiation going into the immunotherapy or the systemic therapy realm. So the other place where targeted therapy has been shown to be extremely helpful is in cytoreduction. So patients with BRAF V600 mutation, we see that dual inhibitors can produce a very high response rate. The problem is they have very good response rate initially, but the median progression-free survival is not great. It's relatively short. So the tumor quickly develops resistance. So how I see it is that the BRAF-MEK treatment is usually a powerful rapid response tool, but it's not always good to have a durable response. So patients with symptomatic bulky disease or need for an urgent response, targeted therapy can be very helpful, but we should still consider how and when we consolidate that effect with radiation. So in general, for immunotherapy, we usually do not recommend holding concurrent radiation and like immunotherapy together, but with targeted therapy, we usually need some washout period so that you do not have a lot of radiosensitizing effect and side effects. The other question that we usually face in clinic is differentiating pseudoprogression, radionecrosis, and actually true progression. With patients living longer after SRS and immunotherapy, this becomes an increasingly different conversation we have in clinics. So sometimes after SRS, whatever changes we see on MRI is actually not tumor progression. It could be pseudoprogression or radionecrosis. So we have to be aware that this is real and the context matters. Timing, symptoms, steroid requirement, the dose that the lesion received. Did the patient have re-radiation, and what are the growth kinetics of the tumor? And when conventional MRI is usually unclear, we resort to modern perfusion MRI sequences and FET-PET, which helps us in differentiating radionecrosis and actual tumor progression. So as we saw, this is a very modern and how I would put it is more of an area where multidisciplinary discussion and we need a lot of heads and ideas to be bounced off each other in treating these patients. So if we see a couple of new interesting trials that are going on right now is looking at whether upfront SRS should be added with combination immunotherapy treatment with patients with brain mets, and the other one is probably should we use SBRT for less than 5 extracranial disease along with immunotherapy to see if we get a more sustained response. So this, in summary, my conclusion would be SBRT 8 greater times 3 probably very good for priming the immune system, and patient selection is important. You could start patients with upfront systemic therapy and watch and then consolidate with radiation, or you could use a combination of both. We have to be aware that when we use radiation with targeted therapy, we need to give adequate washout time to prevent late side effects. And radiation has come a long way from being used for just palliation and salvage to a much more precision ablation treatment as of date. So radiation is more like a partner with systemic therapy and does not compete with that. And the question that needs to be asked is, how efficiently can we use radiation with current day systemic treatments? Thank you.
So sorry, we had a small technical issue. Um, but I'd like to say thank you to Dr. Johnny for that excellent presentation. Our next speaker is Arkadiusz Dudek from the Division of Medical Oncology at Mayo Clinic. And today he will be speaking on brain and leptomeningeal metastases in melanoma. Please go ahead.
And thank you for joining me. I am a medical oncologist in Mayo Clinic, Rochester. Today I will discuss brain and leptomeningeal metastasis in melanoma. I do not have any conflict of interest to declare. Our goal today is to review the epidemiology, biology, and genomics of CNS melanoma metastasis, and then translate that knowledge into practical diagnosis and treatment strategies for metastasis to brain and meninges. This is a major clinical problem. About 30 to 40% of patients with stage 4 melanoma already have brain metastasis diagnosis, and by the time of death, up to 80% will have CNS involvement. Brain metastasis directly cause death in 60 to 70% of melanoma patients. In addition, 10 or 15% of patients with advanced melanoma develop leptomeningeal disease. Importantly, incidence is rising because patients are living longer and imaging is improving. Melanoma has special affinity for the brain. Melanocytes share neuroclast origins with CNS cells, which may partly explain this neurotropism. Melanoma cells can cross the blood-brain barrier hematogenously, and once in the brain, they adapt to a tumor-permissive microenvironment. Prognosis depends on factors such as number and location of lesions, extracranial disease burden, LDH level, ECOG performance status, and BRAF mutation status. Melanoma brain metastases also appear biologic distinct from systemic melanoma. In Mayo Clinic data, they showed reduced tumor suppressor loss but markedly higher TERT promoter mutations, suggestive a unique intracranial phenotype. The median tumor mutation burden was 11.5 mutations per megabase. The diagnostic workup starts with a contrast-enhanced brain MRI, ideally with thin slices of 3 millimeters or less. We also need extracranial staging with CT or PET-CT scan neurologic assessment when patients are symptomatic, laboratory markers such as LDH. Treatment has changed dramatically. Historically, whole brain radiation gave median overall survival of only 3 months, and chemotherapy rates were around 5%. In the modern era, immune checkpoint inhibitors achieve response rates near 55%. BRAF and MEK inhibitors produce intracranial response rates around 58%, and combined, ipilimumab plus nivolumab has delivered 3 years overall survival of 71.9% in asymptomatic patients. Checkmate 204 established nivolumab plus ipilimumab as a landmark regimen in melanoma brain metastasis. In asymptomatic patients, intracranial response rate was 54%, and 3-year overall survival was 71.9%. Outcomes were much worse in symptomatic patients receiving steroids. The clinical message is clear. Whenever possible, eliminate or minimize steroids before starting combination immunotherapy. For patients with BRAF V600 mutant brain metastasis, dabrafenib plus trametinib is an important option. It is especially useful when disease is rapidly progressing, when patients are symptomatic, or when a rapid intracranial response is needed. It can also serve as a bridge while steroids are being tapered. Local therapy remains central in management. Stereotactic radiosurgery is safe, effective, and a mainstay of treatment. Retrospective data suggests the best outcomes occur when surgery or stereotactic radiation therapy is integrated with immunotherapy. Concurrent SRS and immune checkpoint blockade appears to improve regional intracranial control. Surgery is most useful for solitary or oligometastatic lesions, especially when there is a mass effect or a need for tissue diagnosis. Whole brain radiation still has a role in multiple symptomatic lesions, not suitable for SRS, but cognitive toxicity is a limitation. Preventive sequencing strategies, such as in second bit, may also delay brain metastasis development. Management must be interdisciplinary. This patient should be discussed in tumor boards with dermatology, oncology, neurosurgery, radiation oncology, and neuro-oncology. Treatment depends on whether disease is brain only, accompanied by extracranial metastasis, or asymptomatic and multiple or symptomatic with leptomeningeal disease. Leptomeningeal disease is the most devastating CNS complication of melanoma. It involves malignant spread into the pia and arachnoid with dissemination throughout the cerebrospinal fluid. Melanoma can reach this space through hematogenous spread, direct extension, perineural invasion, or retrograde venous and lymphatic routes. The CSF niche then becomes highly immunosuppressive. Diagnosis of leptomeningeal disease is challenging. Patients may present with headache, nausea, seizures, cranial neuropathies, gait instability, or cognitive changes. In the Mayo cohort, CSF cytology was performed in only about one-third of patients and was positive only in 9.1%. All had MRI confirmed diagnosis, showing that in practice, diagnosis often relies mainly on imaging plus the clinical judgment. The Mayo Clinic leptomeningeal disease cohort included 44 patients treated between 2018 and 2025. Most had cutaneous melanoma and heavily pretreated late-stage disease. Leptomeningeal disease usually appeared as a late progression event, often shortly after earlier CNS involvement, emphasizing how aggressive this stage of disease is. Outcomes remain poor. Median overall survival from LMD diagnosis was only 2.96 months. Most patients did receive treatment, including radiation, systemic therapy, or both, but prognosis was still dismal. This highlights the urgent need for better approaches. The strongest predictor of survival in leptomeningeal disease is performance status. Patients with ECOG performance status 2 to 4 had about double the risk of death. Importantly, receiving any treatment was associated with improved survival, even in this poor prognosis population. Systemic therapy for LMD is difficult because most drugs penetrate the CSF poorly, and patients are often heavily pretreated. Still, immune checkpoint inhibitors have shown activity, including pembrolizumab with a 35% response rate in leptomeningeal carcinomatosis. BRAF and MEK inhibitors can also help in BRAF V600 mutant disease, although responses are usually modest and short-lived. Intrathecal therapy is one of the most exciting emerging strategies because it bypasses the blood-brain barrier and delivers treatment directly into the CSF. Intrathecal nivolumab given with intravenous nivolumab has shown feasibility, safety, and early activity, making this a particularly promising direction for melanoma leptomeningeal disease treatment. Radiation therapy in leptomeningeal disease is mainly palliative. Whole brain radiation can relieve neurologic symptoms, but has not clearly improved overall survival, and cognitive toxicity remains a concern. Spinal radiation may help focal symptoms, and proton craniospinal radiation is now being studied as a broader CNS-directed strategy. A number of clinical trials are exploring better CNS-directed therapies. These include combination of encorafenib, binimetinib, and nivolumab, brain-penetrant targeted agents, E6201-based regimens, proton craniospinal radiation, and intraventricular rhenium-186 nanoliposome. These studies are essential because CNS melanoma has historically been underrepresented in trials. To summarize, the practical picture of melanoma brain metastasis, they occur in up to 40 to 60% of advanced melanoma patients, often as multiple lesions. MRI with contrast is the diagnostic gold standard. Treatment includes surgery for selected accessible lesions, stereotactic radiosurgery for limited disease, whole brain radiation when CRS is not feasible, and most importantly, systemic therapy as the cornerstone of modern management. Early detection and multidisciplinary care improve outcomes and quality of life. The key messages for melanoma brain metastasis are these. They are common, lethal, and biologically distinct. Combination ipilimumab and plus nivolumab is the standard of care for asymptomatic disease, while BRAF and MEK inhibitors are preferred when BRAF V600 mutant disease is symptomatic or rapidly progressive. Steroid minimization and coordinated interdisciplinary decision-making are critical. For leptomeningeal disease, prognosis remains extremely poor, with median survival of about 3 months. MRI is currently the most practical diagnostic standard, while newer CSF tools are emerging. Performance status is the strongest predictor of survival. Treatment still matters, and intrathecal immunotherapy may represent the most promising next step. Above all, this population urgently needs prospective clinical trials. Thank you very much for your attention.
Let's welcome in our next speaker, Alexander Shushtari from Memorial Sloan Kettering Cancer Center. And today he will be speaking on non-UV exposed melanoma. Please.
Hi, everybody. My name's Alexander Shushtari, and it's my pleasure to talk about how to improve therapy for people with advanced melanomas that are not related to ultraviolet sun exposure. To do that, I'll outline two specific types of melanoma that are not related to sun exposure, mucosal melanoma, or melanomas that arise in the internal lining of the mouth, the anus, or the vagina or genitourinary tract. And I hope I'll convince you that there's a sort of medium efficacy model system for immunotherapy. It's not quite as sensitive as cutaneous melanoma, but it's not as resistant as the other main type that I'll talk about, which is ocular or uveal tract melanomas, which have very low TMB and need a different way to be treated immunologically. Luckily, we have made progress in both of these fields, and I hope that I'm convincing you that these are distinct from cutaneous melanomas. So first, my disclosures. I work with a number of companies that treat melanoma. So you've seen and you know that if someone with stage 4 cutaneous melanoma is seen, PD-1 based therapy can work and can cure people, particularly at an inflection point around 4 years. So this is the curve from Checkmate 067 that I think you've seen quite a bit. And newer checkpoint agent, relatlimab or anti-LAG3, is similarly showing efficacy. Now, unfortunately, this has largely been shown in the genetic background of cutaneous or unknown primary. Those are when the melanomas regress from where they start. And in Northern Europe, ancestry folks, usually these are regressed cutaneous primaries. So when we looked at this a few years ago, I'm showing a so-called OncoPrint here, where each patient's sequenced tumor is a vertical bar, and this is showing several hundred of these sequenced tumors, and coming up with a classification system for a MAP kinase driver, where you have BRAF V600Es on the left. There's general other classes, things like NF1, NRAS Q61. And on the top, you see these little skyscraper-looking things. That's the tumor mutational burden. That can vary, but the median is about 17 mutations per megabase. And so you know that a large part of the efficacy of immune checkpoint blockade is thought to be related to tumor mutational burden. Now, mucosal and uveal melanomas are distinct. They're not UV exposed. And I would argue they should not be treated the exact same as cutaneous melanomas. And that's because they're genetically distinct. And so here's another look. This is an earlier cohort also of MSK-CC sequenced cutaneous tumors. Again, showing just now a simpler subset of MAP kinase drivers in each row: BRAF, NRAS, NF1 KIT, GNAQ, and GNA11. And here you can see, just looking at the missense mutations in blue, nonsense mutations in black, you see a lot of non-synonymous variants, a lot of green and black here. So acral melanomas, which are melanomas that are in the palms and soles of the feet or on the nail beds, they have fewer sort of canonical drivers. And you see a little bit more blue and red here, and those are amplifications in red and deletions in blue. The overall shape of the driver curve is about the same. You see, BRAF and NRAS, a little bit NF1. In mucosal melanomas, you see a smaller mutational burden. scale isn't visible there, but the median mutational burden is about 6 instead of around 17 with cutaneous. And you see a lot more blues and reds, particularly with NF1 and KIT, and then you notice that a lot of them have so-called undefined or unknown drivers. I won't talk about that in too much detail. Turns out you can find some of these unique drivers if you have a broader panel, but I hope I'm convincing you that the overall type of MAP kinase driver is a little bit different. And you look at this and say, well, why are we even showing GNAQ and GNA11? That's very, very rare. And it turns out that's because they're the dominant drivers of the MAP kinase pathway and other pathways like protein kinase C and other things that don't just feed into ERK in uveal or ocular melanomas. And uveal melanomas never have BRAF mutations. There's some rare iris melanomas that have BRAF mutations, but those generally don't metastasize. And metastatic uveal melanoma never has a BRAF or KIT mutation. Here also just to show that the TMB is very low. It's about 2 or 3 mutations per megabase. There's an outlier of someone with a DNA damage repair pathway, germline alteration, but that's very much the exception. So let's talk a bit more about mucosal melanomas and what makes them unique. It's not just their genetic background, but it's because they arise in these really sensitive anatomic areas, it's not easy to remove them. So I'm portraying a nasal mucosal melanoma here. In contrast to cutaneous melanoma, a surgeon going in and having a gross total resection really is life-changing for the patient, very morbid. They generally have a worse prognosis, so a localized cutaneous melanoma does better than a localized mucosal melanoma. Here I'm showing an old cohort of a subset of mucosal melanomas and saying even when you don't have metastases, over half of these patients die of their disease. And that's obviously very different from stage 1 cutaneous melanomas. And I talked about the lack of BRAF alteration. So if immunotherapy doesn't work in mucosal, we don't really have very common backup plans. So we've made some progress, but just not as much as in cutaneous melanoma. And so, they can metastasize just like cutaneous. They can go to the liver and the lungs and the bone and the brain. And, how do we treat these folks? Well, we looked a number of years ago now, we looked at the Checkmate 067 trial. I'm re-showing the 5-year outcomes on the right in the whole cohort, the intent to treat cohort. And the intent is not to memorize these stats, but to say on the left, this is the smaller mucosal subset of about 79 patients. And you can kind of see that everybody does a little bit worse. But Ipi-Nivo in red did better than either single agent. And so for a number of years, and even to this day, a vast majority of people will argue that you absolutely need to treat mucosal melanoma with combined checkpoint blockade with Ipi-3-Nivo-1. Now, it turns out it's probably not that straightforward. And in a large retrospective of about 550 people treated around the world. Now, it's retrospective, but it's quite a bit bigger than the prospective trial subset I showed you. There really wasn't a difference between PD-1 CTLA-4 combination in PFS and OS compared to PD-1 monotherapy. Those curves are pretty much interchangeable. And I think it's a sobering reminder that CTLA-4 blockade is a little less effective than we expected. So we need to do a bit better. And thankfully, our colleagues in Beijing, Jun Guo and his group there, have done a number of really innovative and boundary sort of pushing studies in mucosal melanoma. I'm just showing one of the first studies that are important for our modern therapeutic era. And this was adding the VEGFR inhibitor axitinib to PD-1 blockade. And this was in a frontline trial. except for a couple of the orange bars that were previously treated. So you can ignore those orange bars and say, well, of the 29 treatment-naive patients, they had a response rate of almost 50%. Now, for a little while, we were all wondering, is that because there's something genetically distinct about mucosal melanomas arising in East Asians? They're a little bit more common in people of East Asian ancestry, relatively speaking, compared to cutaneous melanoma. So we launched a single center study of axitinib with nivolumab in mucosal melanoma in a US population, and it was 20 evaluable patients, and we had a subset of East Asian ancestry patients, but the majority were so-called Caucasian or white patients. And here you see that we recapitulated the same efficacy. We had 5 CRs and 9 out of 20 responded, showing us that there is indeed some signal here for VEGF receptor blockade. And, just to show a couple of nice examples, again, local mucosal melanomas can be very burdensome. And you'd say, well, why don't you just remove this anal tumor on the left? And the answer is, number one, you'd get a permanent colostomy, which is burdensome for the patient. You'd do it if it were curative, but historically, 90% of them recur distantly, and that feature is not curative. So it's really nice to have a durable, ongoing response to PD-1 VEGFR. Now, it doesn't always work, and I think that tells us that the VEGFR, more TKI type response, is sometimes a transient one. So here, this is a sinonasal tumor that has a really quick response, but then is rapidly growing. And in fact, this patient also had checkpoint toxicity, unfortunately. And then, of course, it doesn't always work. We have someone with rectal melanoma where their initial scan shows growth both in the rectum and in a liver metastasis. But I think it goes to show us that, VEGFR is not something that we're looking at in cutaneous melanoma right now. It's FDA approved and widely available around the world. For things like renal cell carcinoma, for endometrial carcinoma. And in the melanoma community, there's increasing understanding that you can't just say with a broad brush, all melanomas are the same, VEGFR either works or doesn't. I would argue that the PD-1 backbone is still essential, but VEGFR blockade has enough promise that we should really be looking at doing specific global trials in mucosal melanoma that have East Asians, that have Caucasians, that have people of color, to really define which one is the best frontline approach. The other concept, which I think you'll be hearing about neoadjuvant, is, again, for this person, localized mucosal melanoma can still be very burdensome. This person ended up having a fatal local recurrence. And I would argue that even if you can do surgery, you should be thinking of using some form of medical treatment in the neoadjuvant setting. So I won't go too much into that. We are trying to investigate PD-1 with or without cabozantinib in the adjuvant setting in a large national trial in the United States. Our colleagues in China are well ahead of us in many ways, sort of studying PD-1 VEGFR versus PD-1 blockade. So now on to uveal melanoma. This is just a schematic of fundoscopy looking at the eye. I got this online from the University of Michigan website showing a pigmented lesion in the choroid, which is underneath the retina and often disrupts vision as their initial sign of a tumor being present. And uveal melanoma, interestingly, when they looked back historically, was one of the few diseases in the United States where you didn't do better if you were wealthy. And there's something egalitarian about that, but unfortunately, it's because really there were few effective therapies up until recently. So nivolumab plus ipilimumab, there were a couple of frontline trials published showing really a quite poor initial response rate and overall survival compared to checkpoint blockade. And again, this is because the TMB is a lot smaller. There isn't as much of a exhausted CD8 immune environment waiting to be disinhibited by checkpoint blockade. So in steps, a different way to manipulate the immune system turns out, and this was the initial presentation, there's since been updates from this trial comparing a HLA-specific T-cell receptor product against the investigator's choice, which is pembrolizumab, ipilimumab, or dacarbazine. And so tebentafusp is a first-in-class, really exciting idea, which is similar to a bispecific antibody, except on one end, it's not. On one end, it's a CD3, sort of antibody fragment latching onto CD3. On the other end is a very sort of sticky engineered T-cell receptor for GP100, this protein on the surface of melanocytes, and thankfully highly expressed on the surface of uveal melanoma cells. And because of this T-cell receptor kind of stickiness, it has to be only for a specific HLA type because they're all distinct molecularly. And so they picked the single most common one in worldwide, actually, but especially among Caucasians, called HLA-0201, which is about 40% of people. And they showed that this is the 3-year data that were published in the New England Journal a few years ago. The 5-year data were recently presented at the AACR meeting a month ago, showing a sustained overall survival benefit. The hazard ratio of reduction is about 33% reduction in the risk of death. Now, unfortunately, the plateau is not as good as we would like to see. We would hope to see something much better than this. But again, showing that we are already making progress. Remember, this is over pembrolizumab and ipilimumab. So things that were standard just 10 years ago are already being surpassed. Now, it turns out that it won't always matter where you are in your access to care, because as something starts to work, you realize, hey, it might work better when you get smaller tumors rather than larger tumors. And I think that's a great thing. It encourages surveillance. I think it pierces the nihilism that sometimes was present in ophthalmology clinics and in medical oncology clinics for people with this disease. Oh, there's nothing to do about it. It either comes back or you're cured, nothing in between. Now we say, look, we have some treatments that are available for you. But it also means that people who don't have access to care won't live as long. And I think we have to work hard to maintain that access to care for all of our patients. And of course, HLA allele prevalence, which I'm showing in a map here that's color-coded, is not evenly distributed across the globe. That's just the way it is. In northern Central Europe, it's quite frequent in orange, but in South Asia, East Asia, in certain places in Africa, it's certainly not at all as common. Now, there's a targeted therapy approach, stepping away from immune therapy for a moment, just to end with, that is uniquely tailored to uveal melanoma. It's an exciting story that's coming out just in the last couple of years. This was a presentation at the Society of Melanoma Research by Meredith McKean and her colleagues, showing a phase 1/2 study of a protein kinase C inhibitor, called darovasertib, plus the drug crizotinib, which is not used as an ALK inhibitor here, but instead is used as a MET inhibitor, because hepatic growth factor, a lot of these liver metastases are exposed to hepatic growth factor, and the sort of ligand for that is MET. Binds to MET. So here, the combination in the first 41 patients had a response rate of about 1 in 3, which is certainly better than MEK inhibition, which had been tried in the past and had only a response rate of about 5 to 10%. And some of these responses are quite durable. The PFS was about 7 months, but there is a little bit of a tail to this curve. And coming up actually just in a few weeks at the 2026 annual ASCO meeting, there's going to be a late-breaking abstract that was announced showing that this combination had a superior PFS to ipilimumab plus nivolumab. So we expect this to be a more widely available regimen if we had to guess sometime maybe in the next year or so. And it's an exciting proof of concept that if you understand the biology of distinct types of melanoma, you can improve care for everybody. So in summary, I hope I've shown you just a couple of examples where melanoma is no longer this one-size-fits-all kind of entity. Cutaneous melanoma is still influential, of course, and we use the PD-1 backbone for many patients, and some patients still do benefit from that. But I think we can do better. I didn't show you, but in acromelanoma, there's some evidence that VEGFR blockade plus temozolomide with PD-1 can be effective. And I showed you the PD-1 with VEGFR story in mucosal melanoma. In uveal melanoma, we have this really exciting HLA-specific way to engage the immune system that is influential across oncology. Different cancers are going to be using that approach as well. And we have a targeted therapy approach of PKC plus MET inhibition that's improving care, we think, very soon for these patients. So with that, I want to thank everybody and numerous colleagues and sources of funding. I appreciate your attention, and I hope to engage with you soon if you're interested in this field.
Thank you so much, Dr. Alexander. Let's welcome in our next speaker, Dr. Douglas Johnson from Vanderbilt University Medical Center, and he will be speaking on related adverse events. Please go ahead.
Thank you to the organizers for the opportunity to speak today about immune-related adverse events. My name is Doug Johnson. I lead the melanoma program at Vanderbilt University Medical Center in Nashville, Tennessee. One of my main research interests is in immune-related adverse events, so looking forward to this talk today. My goal here is to tailor this to a group of practicing oncologists and hopefully have there be something useful for you in your practice today. Here are my disclosures. So as you're all aware, immune checkpoint inhibitors work by activating immune cells against cancer, hopefully. Now, immune cells can also be activated against other tissues, and hence the reason for immune-related adverse events. These, of course, work at two different ways, where at the PD-1, PD-L1 level, they function at the level of the T cell and target cell, whether that's cancer or organ. And then anti-CTLA-4, which is used in combination with the anti-PD-1, really functions at the level of dendritic cells interacting with T cells. And essentially, these turn off the negative regulators at each of these points and activate T cells against cancer. So we'll talk a little bit about immune-related adverse events in general, and then think about important considerations for you in your daily practice. So I think it's always useful to start off with a case, and this is one that got me really interested in this field in general. This was a 63-year-old woman with fairly disseminated metastatic melanoma that was treated at our center. She received a single dose of ipilimumab and nivolumab at the sort of standard melanoma dose, and then within a couple of weeks, 12 days into treatment, had some relatively non-specific symptoms, shortness of breath, pleuritic chest pain, a little bit of a cough for a couple of days, and came into the emergency room. And her labs were overall unremarkable, except for a few glaring exceptions where you could see her CK-MB and her CK were quite elevated, and her troponin levels were also substantially elevated. That's about 40 times the upper limit of normal for the assay at the time. So clearly something going on in the heart and or muscle. And this was her initial EKG finding, which many of you may not be cardiologists, but if you sort of squint and look closely, you can potentially see that these P waves are essentially divorced from the QRS complexes. And this is something, as you well know, is complete heart block or third-degree heart block. And actually, the patient's initial EKG, even before this, showed a first-degree heart block, followed closely by a second-degree heart block, followed by this EKG. Followed by, unfortunately, this EKG, which is a sine wave EKG consistent with ventricular tachycardia, and really that's not compatible with life and stable hemodynamics. And this is the patient's overall clinical course, where you can see she was admitted early in her treatment course. It took a little bit of time. This was back in 2015 to understand what was going on, but the patient was relatively promptly started on steroids. But despite that, the troponin levels continued to get worse, the arrhythmias continued to get worse, and the patient unfortunately passed away about 5 days into her hospital stay. So this was a case of immune checkpoint inhibitor myocarditis. In fact, we had another very similar case that we wrote up together with the first one that presented within a few weeks of each other, that essentially had very similar features: progressive arrhythmias, heart block, ventricular arrhythmias. Interestingly enough, they both had preserved ejection fractions. They both had skeletal muscle involvement as well, with myositis. They both were within the first dose of immunotherapy, and then both patients died, and we subsequently found this condition has a very high fatality rate. When we did an autopsy, we found that the heart muscle was absolutely shot through and infiltrated with CD8 positive T cells. These are cytotoxic T cells, as well as CD68 positive macrophages. So basically, just immune, particularly cytotoxic T cells and myeloid cells infiltrating the heart. And interestingly enough, you may have to trust me here, but if you look, and we did a very thorough autopsy in these situations, and actually found this is a slice from the patient's esophagus, where you can see the smooth muscle here in the black arrow essentially has no T cell infiltration, but in the green area, the skeletal muscle is completely obliterated with necrosis and with immune cells. And so this is a very specific process where, again, similar to the smooth muscle, we didn't see any infiltration in essentially any other organ. But with the striated muscle, the skeletal and cardiac muscle, there was an absolutely intense immune response that was resulting in the patient's symptoms and unfortunately death as well. So what are IRAEs? How often do they occur? Again, this is most likely familiar ground to many of you. Essentially, the way I think about it is they tend to occur most commonly in organs that are predisposed to autoimmunity, so thyroid, joints, or organs with significant environmental interface, so colon, skin, lungs. But of course, there's also a whole host of less common toxicities where you can see brain inflammation, eye inflammation, heart inflammation, kidney, nerves, you name it. Almost every organ system can become inflamed. How often do they happen? Well, certainly they increase with combination immunotherapy. This is data from phase 3 Checkmate 067 study looking at nivolumab and ipilimumab or nivolumab alone in metastatic melanoma. And what you can see is high-grade toxicities happen about half the time with nivo and ipi, and about somewhere in the range of 10 to 20% with nivo alone. And you can also see the rate of treatment discontinuation there. So why do they happen? Well, the sort of simple answer that you can think about is that, of course, they remove brakes on the immune system. They sort of turn up the immune tone, and immune-related adverse events can happen in that context. The less simple answer, and probably more accurate one, is that we really don't know, because as many of you have experienced as well, patients can go through their entire treatment, including with combination immunotherapy, and have only very mild or no side effects at all, whereas other patients have multiple organs involved or really severe side effects. So there's a few different potential mechanisms. It may be that patients have smoldering autoimmunity before they start treatment. Maybe there's some sort of cross-reactivity with tumor antigens with similar proteins that are expressed in our own healthy tissues. But the bottom line is it's really impossible at this point to predict ahead of time which patients are going to experience toxicities, whether severe or not. When do they happen? Well, there's, as you probably know, there's some general patterns. You can see some toxicities a bit earlier, like some of the skin and colon toxicities, whereas maybe a little bit later include lung, liver, pituitary events, kidney events. But it's a little bit of a crapshoot. You really don't have a great, very specific set of timing that you can hang your hat on. So essentially, it's any toxicity can occur at more or less any time. And then, of course, the converse to that is many patients go through their entire course, especially if you're treated with monotherapy, and have essentially no side effects. So very different from something like chemotherapy, where you have sort of predictable side effects that happen at predictable times. With checkpoint inhibitors, you can have absolutely no side effects, but you can also have any side effect at any time. How are they treated? Again, it's not terribly complicated, at least in terms of superficially. For grade 1 toxicities, we tend to just monitor the patients, and if it's a hormone deficiency like hypothyroidism, we replace that and usually continue therapy. For more significant side effects, for higher grade toxicities, we tend to hold treatment, of course, but that's really not enough because of the long half-life of these drugs and long pharmacodynamic effects as well. And so we have to use something active to decrease the inflammation. And so generally that tends to be steroids at a dose of 1 milligram per kilogram or thereabouts, or sometimes higher doses if it's more severe. And then patients potentially could be resumed later on. And then if the patients are refractory to steroids, they can receive something specific to their toxicity. So at least our algorithm here is to use something like infliximab if the patient has steroid refractory or steroid dependent colitis, something like mycophenolate for hepatitis. These things are rapidly, I think, evolving and changing. And then, sorry, this is probably behind my, depending on how the recording sets, it's maybe behind my head, but this should be noted. This is not really evidence-based. This is not based on large clinical trials. This is more based on sort of expert opinion standard practice. So why is it important? Well, we talked about that it can lead to treatment discontinuation, which is important. It can lead to fatal events, is the case that I showed you. We had published this in JAMA Oncology. Really, myocarditis is the one that has the highest fatality rate, although pneumonitis is probably the one that causes the most overall fatalities. And these fatal events tend to happen very early, so that's certainly very clinically relevant. The good news is they don't happen very often. So with anti-PD-1 alone, it's only about 1 out of 300 patients. With combination checkpoint inhibitors, it's maybe as high as 1 out of 80. And then there's also chronic toxicities. I won't spend much time on this, but we had found that up to 40 patients treated with adjuvant therapy had toxicities that lasted at least 3 months after therapy. And this can certainly be the endocrinopathies, which is the most common, but we also see a broad smattering of other toxicities like arthritis and skin toxicities, neurotoxicities that can be quite persistent. So let's get into some important considerations for you in your practice and some things to think about. All right, so first would be monitoring. So, how do you monitor for toxicities? As we mentioned, there's really not a great predictive marker to either a test or a clinical factor that could predict which patients are going to have toxicities. So, one, of course, early detection is very important. Patient education is very important to make sure that they know that if they do have significant diarrhea, they need to call in. They don't need to sit at home and just manage it. These are my labs that I tend to check with every cycle, usually a CBC, CMP, and a TSH. It's hard to actually know whether the CBC is all that useful, but certainly CMP and TSH. And then other labs you can think about, I tend to get for patients on ipilimumab and nivolumab, include troponin, CK, and a random cortisol. And I do that just because the rate of those toxicities is high enough with ipi-nivo that I feel like I'm getting something out of that, especially the cortisol. Something like 10+% of patients will get hypophysitis on ipi-nivo, especially the melanoma dose of ipilimumab, the 3 milligrams per kilogram. So I think that's worthwhile getting. And of course, patients often have fatigue, and so it's just very common for me that I feel like I need it if I don't have it. So I tend to get a random cortisol as well as the TSH for these patients. Again, single agent PD-1. It probably can be just obtained as an as-needed basis, although, practice may vary. Second consideration, it's when do you stop treatment for toxicity? Certainly by looking at the guidelines, generally speaking, if somebody has a grade 3 or 4 toxicity, at least you want to pause the treatment. Sometimes patients with more significant bothersome grade 2 toxicities can be a consideration. There's guidelines. I think the SITC, NCCN, and ASCO, as well as ESMO guidelines, can kind of have nice flow sheets in terms of when to think about stopping therapy, and I think that's important to look at. It's also important to note when not to stop. So certainly the endocrinopathies, even type 1 diabetes, which is rare but serious when it happens, you really can kind of keep treating. And then, of course, if it makes sense, if the patient has infections or other issues that are not related to the checkpoint inhibitor, or maybe even related to some other therapy that you're giving them, like a TKI or chemotherapy, that is not necessarily an indication to stop immune checkpoint inhibitors. This can be nuanced, as I'll go into in a few other slides, that sometimes these patients are having sort of chronic low-grade events, and it's quite bothersome to patients. But so that can be a complicated scenario. Another big question that comes up is rechallenge. So if a patient has a toxicity, maybe it's even a grade 3 toxicity, do you rechallenge the patient? Do you keep going with immune checkpoint inhibitors? Do you, once the patient tapers their steroids, do you restart them then? Or if, maybe the patient stops altogether, but they have a recurrence of their disease and you want to think about reusing treatment. Well, I've got a picture of a coin flipping there, which basically is kind of the potential outcomes when patients are rechallenged. The literature generally shows a 40 to 50% rate of recurrent toxicities when the patient is rechallenged, and so it is very possible that the patient will have a recurrent toxicity. So what would maybe push you towards thinking about rechallenge? So I think the first question is, should you rechallenge the patient? Do you need to from an oncologic standpoint? Clearly if a patient is rapidly progressing on a treatment, maybe it doesn't make sense to rechallenge them. If a patient has for example, with melanoma, they've had a complete response and they're a year and a half into treatment, do they really need to continue therapy, or can they just go ahead and stop and you just monitor them from there? So I think that's the first question to ask is, do they really need to be rechallenged? But if you think, yes, they probably do need to be rechallenged ideally, some things that might make you think, yeah, let's go ahead, would include things like a relatively mild toxicity. If the patient responded very quickly and very well to steroids, that would make you think, well, hopefully if they flare again, they would have a similar situation. If the patient clearly was benefiting from checkpoint inhibitors, so if they had acquired resistance where they initially responded, took a break from treatment, and now they're progressing. One thing that comes up not infrequently is unclear attribution. So if you're not actually sure it was a toxicity, maybe the patient had elevated LFTs, and you weren't 100% sure if it was that versus something else. And then, probably there's not exactly great data for this, but if it's been a long time, the patient benefited from treatment 2 or 3 years ago, now they need therapy again, it's probably lower risk to rechallenge them after a long duration if their immune system has sort of quote unquote reset. I don't have clear data for that, but that's certainly been my general experience. And then, of course, the converse would make you think twice about rechallenging, which would include, very severe life-threatening toxicity, the toxicity that was steroid refractory, that was, much more recent. None of these are necessarily absolute contraindications to retreatment, other than perhaps life-threatening myocarditis or life-threatening pneumonitis. I would be very hesitant to rechallenge those patients. Again, there may be some situations where you just say, well, there's no other options and I might have to do it, but I would certainly think very cautiously. I think one other thing to note is that de-escalation of treatment is also associated with less toxicity. We had published, if you have a severe toxicity with ipilimumab and nivolumab and you de-escalate just to nivolumab, there's only a 20% risk of recurrent toxicity. So that's certainly something to consider. It's not exactly rechallenging, it's more of a de-escalation for somebody who's been on ipi-nivo and considering switching over to single agent PD-1. I alluded to this earlier, but toxicities that are ongoing, but you don't really want to stop treatment. The patient maybe doesn't want to, maybe wants to, maybe doesn't, but it's just quite bothersome toxicities. And so these are just a few of those to think about. So if somebody has a bothersome skin toxicities, dermatology might be able to help you, but you can certainly use topical steroids. You can always go to higher potency topical steroids, antihistamines, other topicals like oatmeal baths, Aveeno, things like that. Itching without rash, this is rare, but it's actually quite bothersome to patients. If it happens, it tends to be maybe a neurogenic itch in these patients, and so oftentimes a GABA agonist can be helpful here. Pregabalin or gabapentin antihistamines may be helpful, and then there's a number of second-line options as well that dermatology can potentially help you with. Joint pain is another very common one. Arthralgias, arthritis from checkpoint inhibitors, especially in older patients. Certainly worth seeing rheumatology in some patients. I've sometimes treat patients with a DMARD or with a low-dose prednisone. That often can make it much more tolerable for patients. Ideally, I try not to make them adrenally insufficient with iatrogenically with prednisone, but occasionally have to. But sometimes patients can get away taking prednisone 5 to 10 milligrams 3 times a week, and that can really help them. And then, of course, fatigue is a tough one. I don't have a great answer. If anyone has a great answer for fatigue from checkpoint inhibitors, send me an email, because I don't really have a great answer. Of course, pre-existing autoimmunity is a big one. We see these patients all the time in our clinics. They were excluded from most trials if they have a pre-existing autoimmune disorder. And essentially, if you boil down some of the data that our group and many others have published, there's about a 1/4 to 1/2 rate of having that particular autoimmune disease flare. So rheumatoid arthritis, Crohn's, etc. They generally tend to be manageable. So, if somebody has an RA flare, you can treat them with a little bit of prednisone and they get better. Similar for inflammatory bowel disease for the most part. I would say one exception to that is myasthenia gravis. So generally speaking, you can usually proceed with immune therapy with these patients. You may need to co-manage them with their other physicians. You may need to use a DMARD or low-dose prednisone to manage, but oftentimes these patients can be treated. When do you sort of pull the trigger on a second-line option after steroids? This is my practice. I tend to not just endlessly taper steroids. So if I have a patient whose symptoms flare during the taper, I tend to go ahead straight to the second line option. If it's colitis, infliximab, or hepatitis, Cellcept, or mycophenolate. And then if they don't initially respond well, even if it's been a few days in a hospitalized patients, I tend to escalate. And then in the outpatient setting, I may give them a week, but I tend to be pretty aggressive on escalating beyond steroids. What do you do if you're not sure if it's toxicity? These can be tough cases sometimes. They can be complex, patients with lung cancer with increasing opacities, and is it pneumonitis? Is it infection? Is it disease progression? Here's a few considerations. Do you really need to sort of get do a bunch of diagnostic tests? Will it really change the management? Is this a patient that really needs to continue treatment? That may push you to do more diagnostic tests. How sick is the patient? Are you going to treat them empirically anyway? And do they have other treatment options? So there's not necessarily a one size fits all, but these can be a few principles to think about. And then I'll briefly wrap up. The other long-term impact, we do see these chronic toxicities as well as, thankfully, chronic long-term responses from checkpoint inhibitors. What we don't really know is what is the effect on the rest of the body, other pathophysiological processes that do have an immune interaction. This is something that we're still studying. So with that, I will thank you for your time, and hope everyone has a nice day. Happy to answer any questions by email, and thanks again.
Thank you so much, Dr. Johnson, for that insightful presentation. Our next speaker is James Smith from Memorial Sloan Kettering Center. Today, he will be speaking on emerging cell therapy platforms for advanced melanoma.
Hello. I'd like to thank the organizers for the opportunity to present at today's symposium. I'm Dr. James Smithy. I'm a melanoma physician at Memorial Sloan Kettering Cancer Center, and I'm excited to talk to you today about emerging cellular therapy platforms for advanced melanoma. Here are my disclosures. The approval of lifileucel in February 2024 represented a sea change in the treatment of PD-1 refractory melanoma. Lifileucel represented the first cellular therapy that was approved for any solid tumor and had real efficacy in a difficult-to-treat setting. Here, we see the extended overall survival curve from the registrational phase 2 C11401 trial. Here, among patients that were infused with lifileucel, we see that the median overall survival was 13.9 months. At the far right end of this curve, you can see the flattening of the curve and that there are patients with ongoing survival going after 4 and 5 years from cell infusion. While this represents a huge improvement in this hard-to-treat setting, there are certainly opportunities for a greater percentage of patients to respond to cell therapy and to have more patients experience this type of durable tumor control. So with that, I'd like to transition to talk about some emerging cell therapies for melanoma. To frame our discussion, I'd like to talk about two distinct classes of cell therapies, both of which are undergoing active clinical trials in melanoma. The first, and the one that lifileucel belongs to, are TIL therapies. And so these are cell therapies that are derived from the lymphocytes that are present already in the melanoma metastasis. So for both lifileucel and other investigational TIL products, a melanoma metastasis needs to either be surgically removed or biopsied to procure the lymphocytes to make the product. Most of the cells, and the ones we think are most important, are CD8, and we think that this represents a polyclonal population of T cells that is used to generate the product. So for lifileucel, there's no selection or genetic engineering. Whatever T cell clones are present in the product are the ones that are expanded and then used to treat the patient. We do not know which targets these cells are targeting, and it could be that they're targeting multiple antigens, or there could be a few dominant antigens or dominant clones that are doing the majority of the work. I think as future research goes on, this will be an important question to explore further. Most of these products, do require lymphodepleting chemotherapy, which kind of depletes the endogenous T cell repertoire and makes space for the TIL to come in. And then as of 2026, all of our TIL therapies do require stimulation either with IL-2, as in the case with lifileucel, or IL-15, as we'll talk about one of the products. These cells can have durable benefit, as we just showed on the prior curve, and we do have an FDA-approved therapy in lifileucel. Common side effects with TIL therapy are those derived from lymphodepleting chemotherapy, so fatigue, hair loss, low blood counts. IL-2 can have pretty profound inflammatory side effects as well. That's a major consideration when thinking about patients for TIL therapy. And then other side effects can be variable depending on which other cytokines might be used in investigational platforms. On the right side, we have an alternative treatment modality called TCRT. And instead of using a tumor source of these cells, these are phoresed from the peripheral blood. So this is more in line with what we see in the hematologic malignant space with CAR T, where there are several approved products. So here, patients undergo phoresis, and these cells, unlike TIL, are always going to be genetically engineered with a synthetic TCR moiety that targets a specific antigen on the melanoma cell. So TCRs are specific to both the antigen and the HLA type that presents the antigen. And the benefit of this is that you can target any intracellular antigen, but the downside is that it needs to be designed for a particular subpopulation of patients with advanced melanoma that carry a specific HLA. So today, most products have targeted patients with HLA A0201, as this is commonly presented or carried in patients with melanoma. But I think as time goes on, there's going to be a push to develop TCRTs and other HLA-specific therapies for other HLA types down the road. We do know, when we engineer a TCRT, what it's targeting. And the TCRT that's furthest along in clinical development in melanoma is Anzu-cel, or IMA203, and we'll talk quite a bit about that in the coming slides. Unfortunately, with TCRT, we can target a specific intracellular or extracellular antigen. And here, right now, patients still require lymphodepleting chemotherapy and some degree of stimulation with IL-2 for TCRT treatments, but to be seen in the future if there might be opportunities to de-escalate or eliminate some of those additional components as the cellular engineering gets more advanced. We have seen patients with TCRT develop durable benefit, and we do not yet have an FDA-approved TCRT for melanoma, but hoping that will change in the coming year to 2 years. And something with TCRT that we do not see with TIL is a specific toxicity of CRS or ICANS. So CRS, or cytokine release syndrome, ICANS is a neurotoxicity related to cells. These are commonly seen in CAR T treatments and well characterized in the heme malignancy space, something we don't typically have to think about too much with TIL, but with TCRT we see these, and we'll get into more details of the management of this in a few minutes. To kick off our discussion, I'd like to talk about OBX-115, an engineered TIL product that seeks to improve on our current understanding of how TIL work. So unlike lifileucel, which are unmodified TIL, OBX-115 is an engineered TIL that's designed to self-stimulate with acetazolamide exposure. So that once TIL are harvested, as part of the manufacturing process, they are genetically engineered with a gene cassette that includes IL-15, attached to, in red, a drug-responsive domain. So at baseline, if this is expressed and converted into protein, this drug-responsive domain automatically targets the IL-15 to the proteasome and leads to degradation. So there's kind of constitutive degradation of this IL-15 signal. However, in the presence of acetazolamide, which is a standard diuretic that's been around for decades, this drug stabilizes the drug-responsive domain, and the IL-15 is able to stay stabilized and expressed on the protein surface. So IL-15 stimulates the T cells in a way that's similar to IL-2, and this leads to both autocrine and paracrine signaling. So these IL-15 molecules that are membrane-bound can stimulate nearby T cells and lead to targeted stimulation in the presence of acetazolamide. And one benefit of this approach is that the acetazolamide can be dosed not just immediately after cell infusion, but can be redosed later on with the hope of leading to later expansion and further deepening of anti-tumor response. Here we see some of the early clinical activity of OBX-115 in melanoma. So these are data that were presented about a year ago in the phase 1 trial of OBX-115, and we see that in escalating dose levels, there are significant both partial and complete responses in patients with melanoma. So here at dose level 3, which was a cap of 100 billion cells of OBX-115 and acetazolamide 500 milligrams of these 6 patients, we see that 3 of them had partial responses in green and 1 had a complete response. So there are active ongoing trials right now to test this in larger patient populations, and I hope to see more efficacy data soon. Now, to pivot to the other class of emerging T cell products, we have Anzu-cel or IMA203, and we'll talk about this in a bit of detail. So first, to talk a bit about the target of Anzu-cel, and that is PRAME. And so PRAME is a cancer testis antigen that is highly expressed in melanoma and other solid tumors. It stands for preferentially expressed antigen in melanoma and was discovered back in the 1990s when T cells that were reactive to melanoma were first kind of studied in the lab. So PRAME has been studied extensively in melanoma tissue at MSK. One of my colleagues, Dr. Lascano, has been a leader in this effort. And she had looked at large tissue cohorts of melanoma and saw that PRAME nuclear reactivity, diffuse nuclear reactivity, was seen in 83% of primary melanomas and 84% of metastatic melanoma lesions. In contrast, looking at melanocytic nevi, which are derived from the same cell type, PRAME expression was quite low, so only 14% of nevi had diffuse nuclear staining. Here in the middle panel, you can see this pattern of PRAME expression. You see this bright brown signal in the lower panel, just shows what diffuse PRAME expression looks like. So I think across melanoma subtypes, we do see consistent high PRAME expression. One caveat is that in desmoplastic melanoma, the rates do seem to be quite a bit lower, somewhere in the 30 to 40%. So that might be one exception to types of melanoma where we see really diffuse high PRAME expression. PRAME is not a neoantigen in that it's not mutated and specific only to tumors. So there is some low-level expression in a few other normal tissues, so including testis, ovary, adrenals, and placenta, but this is considerably lower than what is seen in tumors. Beyond melanoma, we know that PRAME is expressed in a number of other tumor types as well. So this on the right-hand side is looking at mRNA expression data and looking at a number of different solid tumors. So in addition to melanoma, we see uterine carcinosarcoma, synovial sarcoma, also carrying expression rates of greater than 90% of PRAME. So I think this is an attractive target that could be relevant to many different disease types. Anzu-tresgene autoleucel is an engineered TCR-T that targets PRAME in the context of HLA-A0201. So we discussed earlier how TCR-Ts can target intracellular antigens that are expressed by the HLA complex, and this graphic on the left side just describes that in a bit more detail. So we can see that intracellular PRAME is degraded by the proteasome, can be chopped into peptides, and then loaded onto the HLA complex. And so then this gets presented on the surface of the cell. So you have your HLA machine with a PRAME antigen, and then we have the engineered PRAME-specific TCR that's targeting that complex. So Anzu-cel was discovered using normal T cells that are reactive to PRAME, and there was collection of 52 PRAME-specific TCRs generating from 20 healthy donors, and then once some candidate TCRs were identified, they then subjected that to genetic engineering to enhance the avidity and affinity for the PRAME antigen. So there are two specific amino acid changes that were made from the parental TCR, and these were both occurring somewhat distantly from the complementary determining region. So it's thought that this might help stabilize or lead to more prolonged engagement with the TCR antigen complex. And I think importantly, once this candidate or engineered TCR was identified, there's a lot of in vitro testing to make sure there wasn't a lot of off-target activity, and really there was negligible reactivity against many different types of human epithelial cells, with the exception of some very low activity in renal epithelial tissue. And fortunately, to date, there has not been a significant signal for renal toxicity with this TCR product. Okay, so in the clinic, this TCR, IMA203 or Onzucel, was tested in a first-in-human phase 1 trial across refractory PRAME-expressing solid tumors. The key objectives of this trial were tolerability and the determination of the recommended phase 2 dose. The secondary endpoints were the T-cell engraftment, persistence, and efficacy. And so to be included in this trial, patients needed to have a confirmed advanced and/or metastatic solid tumor. They had to be greater than 18 years of age, have an ECOG status of 0 or 1, and have positive PRAME status, as well as carry the HLA-A0201 allele. Patients should have received all prior standard of care treatments before going on to this trial. And here's just a schema of how patients were treated on the right-hand side. So you can see with this HLA-A0201 testing step, the prevalence of this allele is about 41% in the US, 48% in Europe, and then patients needed to have archival tissue treated for PRAME or tested for PRAME as well. All patients underwent leukapheresis, and then after about 2 weeks of production time, patients were ready to undergo lymphodepletion. All patients received fludarabine 30 mg per meter squared and cyclophosphamide 50 mg per meter squared for 4 days, day -6 to day -3. There were then 2 rest days, and patients were infused with the IMA203 product. After infusion, patients received low-dose subcutaneous IL-2, so this represents an order of magnitude less than what we see with lifileucel. Patients got 1 million international units subcutaneous daily for days 1 to 5, and then on days 6 to 10, this was increased to BID dosing. With this regimen, cytokine release syndrome was generally low grade, and ICANS and HLH were rare. So these are 3 AEs of special interest with any engineered cell product. CRS did occur in about 94% of patients. However, this was all grade 3 or less. There were no patients with grade 4 or 5 CRS, and ICANS occurred in 13% of patients, and HLH only in 2.7% of patients. Other AEs that were commonly observed were those that were largely expected, with cytopenias related to lymphodepletion, GI disorders also kind of related to both chemotherapy and general inflammation, and some lab abnormalities with liver enzymes being elevated and creatinine being elevated. There was a signal for rash in some patients, but this was not severe. Only 8% of patients had a grade 3 or higher rash. Okay, and so of the patients that were treated on the phase 1 trial, there were 33 included in the melanoma efficacy population, and this represented a pretty, I would say, representative melanoma population for those that have progressed on PD-1 therapy. The median age was 57, it was about 50% female, LDH was elevated in 58% of patients, and 100% of patients had M1b, C, or D melanoma. The median target lesion sum of diameters was 10, and 79% of patients had liver metastases. Most patients had a median number of 2 systemic therapies, and 33% of patients had prior to ventifusp, and this was because this was for HLA A0201 uveal patients were included. The median infused TCR-T dose in this population was 4 billion cells. And here are the waterfall plots, which I think are quite striking. This was presented at ASCO 2025 by Martin Wormke, and you can see in the cutaneous melanoma population, the confirmed objective response rate was 50%, with 7 of 14 patients having either a CR or PR. The disease control rate was 93%. In uveal melanoma, where it's even harder to generate, kind of long-term immune-mediated responses. We see an impressive confirmed objective response rate of 67% with 10 of 15 patients responding. In this other cohort, which was a mix of mucosal and melanoma of unknown primary, we did see 1 in 3 patients have a confirmed objective response rate. So all in all, over half of patients in this melanoma efficacy cohort had a confirmed response to IMA 203 infusion. On the next slide, you see that many of these responses appear durable with a median duration of response of over 12 months. There are some patients that have early progression, but you can follow a number of these partial responders out beyond the 12-month mark, and there are a number of patients with ongoing responses at the time of presentation. So this exciting data led to the opening of a randomized phase 3 trial, which is currently underway in both the US and Europe for cutaneous melanoma and melanoma of unknown primary. There are separate efforts for uveal melanoma, which are not included in this trial. But this is, with registrational intent, 360 patients with PD-1 refractory melanoma, cutaneous or unknown primary, randomized 1-to-1 to IMA 203 or investigator's choice. So I think promising in the investigator's choice arm is that lifileucel or another cell therapy is included as an option. So this will be one of the first randomized trials to compare two cell therapies against each other. While active brain mets are not eligible at the outset, or patients with active brain mets are not eligible, patients that develop brain metastases during production of IMA 203 are eligible to be included in a separate exploratory cohort. So there has been some anecdotal efficacy in the brain, and I think this will be really important as this is a common clinical scenario that's run into during the development of cell therapies, and it'll be great to get some preliminary data for that population as well. The key endpoint of this trial, the primary endpoint, is going to be progression-free survival, with a key secondary endpoint of overall survival. Other secondary endpoints include safety, objective response rate, and patient-reported outcomes. And then on the lower right here, you see a full list of the investigator's choice options. In addition to lifileucel, patients can be treated with nivolumab, relatlimab, anti-PD-1 monotherapy, ipilimumab monotherapy, or cytotoxic chemotherapy. And then lastly, we're thinking of ways that we can potentially improve on the efficacy of IMA 203 by combining it with other treatment modalities. So IMA 203-102 is a phase 1 trial, which it builds on the backbone of the same IMA 203 treatment. So all patients receive the same lymphodepletion, cell product, and low-dose IL-2. But then after that, patients are boosted with a mRNA vaccine that encodes PRAME peptides. This is a lipid nanoparticle that's built on the Moderna platform, and patients, once they recover from their IL-2 and any CRS that they had, they're dosed with this first every 2 weeks for the first month, and then every month for an entire year. And so we're really excited to be leading this trial at Sloan. It's going to be open at 4 sites, so us, Dana-Farber, MD Anderson, and UCSF. And I think with this, we're going to be collecting a lot of really interesting correlative data to see that as vaccines are administered throughout this first year, do we get a deepening of the TCR response? Does it lead to better persistence of the cells? And then is there an opportunity to potentially activate endogenous, non-IMA 203 PRAME-directed clones to see if that could lead to more of a polyclonal response and potentially something more durable? So really excited to continue to get safety data from this, as well as some preliminary efficacy data. And I think another interesting thing about this is, in addition to metastatic melanoma, this is open to patients with synovial sarcoma as well, which is one of those other tumor types that's very highly expressing of the PRAME peptide. We're working closely with Ben Greenbaum and Santosh Vardhana at Sloan to do a lot of the TCR-seq computational analyses, and hopefully we'll be doing some single-cell RNA-seq as well to characterize the phenotypic or functional aspects of these cells over time. So just in conclusion, OBX-115 represents a first-in-class engineered TIL product and has promising initial clinical activity in PD-1 refractory melanoma. Anzu-cel is also an engineered TCR-T that has demonstrated clinical activity in multiple melanoma subtypes. And the toxicity profiles, I'd say, for both products appear tolerable compared to approved cell therapies, and larger trials are currently underway to better assess the efficacy of both of these products. Lastly, combination approaches with novel cell therapies could help lead to more durable or broader anti-tumor responses. I think this will be a big area of research in the coming years. So with that, I just want to thank you again for the invitation to speak on this topic, and hope to listen to all the other speakers on today's symposium. Thanks again.
Thank you so much. Thank you so much. Sorry for that issue. So sorry for that minor issue, but thank you, Dr. James, for that excellent presentation. Our next speaker is Zulfikar Oti from Townsville Cancer Center, and today he will be speaking on first-line therapy of metastatic melanoma. Please.
Hi, Zulfikar Oti here. So my topic is first-line therapy of metastatic melanoma. Very interesting topic for me because I treat melanoma patients every day. So over the last decade or so, treatment of metastatic melanoma has been undergone a revolution, as you know, and patients are getting benefit.
We're going on a short break, and we will be back in 5 minutes.
and thank you for joining me. I am a medical oncologist in Mayo Clinic, Rochester.
Biotech is moving fast. New breakthroughs, major clinical updates, company moves, regulatory decisions, and industry shifts are happening all the time. But keeping up with what actually matters can be difficult. That's where OncoDaily Biotech comes in. We bring you timely, relevant, and engaging biotech news in one place. From innovation in cancer care to broader developments across the biotech space, including research progress, funding news, partnerships, emerging technologies, and the stories shaping the future of medicine. Whether you're a healthcare professional, researcher, biotech leader, investor, or simply someone who wants to stay informed, OncoDaily Biotech helps you stay connected to the news that matters. Follow OncoDaily Biotech and join a growing community exploring the future of biotech one update at a time. Artificial intelligence is quietly reshaping oncology, not in theory, but in how we think, how we work, and how we decide. Across the world, researchers and clinicians are moving with it. Different places, the same moment. A pause, a realization, a decision, and then they move. On May 30 in Chicago, during the ASCO 2026 annual meeting, these paths come together. OncoDaily Grand Rounds, AI and Oncology Edition, organized by OncoDaily with ZS as exclusive partner. Become part of the AI Oncology community. Register now.
Hello. Hi, everyone. I'll be talking about management of metastatic melanoma, mainly the first-line treatment. Broadly speaking, metastatic melanoma treatment can be divided into immunotherapy and targeted treatment. As we know, nearly 50% of melanoma patients have BRAF V600E mutation. So first I will speak about managing BRAF wild-type metastatic melanoma. Majority of the treatment would be based on immunotherapy. Although there are now new experimental treatments being tried. And also treatment also depends on where the metastasis is. If it is a small amount of metastasis, or if major organs like brain or liver is involved, or how symptomatic the patient is. And also the medical comorbidities and age of the patient as well. Is the patient fit for intensive treatment? So all these factors has to be taken into account before deciding what's the best treatment for our patient. So immunotherapy, now we have about 3-4 choices. One is the PD-L1 antibody like nivolumab or pembrolizumab. And also we have combination immunotherapies with PD-L1 antibody and CTLA-4 antibodies, nivolumab and ipilimumab. Also, we have a combination of nivolumab and LAG-3 antibody relatimab. And then we have single agent ipilimumab. which was the first immunotherapy approved in metastatic melanoma. So we have all these options in treating metastatic BRAF wild type melanoma. So how do we choose what is the best for our patient? Depends on the individual patient. So in Checkmate 067, which compared ipilimumab with single-agent nivolumab and ipilimumab, was a landmark trial which showed that combination therapy has better PFS and overall survival compared to single-agent ipilimumab or nivolumab. So that became standard of care in patients who have high-risk features, like patients with high LDH or patients with brain metastasis, patients with liver metastasis, or patients with BRAF mutant melanoma, which we will be talking about shortly. So Checkmate 067 showed that 10-year overall survival. So we have data for 10-year overall survival, which is about more than 40% for if we use ipilimumab and nivolumab compared to about 37% in patients who received nivolumab and 19% who received ipilimumab. So obviously, the combination of PD-L1 antibody and CTLA-4 antibody is superior. But the problem is it has more toxicities. We all know that, doctors who have treated or used combination immunotherapies know, and these side effects are well known, and they can be really severe. Like nearly 50% of patients get grade 3 toxicities, like severe colitis, hepatitis, pneumonitis, and rarely can be even fatal. So I think patient selection is very important in this aspect. We need to make sure the patient get the best possible treatment, but also we don't want to put patients' life at risk. So, as I mentioned, if the patient has high-risk features, then definitely I would use combination of ipilimumab and nivolumab, especially if the patient is otherwise fit and healthy. But if the patient is not very fit, elderly, and not ECOG 0 or 1, then I would go for single-agent PD-L1 antibody like nivolumab or pembrolizumab. And now we have another option of combination of PD-L1 antibody and LAG3 antibody. So nivolumab and relatimab. So which is been shown to be superior to single-agent nivolumab in the Relativity 047 trial. So I think since the nivolumab relatimab combination became available, I've been using more of the combination compared to single agent because the toxicity is much less compared to ipilimumab and nivolumab. So if the patient is not fit for ipilimumab and nivolumab, the next choice would be the combination of nivo and relatimab, or otherwise known as Opdualag. The grade 3 toxicity levels are possibly around 20-25%, but most of them are manageable. So that is a good choice. But if the patient is having only minimal metastatic disease or very elderly, and we don't think patients would be able to tolerate the side effects, I would just offer single agent PD-L1 antibody, pembrolizumab or nivolumab. And we don't use ipilimumab alone as first line nowadays, as efficacy is much less and side effects are definitely more than PD-L1 antibody. So this is briefly about managing BRAF wild type metastatic melanoma. And the next is role of local therapies, like, for example, if there is symptomatic brain mets, obviously surgery has to be looked into, need neurosurgical consultation. Of a patient has smaller metastasis, stereotactic radiation is the best way to go. But I think these are all accessory treatments. And in a rare subgroup of patients with acral or mucosal melanomas, usually I would use combination of ipilimumab and nivolumab, because single agent PD-L1 antibodies are the efficacy is much lower. And then coming to patients with BRAF mutated metastatic melanoma, which accounts for about 50% of our patients. The first line is still immunotherapy, unless patient has life-threatening disease. For example, if there is severe symptomatic brain metastasis, or the patient has widespread liver mets with impending liver failure, etc., then I would use targeted agent BRAF plus MEK inhibitor. Otherwise, almost all the patients, the first line treatment would be immunotherapy, usually with a combination of ipilimumab and nivolumab. And in Checkmate 067, the 10-year overall survival for BRAF mutated melanoma was much higher than BRAF wild type melanoma. So it was more than 50%. And single agent nivolumab, it was around 35%, 10-year overall survival. So definitely it is more than 10% difference in overall survival, which is significant. And many of these patients are possibly cured and they never have recurrences. So my first choice is always a combination of ipilimumab and nivolumab, unless patient is not fit or has contraindications. Then I would go for single agent PD-L1 antibody like nivolumab or pembrolizumab. And the contraindications to immunotherapy are well known. Or if the patient has severe autoimmune diseases like ulcerative colitis or pulmonary fibrosis, etc. But I think we are learning how to manage most of the patients with mild autoimmune diseases, and we are using more and more immunotherapy in these patients with the closely monitoring for toxicity. So that is in brief about managing metastatic melanoma. Sorry, I forgot to mention about targeted treatments in BRAF mutated melanoma. So that is usually used as second line unless patient has has contraindications for immunotherapy or has impending or life-threatening illness where we need immediate responses. So BRAF targeted agents, the response is immediate, while the immunotherapy responses takes sometimes weeks. So that is one place where BRAF targeted therapy has a role. And almost always we use BRAF and MEK inhibitor combination, which is superior to single agent BRAF inhibitors. And we have now about 3 commercially available agents, dabrafenib and trametinib, or encorafenib and binimetinib, and pembrolizumab and cobimetinib. And these agents have different side effects profile. So basically, we choose agents which can cause less side effects, and but overall they all have similar efficacy, and they are now mostly used as second-line treatments for BRAF-mutated melanoma. And the other aspect what I would like to discuss is about duration of treatment for immunotherapy in metastatic melanoma. There has been no much data on duration of treatment, but because most of the landmark trials used immunotherapy until progression, or if there are significant side effects. But in practice, I think most of the oncologists stop treatment if there is complete metabolic response in PET scans, and at least for serial PET scans over 6 months if there is complete response, and after a discussion with the patient of the potential for recurrence and potential for reintroduction of immunotherapy. So we don't have definite data on exact duration of treatment. So that is in brief about managing first-line therapy of metastatic melanoma. Thank you. Sorry, I can't hear. I can't hear anything. Sorry.
It was a technical issue. Can you hear me now?
Yes.
Thank you very much, Dr. Otti, for your insightful perspectives on metastatic melanoma. Now we would like to introduce the next speaker, Professor Axel Haushild from the University Hospital Schleswig-Holstein in Kiel. Professor Haushild is a highly respected expert in melanoma research and treatment, and today he will speak on how we treat melanoma in Europe. Please welcome Professor Haushild.
Hello, everybody. I just need a confirmation that you can see my screen. Just a moment.
Yes, everything is all right. Your presentation is
all right. Fine. Can you confirm? Oops. What happened now?
Just a second. We will correct the...
I hope it was not on me.
No, it's all right.
I can't see the slides now.
We'll just take a minute to correct the issue.
Okay, that's fine. I'm not in a hurry. I'm a little bit early.
Yes. Dr. Axel, we would like to ask you, could you please unshare your screen?
Yep.
Just a moment, because I think the issue is not from here.
Yep. I can try again to share.
Yes, please, you can try again now.
So I have shared now. And now it's World Melanoma Day. Can you see it?
Yes, everything is all right. I think.
Okay, good. So I can start. So first of all, I'd like to thank you, OncoDaily in general, and Dr. Steve O'Day for the kind invitation. It's a great pleasure to talk to you on the World Melanoma Day on the question how we treat melanoma in Europe. So you need to know I'm a dermato-oncologist based on the University Hospital in Kiel in northern Germany. And, I will explain that certainly the driving force in our country is the dermato-oncologist and not the medical oncologist for treating even metastatic melanoma. So this is my disclosures. I work with a number of companies and as a consultant and as a presenter. And I need to explain in the first couple of minutes the EADO. It's our European Association of Dermato-Oncology. You all know ESMO, European Society of Medical Oncology. I'm a member of both, but I'm a board member of EADO, and I'm in guideline committees and all of this. So we are conducting scientific congresses and educational events. We are collaborating with EORTC and others for designing European guidelines on all types of skin cancer. We're doing research in skin cancer, and we have something really special which matters for the management of melanoma. We have an EADO certification in medical tumor therapy, as well as a fellowship program. So this is our current EADO board members, and I'm the treasurer of the society. The current president is Professor Joseph Malvehi from Barcelona, Spain. We have skin cancer societies which are collaborating with us, other cancer societies in a good standing, patient and foundations with collaborations, and dermatological associations. So there are several task forces for prevention and early detection of skin cancer, for instance. We have a committee for the access to treatment, which is very important because in Eastern Europe, many drugs are approved but not reimbursed because the countries have different healthcare systems. The system is relatively poor. The countries are not this wealthy compared to Western Europe, and you might have forever an approval, but never ever payment for the patients, which is very important. We have a biomarker committee and investigator-initiated trials. We are conducting scientific congresses. The last one was just 3 weeks ago in Prague, Czech Republic, and some educational events. And now I'm coming to the point. We have developed European guidelines for different skin cancers. I want to introduce you to the current guideline and the changes 2026-27, which is very nice. And apart from the guidelines on melanoma, we have basal cell, squamous cell carcinoma, dermatofibrosarcoma, protuberans, Kaposi, Merkel, actinic, and now we are having a guideline development right now for rare cancers such as atypical fibrosarcoma, dermal pleomorphic sarcoma, and so on and so on. So now I need to explain why I am speaking to you as a dermato-oncologist. We have organ-specific cancer centers in Germany, which means we have certified skin cancer centers, but also certified breast cancer centers, colorectal cancer centers, neuro-oncology centers, and so on and so on. This is what I call organ-specific. And we have 82 certified centers in Germany and Switzerland and Austria. The dermatology centers co-opted our model, and we have a couple of centers over there. And I can tell you that in most European countries, still the medical oncologists are the lead of administering systemic treatment in the adjuvant and stage 4 melanoma setting. But in these countries, 90% of the patients are treated by dermato-oncologists. But this is a tradition long time ago when I went to dermato-oncology 38 years ago already. It was already in the hands of dermato-oncologists because the medical oncologists were not really interested in this dismal disease, we need to say, which was widely neglected. The requirement includes intensive training in all kinds of medical systemic tumor therapies, and you need to show the numbers. There's a certification round, and all of this leads to a certified center. Certainly, as in the United States and elsewhere, we have a multidisciplinary collaboration and a multidisciplinary board where we discuss patients. In all of the certified skin cancer centers, the dermato-oncologist is in the lead, and that's the reason why I highlighted it in red color. But to this concert, the care in concert, All the others are contributing, in particular medical oncology, who is on board at every Monday at 4 p.m. in our center, the surgical oncologists, the radiation oncologists, ENT, maxillofacial surgery, and sometimes palliative care. So there is certainly a care in concert ongoing. So the last guideline in melanoma was updated 2024 and published in January 2025. I will show you in a second that we are already updating this guideline. I will be the new lead of the EADO guideline, again aimed to be published in European Journal of Cancer. It will be ready to go for publication early 2027. The consensus conference is in November. As for ESMO, I'm an ESMO member, an active member, committee member, and the guideline group, and the update comes out very soon. It's already ready to go. It has been submitted to Annals of Oncology, and the lead author this time is Karin Zuckerberg from Utrecht in the Netherlands. So you will see an update of the ESMO guidelines in due time. I expect to see the guideline within the next 8 weeks. So if I start with German behavior for melanoma surgery. So we are saying that a sentinel node biopsy is good for correct stage classification and treatment decision, but it's not a therapeutic intention which we have, which means the sentinel node biopsy is not improving the prognosis. It shall be offered in patients with more than 1 millimeter and or in patients with at least 0.8 millimeters with additional risk factors such as ulceration. However, there is a question mark behind it for the update because in general, the value of the sentinel node biopsy is under debate. And the question is if it can be replaced by some biomarkers, which is gene expression profiling tests. They are so far not mentioned in our guidelines. I expect to see at least a paragraph and a comment on it in the new guidelines. And this holds particularly true for patients in AGCC stage 2B and C because they can go immediately without a sentinel node biopsy by approval to the treatment with PD-1 antibodies, pembrolizumab and nivolumab in these 2 stages. So should we perform metastasectomy in oligometastatic disease? No. The systemic treatment should be first-line treatment, the treatment of choice. That I think is a very important change, which was included 2024, that surgery is no longer first-line treatment for stage 4 patients. I need to switch to neoadjuvant therapies. Neoadjuvant, I think, is a very important topic because in neoadjuvant, we have seen so many exciting data. Everybody who was at ASCO 2 years ago will remember the exciting presentation of Christian Blank on neoadjuvant ipilimumab nivolumab, followed by a complete surgical resection of the skin or lymph node metastases. And then, there was a risk-adapted follow-up with just wait and see or with some adjuvant treatment for those patients who didn't show a favorable outcome in the investigated tumor tissue. So that is now, I would say, standard of care. You will see a recommendation in the ESMO guidelines, which come very soon. I explained it already in our EADO guideline. I'm pretty sure you will see the same recommendation because the data look very good. As an alternative, we mentioned the neoadjuvant pembrolizumab followed by complete lymphadenectomy and then an adjuvant treatment for the rest of the year with pembro as another option. This is called perioperative treatment in our days, and Sapna Patel has presented the data, and this was leading to guideline changes. So in our guideline, I believe we will have a paragraph which says ipilimumab plus nivolumab or perioperative pembrolizumab, but we are not giving a clear favor for one over the other one. And now I need to explain something which is of importance for the understanding. In Europe, and in particular in Germany, you are not allowed to treat off-label. There is no approval for ipi-nivo neoadjuvant and no approval for perioperative pembrolizumab. And the prescribing doctor needs to take the risk for being judged for this malpractice if you give a prescription of an unapproved drug. Therefore, we hope very much for an approval, at least of ipilimumab and nivolumab, and the perioperative trial on another drug combination, which is currently underway. This is our hope for Europe, because otherwise, we can talk about standards of care scientifically, but if it's not reimbursed, it's not helping the patients. So we have also made an update in the guideline on intralesional Darumon, including the ESMO guideline. You will see it as an alternative, particularly in previously treated patients. This is patients who got an adjuvant systemic treatment, for instance, with PD-1 antibodies already, and intralesional Darumon applied to skin or lymph node metastasis is highly efficient. You will see an update presented by our group at ASCO in 3 weeks in Chicago, and hopefully will be simultaneously published. So therefore, Darumon is something really new. It's a fusion immunocytokine which releases highly immunostimulative agents like TNF-alpha and interferon gamma signature. And what you will see is certainly an improvement of these drugs. So it's linked IL-2 with TNF-alpha, and this is really a true innovation, but not yet approved in Europe. So if I may switch to adjuvant treatment, you all know what we are doing right now. We are performing a sentinel node biopsy. I was putting a question mark behind this, but if you turn from SL and D to the left-hand side to negative, it means there's just a clinical trial available. At the moment, there is no trial for stage 2A patients and standard follow-up. For stage 2BC, it leads to clinical trial or anti-PD-1 with Pembro or Nivo for 1 year. If it's positive, patients are upgraded to stage 3, and then we have another option. It's dabrafenib and trametinib apart from the PD-1 antibodies, and you will see the guideline change on this in a moment. So you have a BRAF-directed treatment option. You have the PD-1 antibodies, which are available for stage 3. The Daptram, once again, is only approved for stage 3 and not for stage 2, B, and C. So the recommendation is that we should discuss in patients with resected stage 2 BC, the PD-1 antibodies, and in stage 3 B to D, it is the MEK inhibitor and the BRAF inhibitor in addition. Stage 3A, we are leaving a little bit open because there is, in general, a relatively low risk for a relapse. So the recommendation is not that strong in stage 3A. What you see here is the update change. Trametinib and dabrafenib is no longer recommended for all BRAF mutated patients. It's only recommended for BRAF V600E, which is in the Western population of Caucasians, about 90% of patients, 90%, and no longer recommended for V600K patients because the COMBI-AD study showed clearly that these patients are not benefiting in terms of overall survival. But there is a statistical significant benefit of Daptram for overall survival, and that is something which matters really, and there's a clear trend to Daptram in BRAF-mutated patients over PD-1 antibodies in Europe because the tolerability is nice. We have no long-standing irreversible toxicities. Most of the sequelae are solved within weeks when you stop the treatment or you have some sort of treatment holidays or dose reductions. So Daptram in stage 3 in a BRAF mutated patients with V600E is currently our favor. That might be, by the way, different in the United States, Canada, and eventually also Australia, but I know the Australians, they like also the BRAF-directed treatment in stage 3 because it's relatively harmless compared to the PD-1 antibodies, where in 2% of the cases you see irreversible adverse events which are non-thyroid endocrinopathies, for instance, the Addison, the adrenal insufficiency, hypophysitis, or neurological or cardiac toxicities, which might be ugly from time to time. It's not the rule, but if patients are suffering from it, it's a serious disease. So I switch now from stage 3 adjuvant treatment and the neoadjuvant treatment, which is applied if possible, and I explained the limitations already, to a systemic treatment in irreversible stage 3 and stage 4. So this trial, everybody knows who is dealing with melanoma patients. It's a landmark trial called Checkmate 067, which was bringing us ipilimumab and nivolumab as a combinational immune checkpoint inhibitor therapy to the market and to our patients at the end of the day. And you see the 10-year estimate for melanoma-specific survival, which is the best 10-year data we have ever seen. And I would say now here on the Melanoma World Melanoma Day 2026, it will be very, very hard in a randomized phase 3 trial to show superior results to these 10-year melanoma-specific data. 52% for ipilimumab, nivolumab, 8% lower, which is still a good result for nivolumab. Pembrolizumab was not included here, but showed more or less the same results. And for ipilimumab is significantly lower. That leads to treatment recommendations, which are crystal clear. Ipilimumab is not recommended for first-line treatment of stage 4 melanoma, whereas the PD-1 antibodies, nivolumab and pembrolizumab, and in particular, the combination is recommended. However, in Europe, we have a hard time to say that ipilimumab, nivolumab should be first-line treatment for everyone compared to PD-1 antibodies alone, because it's going along with more toxicity. And now we are coming to an important point. Statistically significant was just the relapse-free survival of nivo and ipi over nivo. However, we are missing the statistical significance for nivo, ipi versus nivo. It's very tough. There's a clear trend towards a better OS of ipi nivo, but it's not statistically significant, even not after 10 years. And now, you may argue in the United States and Canada in particular, but in very many other countries, why not use flip-dose ipi-nivo? And I can tell you, in Germany, almost nobody, and in Europe, very few are using flip-dose, simply because it's not approved. Although the data look very similar, with better tolerability for ipi-nivo flip-dose over full dose as approved, we need to say it's not approved and therefore not reimbursed in very many healthcare systems. That's the reason why in Germany nobody talks about flip dose. And we have a new option for this available in Germany since only 5 weeks. I will come back to this in a second. So what we are recommending now in European guidelines is ipi-nivo in combination ipi-nivo or anti-PD-1 plus LAG-3. Why is it written like this here in the guideline? It's written like this because the Rela-nivo, the relatlimab and nivolumab combination is approved in Europe, but in Germany it's reimbursed only since 8 weeks. And the European approval is different from the US approval because we have a PD-L1 expression limitation, which means only patients who have a PD-L1 expression in a TPS score of less than 1, which means 0, are allowed to be treated. It's a subgroup of patients. Although the trial was positive for all comers, the European Medical Agency, EMA, made the decision that the approval is only for PD-L1 negative patients. All right, it is like it is. And because of this, the company, the producing company, was not introducing the drug combo to Germany because our price negotiating agency was saying no to it. At least not, they were saying no to a good price. The price of the combo was negotiated 10% lower than nivolumab alone. And come on, which company would introduce a drug to a market when they are not making some money with it? And every combination is more expensive than single agent treatment. Now they found a compromise, and since April 1st or whatever it was, March 15th, we can use Rela-nivo now, and this is the alternative to ipilimumab, nivolumab. You know that there is another drug combo underway, which is the cemiplimab and the fianlimab, with 2 different doses of fianlimab in a randomized trial. But I believe before the end of the year, we won't see data. And therefore, we need to stick to the drugs which are approved right now. For patients with stage 4 melanoma and contraindications to immune checkpoint inhibition, and those who have a relevant BRAF mutation, which is V600E or K, here it counts K as well, we can offer a first-line treatment with BRAF and MEK inhibitors. This is how the EADO guideline published January 2025, created in the year 2024, looks like now for stage 4, that a first-line treatment with BRAF and MEK inhibitors should be offered in these kind of patients with contraindications. That's crystal clear. And look here, we are talking about the level of evidence, which has different categories. We are talking about level of recommendation, which is only a B in the absence of randomized clinical trials. And we have a consensus rate of 100%. This explains that 26 of 26 guideline committee members were saying yes to this consensus-based recommendation and the exact wording. You won't believe how long we are working sometimes on the wording of this, because it's so sensitive. Should be offered is something different. One can be offered. Can be offered is soft. Should be offered is strong. The next recommendation change is a so-called stage 4 sandwich treatment. The recommendation level is lower. It's a C, the level of evidence 2A, but the consensus rate another 100%. And we are saying that in particular scenarios like poor performance status of the patient, high LDH, high tumor burden, aggressive course of the disease, or symptomatic metastases, we recommend in patients with a relevant V600 mutation, first-line treatment with BRAF and MEK inhibitors for 6 to 12 weeks. And then we are switching independently from the reevaluation results to immunotherapy, which means PD-1 alone or ipi-nivo. That is called the sandwich, the sequential treatment. The data from at least 2 clinical trials have been analyzed, nicely published, and they all show convincingly that this is an alternative approach to the initial use of ipilimumab, nivolumab, combinational immunotherapies. The next recommendation is on stage 4 second-line treatment. Very, very few randomized data. Now there are some clinical trials underway, which makes us happy, but this is little more than gut feeling. We have data, but it's not from randomized trials, it's from phase 2 data. So unresectable disease after treatment, and there's very clear, if in first line you used an immune checkpoint inhibitor-based treatment modality, and the patient carries a BRAF mutation, we can use BRAF and MEK inhibitors in this particular case. Very high response rates, up to 70%, even in second line. So it appeared, at least from 2 clinical trials, that the second line data are as good as the first line data for response rate, but the duration of response is shorter if patients are pre-treated with some sort of immunotherapy. And that is something which matters, because the second line treatment is preferentially being done in clinical trials. And we have a number of clinical trials available. And in my opinion, my gut feeling is that more and more of the pharma companies are interested in not the last line, but in second or third line treatment, because in first line it's very busy. We have very strong treatment modalities, and I explained to you already that I don't believe that we will see significant changes in first line over the next years, because I don't see very, very strong innovative new agents coming on the horizon. That's my personal expectation. So therefore, clinical trial is first choice, as always, if clinical trials are available. So what are we doing with brain mets? Brain metastases are an issue everywhere in the world. And, here we have the exciting data from Hussein Tabi, published in New England Journal of Medicine, And I need to say the data are so good that there was no doubt to recommend for patients with active brain metastases, not those where you have a single brain met and you can use stereotactic irradiation or brain surgery if they are symptomatic. This is patients with multiple brain mets, a typical situation where we should use PD-1 plus CTLA-4 antibody as first-line treatment, 100% consensus among the experts again. And I think it's absolutely right. So this has changed our guidelines significantly, and the targeted therapies are not this strong in first line. And what is impressive here is that Ipi/Nivo produces long-lasting responses even in patients with multiple brain mets. Let me say a word on Ipi/Nivo here again. Here, I think even if we have the flip dose available, not only approved but also reimbursed in Europe, very few would use the flip dose. Most of us are hesitating with the flip dose, and the reason for this is that these kind of patients, which is the toughest to treat with multiple brains, may need the full dose of ipilimumab. Therefore, we go with a conventional dose of ipilimumab and nivolumab as it is approved. May I come to the last chapter of how we treat melanoma in Europe? It's a symptomatic brain mets treatment. And, honestly, these patients don't have a good life expectancy. In every country, we know even if you can decrease the size or eliminate the metastases for 4 months, the risk of a recurrence is extremely high. And we believe that for these patients with symptoms, if they have a V600 mutation, the targeted therapies should be a first-line treatment. But also here, we have in mind that the next tumor board discussion may lead to a sequential treatment. So after you used it for 8 to 12 weeks, the BRAF and MEK inhibition, we have 3 different kinds as in almost all parts of the world available, namely encorafenib, binimetinib, and dabrafenib, trametinib. And last but not least, it's the vemurafenib and the cobimetinib. So we have the choice of 3 different regimes with different toxicities, but the efficacy is almost the same. These patients might need a switch, and it's not always useful and not always working. We have a number of patients who had a rapidly progressive disease when we stopped the targeted therapies and switched to Ipi/Nivo, and others are doing well. But here, I think you have a really hard time to discuss it because these symptomatic brain mets indicate a worse prognosis. So whatever you do, have in mind to release the symptoms, and then you can aim on long-term outcome. Well, with this, I'd like to thank you very much for your kind invitation. I started 5 minutes earlier, so I can close 5 minutes earlier. And I want to sum up that we have more or less the same evidence for guideline developments, but the evidence is the same, but not the approval situation, and obviously not the reimbursement situation. So therefore, we have different treatment regimes and different recommendations, but the 2 biggest European guidelines, namely the ESMO guideline and the EADO guideline, are currently under evaluation for the new release. And in 2026/early 2027, you will see the outcome, and you can look up what we are doing right now. Thank you very much for your attention with this photography of our university hospital, which is only 5 years old. I'd like to thank you very much. Bye-bye. I can't hear you.
Yes, I apologize again. Dr. Hauschild, thank you very much for the great presentation and very informative 30 minutes. For now, I would like to invite our next speaker, Dr. Zohra Mohammed Ahmed from HCG CCK. Dr. Ahmed's presentation is titled When Guidelines Meet Reality. Please welcome Dr. Ahmed.
Good afternoon, everyone. Am I audible?
Good afternoon for you.
Please share my presentation.
Yes, your presentation will be shared just in a minute. Dr. Ahmed, could you please share your presentation? Yeah, I think it's all right. You can.
Okay.
Yes, if you're ready, you can start. We are here to listen.
So my name is Dr. Zahra from Kenya. I'm a clinical oncologist. And after hearing about all the to clear. I think there's a problem with my screen sharing. We can start.
Dr. Ahmed, I think on the screen we have multiple screens. If it's okay, could you please unshare your screen and share one more time?
Okay. Can you share it from your end since I shared it with you?
We would like to ask you to try one more time. I think it should work, actually. Yes?
Are you
good.
able to see it?
It's perfect. You can start now.
Now?
Yes? Now it's perfect. Okay, then let's start.
So I'm going to make a short presentation of guidelines meeting reality, especially for us who come from resource-limited areas. Now, I'd like to start by indicating that melanoma is the highest incidence is seen in fair-skinned populations, and it's strongly associated with ultraviolet exposure and tanning behavior. In this subtype of patients, the cutaneous melanoma is the one that dominates, while in our African population, we see more commonly the acrolentigious and mucosal melanoma. So it's not a matter of it is uncommon in our population, but the subtypes we see are very aggressive and disproportionately lethal. We just had the best presentation indicating all the steps forward we've taken in regards to melanomas and all the positive survival outcomes we've had. But while melanoma is one of the oncology's greatest therapeutic success, in many African patients, they remain excluded from these advances. Now, this is the age standardized global data indicating that in 2022 we had 331 new cases of melanoma which were diagnosed globally, and it was ranked number 17. While in Kenya, we are a small country located around here, melanoma is number 25, and the numbers are extremely low. So why does this matter? It matters because melanoma outcomes have dramatically improved globally with the emergence of immune checkpoint inhibitors and targeted therapies. This has changed outcomes and it has improved survival. And while access remains highly unequal in African and across low middle economic status country, the challenge still remains: how do we translate these ideal guidelines into real world care? Now, the next image is just the cases we usually see in our patient population. This is an example of an acrolexidius melanoma occurring at the heel in the foot, and a mucosal melanoma that is mostly and often misdiagnosed as an ulcer. And these patients usually go to the dental department often. So how do we compare the global picture to the African picture? Globally, especially in Europe, Australia, and all those countries, there is high incidence of melanomas, where in the African picture, our incidence is not as high. The global picture is usually ultraviolet driven, less common in our patient population. The most common subtype globally is the superficially spreading melanoma, while we most often see the acrolentigious melanoma. Globally, melanoma is diagnosed at least earlier. For our cases, 60% or 60 to 80% of the patients are stage 3 and 4. We have globally, there is strong screening systems. For us patients, the awareness is not that common. That is why most of the patients come in with a chronic ulcer that has been there for several months. Globally, there is broad immunotherapy access, while we have major treatment access barriers. There is extensive genomic data globally, and hence all these forward steps in the studies, while you have very sparse genomic data. And the data that's currently available that is internationally practiced is very Western-centric, while our African population is not included in these patients' trials. So I was going through all the data available for African melanoma, and the strongest data I could find was from South Africa, stating that acrolentigious melanoma represents approximately 60 to 70% of the patient's population. Black patients often present with thicker tumors, more advanced diseases, often acrolentigious from the foot, the areas that are not that sun exposed. That is why UV violent rays are not the most common risk factors. And studies have shown that low public awareness, low clinical suspicion leads to delayed diagnosis and delayed access to treatment. Now, crop farmers in Africa face a significant, often underestimated risk of skin cancer, including melanoma, due to the high level of occupational exposure to solar ultraviolet radiation. While deeply pigmented skin usually offers a natural protection compared to fair skin, prolonged exposure to the sun, particularly in high altitude or tropical regions, leads to severe skin damage, actinic keratosis, and malignancies. Now, the interaction between the ultraviolet rays and the farm chemicals, such as pesticides, compound the risk of developing the skin cancer. Now, as I told you, the most common types are for us are the acrolentigious and the mucosal melanomas. Now, while mucosal melanoma account for 1 to 1.3% of all melanomas, from the melanocytes in the head and neck, sinonasal tract, oral cavity, genital, urinary, and the conjunctival, the incidence in Africa is still poorly defined. Yet, it's very aggressive and we see it more often. It is less related to sun exposure, also has fewer BRAF mutations and relatively more KIT mutations. When we do face these subtypes of melanoma, we usually have an MDT discussion, and the most common treatment options the patients get is surgery with or without therapeutic nodal dissection whenever possible. However, most of the patients that come in are usually stage 4 with widespread metastasis. Now, the question remains, do we have the same biology? I was trying to get data from the major public health private facilities that test the PD-L1 and BRAF testing. Now, I managed to get the data for 2024. We had 30 BRAF cases tested for melanoma, and out of that, only 2 were positive. And in 2025, out of 52 cases tested, only 3 of them were positive. Now, this again brings us to the same question. Are we dealing with the same biology? And if not, are these international guidelines with very good outcomes applied to our patients population? I also wanted to mention that for the public health setup, for patients who are candidates for immune checkpoint inhibitors, affordability is a huge challenge. And just to mention how that challenge comes about is the national medical cover for 1 year is usually equivalent to one supply of pembrolizumab only. Now, while melanoma guidelines have internationally changed and globally we have very good outcomes, I just kept this picture to show how the African population is not included in these landmark trials. Before immune checkpoint inhibitors, metastatic melanomas had extremely poor outcomes, and all these checkmate trials, the keynote trials, have been landmark trials that have shown that immune checkpoint inhibitors, either single agent in combination as the previous checkmate trial we just saw, showed extremely good outcomes. And while melanoma treatment has globally produced better survival, better response rate, and lower toxicity, African population remains hugely underrepresented. I just kept this trial to show that this is one of the landmark trials where 87 institutions with 16 countries were included, and there was no single representation from any African country. Now, how do these guidelines really apply to our patient population? The next trial I wanted to highlight is the COMBID trial. This is just a global representation. Now, this trial demonstrated the global expansion of targeted therapies in melanoma. However, again, participation for the African countries was zero. Now, the COMBID trial changed the practice of melanoma with the dual blockade for those patients who are candidate. And we also saw that for the BRAF, it was the BRAF V600E patients who benefited most with the combination regimens. Now, this is also a representation of how African countries are underrepresented and how we can apply these international guidelines to our patient population. Now, the last trial I wanted to keep is the DREAM sequencing trial, because for the longest we've had the question of which treatment do we start with first, either immune checkpoint inhibitors or the anti-BRAFs. Now, while the DREAM sequencing trial showed shifted the question from which therapy works to asking in what sequence the therapy should be delivered, this hugely depended on availability of both immuno and targeted therapy, molecular testing, the availability of multiple lines of therapy, and a structured crossover systems. Again, many African centers struggle to access even one of these modalities consistently. Now, what is our reality? In many African oncology setup, melanoma treatment is also often determined not only by biology stage and performance status, but also diagnostic infrastructure, drug availability, and cost. While surgery still remains the mainstay modality of treatment whenever necessary, and also this includes therapeutic nodal dissection, we hardly do sentinel lymph node biopsies. And radiotherapy, we do have access to SRS treatment, but most of the time, the patients who are candidates for radiotherapy usually have multiple brain metastases and end up receiving whole brain radiotherapy. I just wanted to mention that since affordability of immune and all these targeted therapies is very limited, and the cost implications is almost unattainable for our patients, chemotherapy is still used with minimum benefit, and the most common chemo used are dacarbazine and platinums, which are used with minimal outcomes. And cases of disease also, one more thing, we've seen a lot of, out of the few patients who've received immune checkpoint inhibitors, 80% of them still progress. We had a patient who had PD-L1 of 99%, but progressed to developing brain mets while on treatment. Now, I just wanted to share a small case representation just to highlight my major points in this presentation. I had a 38-year-old male patient who was diagnosed in 2022 with hyperpigmentation of the left heel area after a small prickle from a nail. The patient did not seek any medical attention. The hyperpigmentation increased and became nodular, and over 6 months period, the patient developed an the patient was reviewed in the surgical department and underwent a wide excision. Biopsy came out as malignant melanoma acrolentigious type. When the patient was referred to the oncology unit, we had a PET scan done in 2022, which showed a left heel lesion measuring 1.6 centimeters depth and 2.6 in diameter with an SUV max of 9.32. The patient had a right thigh mass, conglomerate inguinal node, right axillary base nodules, lobe nodules, and left lower lobe of the lung nodules. Now, this patient was initially seen in a peripheral facility where he received 6 cycles of platinum-based chemo with minimum response. The inguinal nodes continued to increase in size and later ulcerated, and that's when the patient was referred to the referral center. Patient was then seen in our referral facility, and we did a repeat PEN which showed interval progression in size and avidity of the inguinal lymph nodes and development of new lung lesions indicating disease progression. At this patient, we could only afford a single agent. Immuno and Evo was the most affordable and accessible at this time. So the patient received 5 cycles and could not continue due to financial toxicities. 3 months later, patient was admitted to emergency department with symptoms of intractable vomiting and 2 episodes of convulsions. MRI brain done revealed multiple widespread brain metastases. Because of the number and size, the patient received whole brain radiotherapy, 1310 fractions, with moderate symptomatic improvement. After this, they opted for home-based care, and the patient succumbed a few months later after the brain radiotherapy. This is just a case presentation of what we often see, what is available, and what we can give to our patients. We can see that we see diseases at advanced stages. Usually the index of suspicion initially is not very high, leading to the late presentations. And also, even when the patient has a diagnosis, like what are the treatment options available and what is the cost implication of those treatments. Now, last but not least, my closing statement will be melanoma in Africa is not simply a lower incident version of Western melanoma. It's a clinically, anatomically, biologically, and structural different disease landscape. And I feel like we need our own data to know what would work best for our African population and our biology. Thank you.
Thank you very much, Professor Mohammed, for your clear and thought-provoking presentation. Now let's invite our next speaker. Our next presentation will be given by Dr. Gerardo Cassato from the University of Bari, Aldo Moro. Dr. Cassato will deliver a presentation on melanoma diagnosis. Welcoming Dr. Cassato.
Good morning to everyone. Thank you very much for this kind invitation to speak at the World Melanoma Day by OncoDaily. I'm so sorry that I not be able to be present at the time of my presentation, but I have already an established task to do, but I will try to do my best to speak about the histological and molecular diagnosis of melanoma, and in details. In particularly, I want to show you the concept of melanocytoma, that is one of the most important concepts in the last 2 WHO classification. And I have no any relevant disclosure to make. And for introduction, I think that one of the most thing is that in 2025 printed 5 edition of the WHO classification, we have the confirmation of the multidimensional model of melanocytic neoplasm that was already present in the previous edition, with a maintenance and strengthening of the concept of melanocytoma as an intermediate state of the progression model, of the progression scheme model for the melanocytic lesion, with a more molecular and genetic insight that confirm this categorization approach. And as defined by my teacher and friend Arnaud de la Fouchaudière, it's important to understand that the terminology melanocytoma is a descriptive terms of an intermediate status for melanocytic neoplasm and not a diagnosis for per se. is quite similar to a concept of rapid car. Rapid car, it is not a brand. It's a descriptive terms to, for example, define a car as rapid or fast or slow and so on. In this case, is an intermediate, so rapid. We have this four-step progression scheme for melanocytic tumor, in which we know that we have an EVI that is defined by a single driver anomaly. We have an intermediate state with the so-called low-grade dysplasia melanocytoma and high-grade dysplasia melanocytoma that are characterized by different number of genomic aberration. And finally, we have at the end of the spectrum the melanoma that is characterized, is a lesion characterized by a multiple genomic alteration. So in terms of integrative classification of melanocytic tumors, we can have two different approach. We have the progression scheme model, it is possible to see in these slides, and we have the model in which we postulate that we don't have a precursor lesion, but we have the direct transformation from, for example, normal melanocytes or melanoblast to malignant cells in one mitotic division. And this is true for more or less 70% of cases, while 30 more or less percent of cases seems to follow the progression scheme model, in which we see a normal melanocytes with a single driver anomaly that define an EVI. Then we can have a driver anomaly plus a second anomaly that define intermediate tumor, the so-called low-grade melanocytoma. Then we can have a driver anomaly plus more than two genomic aberration that define an intermediate tumor, the so-called high-grade melanocytoma. And finally, we can have the melanoma, invasive melanoma, with multiple alterated genetic pathway. And we have different driver alteration, in which we know we have a lot of cases that can be mutated for BRAF, but also for NRAS, HRAS, for Spitz pathway in particular, or also, for example, c-KIT, that is quite common in a good percentage of cases of mucosal melanoma, but also another kind of, for example, gene AQ, gene 11 in blue family blue family of tumors, and also, for example, ALK, BRAF, ROS1 fusion, or TRAC1, 2, 3 fusion that are mostly common in Spitz pathway family of lesion, but not only. And the progression model is very important from an embryological point of view, because we have to underscore that we have a benign nevus with a clonal proliferation of partially transformed melanocytes that is best recognized as a facultative melanoma precursor. And we have to underscore that morphological feature reflects some different oncogenic pathway and probably differences among the cell states and sublineage of the melanocytic origin in which the driver mutation arise. At least two different developmental pathways send melanocytes precursor from neural crest to different destination tissue, and this is able to generate stem cell population residing in different niche with distinct vulnerabilities for transformation. An example can be, for example, uval, blue, and leptomeningeal melanoma that derive from the ventromedial development pathway of the neural crest, with a propensity to harbor GQA pathway mutation, for example. This is the table that are present in the WHO classification, which is possible to see the different type of melanoma, height-grade cumular solar damage melanoma with different grade of solar elastosis, tumor mutational burden, ultraviolet mutagenesis, DNA copy number variation, and so on. Low-grade cumular solar damage, acral mucosal melanoma, uval melanoma, and also Spitz melanoma. And look at the quite significant difference between high-grade, low-grade, acral mucosal, uval, and Spitz melanoma, and this different feature. In these slides, it's possible to see still the different, for example, the mitogen activated protein kinase pathway activation that is very important in the melanocytic neoplasm as molecular feature, molecular mutagenesis, and it's possible to see that we have different frequency of this mutation in different kind of melanoma. Okay, for example, in uveal melanoma, as already said, we can have gene AQ, gene 11 mutation, or for example, phospholipase B4 mutation that is quite rare or uncommon or practically virtually inexistent in high-grade cumulative solar damage melanoma and so on. Also, is very important to address the possibility, to have a mutation in the CDKN2A pathway, cyclin pathway, that we know can be evaluated also by immunohistochemistry for P16, and it can be very interesting, useful, for example, in the differential diagnosis between benign or intermediate lesion and malignant lesion, frankly, malignant lesion. Also, mutation for P53 can be very important, and also mutation in chromatin modifier can be very important in different kind of malignant melanoma. Another important aspect that I want to show you is the TERT promoter mutation that can be very different in the progression scheme of malignant melanoma, but we have to say that in more or less all of different type of melanoma, the TERT promoter mutation or the TERT amplification can be recognized. And this is the classification scheme in the WHO classification that I want to show you and discuss with you about the concept of melanocytoma. So we will speak about in the next 20 minutes about the intermediate and low-grade dysplasia and melanocytoma, and the intermediate and high-grade dysplasia and melanocytoma in the scheme progression scheme model by WHO classification. So we will speak about, for example, the WNT activated deep penetrating nevus. We will speak about the BAP1 inactivated melanocytic tumors. We will speak also about the PAM, pigmented epithelioid melanocytoma. And then we will speak about also the malignant neoplasm that can arise always in the progression scheme model by this entity, intermediate or benign entity. And this is only to show you that the concept of melanocytoma in WHO classification is present also in the 7 pathway and 8 pathway of melanoma. And so, melanocytic neoplasm with a typical feature more than 2 higher order of magnitude for risk transformation. In melanocytoma, we have to have more than one single driver mutation. We can have, from a morphological point of view, a biphasic or asymmetrical configuration with specific signaling pathway that probably contribute to their characteristic clinical pathological feature. And the diagnosis of melanocytoma in the skin should be paired with a classifier that specify the type of melanocytoma. For example, WNT activated melanocytoma, and not only. And the first pioneer paper, probably most important in the literature, that tried to give us the concept of melanocytoma was by Zembowicz et al. And Scollier in 2011, in which paper for the first time was introduced a third diagnostic category, the melanocytoma, that representing tumor of intermediate malignant potential. We know that melanocytic tumor are capable in these cases of regional lymph node metastasis, but with rare distant spread and generally indolent behavior. We can have, for example, the X-animal type melanoma that was reclassified in 2018 as pigmented epithelioid melanocytoma, that is a lesion with frequent sentinel node involvement with yet favorable outcomes, not always, I have to say. And we have so this transition from nevus to melanoma by melanocytoma, for providing a conceptual framework for understanding understanding and managing this borderline lesion. And also, I think that is very important, this concept that is contained in this paper by Zembowicz, in which melanocytoma is defined as a biological entity, while MELTAP is more a descriptive diagnosis of uncertainty. And this slide is very useful to understand the concept of secondary genetic alteration, in which we can have, for example, a common nevi, a congenital nevi with BRAF or NRAS or MAP2K1 mutation with additional molecular anomaly, and we can have three different ways, three different streets, for example, BAP1 inactivated melanocytoma, or WNAT activated melanocytoma, or PRKR1A inactivated melanocytoma, the PAM. And we can use, from an immunohistochemical point of view, like a sort of screening, this antibody for BRAF VS100E or NRAS QS100R or BAP1 or beta-catenin and all or PRKR1A, because we know that more or less of 80% of cases of PAM harbor a loss of PRKR1A. Start with the WNAT activated deep penetrating / plexiform melanocytoma, as is stated in WHO classification, and it's possible to see this clinical feature by Arnaud de la Fouchardie, young adult, mostly at the upper body, small pigmented lesion. Clinical can be worrisome with asymmetrical pigmentation and also modification in the pigmentation. From a histological point of view, these are neoplasm of spindle and or epiphyloid melanocytes with melanophages arranged in a wedge-shaped or plexiform or also fascicular pattern, with frequent extension into the reticular dermis, caused by combined activation of the MAP and WNAT signaling pathway. And we recognize two different subtypes, the so-called classic and plexiform superficial subtypes of WNAT activated melanocytoma. This is the pioneer paper that in 2017 defined for the first time on Nature Communication this entity of lesion. And from a molecular point of view, please, we have to remember that the mutation, the second hit, the mutation, for example, in CTNNB1 or in APC, is able to define a translocation of beta-catenin that is not wild type in the cytoplasm, but that will be present in the nuclei. This is important for the diagnosis of this entity. This is an example of histology of this lesion, in which it's possible to see the clinical feature, sometimes very worrisome, on the left, and the histological feature on the right. So look at this peaceful transition between the common and the pigmented clones. And another important thing is the so-called grade of melanophages that is present in this kind of lesion. This is very important to see in this slide. For example, this is the grade, a sort of grid of melanophages that is one of the most important clues for the correct diagnosis of this entity. And also with the so-called deep vertical expansion into the subcutis as a spatula. Again, large melanocytes with a foamy pigmented cytoplasm, mild nuclear atypia, with also mild dermal fibrosis and vertical maturation that are characteristic of this lesion. And this is the paper that try to shed light on the possibility to use beta-catenin antibody for the diagnosis without, not all cases can be sequenced by NGS. So in this case, it can be useful to use immunohistochemistry, and sometimes we have the possibility to see this kind of staining that is very simple to interpret with a nuclear and cytoplasmic positivity. I have said sometimes, because sometimes it's not very simple to interpret it, but in this case it's very simple to see the presence of beta-catenin staining in the cytoplasm and in the nuclei, while is negative, almost totally negative in the common nevi of background. beta-catenin immunohistochemistry is not always strong because we know that it can be score 0, non-staining nuclei, score 1 plus, score 2 plus, or score 3 plus. So please remember this concept for our dermatopathologies. And also beta-catenin is not expressed, for example, in some mimicry, for example, cellular blue nevus or other blue lesion that can sometimes be confused with WNT activated melanocytoma. This is my personal cases from my department, in which it's possible to see again a peaceful transition between common and pigmented clones, again the grade of melanophages and the morphology of these large melanocytes with a foamy pigmented cytoplasm, mild nuclear atypia, fibrosis, and so on. This is melanate, very homogeneously expressed. This is HMB45 with expression in all lesions. Sometimes this can be very important as a clue to suspect a second hit from a molecular point of view in a determined lesion. This is the positivity for BRAF WES100 that is the first hit, as already said. P16 that we can define as checkboard, and beta-catenin that is very positive in these cases in both cytoplasm and nuclei. Also, cyclin D1 can be very important and can be useful in these cases to make the correct diagnosis of WNT-activated melanocytoma. In the last years, also another paper, very nice, from this author suggests the use of LEF1, of which the nuclear positivity can be very useful and used for this diagnosis. The tips that I have learned from my mistakes for this lesion is that beta-catenin should be interpreted only in the deepest section of the lesion. Melanocytes in the junction and also in the superficial dermis are physiologically positive for beta-catenin in the nuclei because the epidermis can emit cytokines that activate the WNT pathway for pigmentation. So please be careful, because for me the most difficulty is with the superficial plexiform melanocytoma, in which I rely mostly on histological aspect, for example, melanophages grid, and not only beta-catenin immunohistochemistry. This is the 4-step progression scheme of WNT-activated melanocytoma, in which it's possible to see in the first area common nevi, in the second area deep penetrating nevus, in the third area atypical deep penetrating nevus, and the last area the plexiform melanoma, that is the end of the spectrum of this lesion. The high-grade WNT-activated deep penetrating melanocytoma is characterized by a larger size with a cellular density and a higher mitotic activity. So be careful, because in these cases we have to make the correct differential diagnosis between low-grade and high-grade WNT-activated melanocytoma. And in this case, a bulky beta-catenin stain can be useful to confirm the molecular pathway but not the malignancy, or better, the high grade. In these cases, the morphology and the histological criteria are the most important thing. We have the possibility to discuss again this 4-step progression scheme, and this is an example of plexiform melanoma in which it's possible to see a higher presence of mitotic figure in this example of plexiform melanoma. Now, I will show you the molecular pathway of PEM that is present mostly in young adult with a poor or biphenotypic with common component of nevi. Mainly is a dermal proliferation with a lot of melanophages that are mostly presented respect the melanocytes, and this is a clinical picture of this lesion that can be very worrisome, I think. This is my personal cases in which it's possible to see a more or less well circumscribed lesion, in which it's possible to see a lot of melanophages with also melanocytes that are present, and look at these cells that are very epithelioid, very freed X appearance from a morphological point of view. In these slides, it's more simple to see the epithelioid morphological feature of these melanocytes, and it's possible to see also in these cases the possibility to describe the positivity for melanA and the loss of PRKR1 alpha that is able to confirm the diagnosis of PAM. In this paper was presented in literature for one of the first time the so-called melanoma PRKR1A inactivated melanoma with a BRAF VS100E mutated background. And in these cases, it's very nice to see that more or less an half of the patient was positive for BRAF mutation, 28% of cases was NRAS mutated, and also in 18% of cases was a mutation for NF1, neurofibromin 1, and another 18% of cases was triple wild type. Now we have to discuss another entity that is called BAP1 inactivated melanocytic tumors, and this is a mutation that can be somatic but also germline, and is very important because this is a lesion that can involve children or young adults, female more than male, sun-exposed areas. We can have a modification of a pre-existing nevus with a growing unpigmented nodule that is commonly less of 1 centimeter. We can have also, from a clinical point of view, inflammatory feature, and when a patient had harbor multiple lesions, this is a tip for germline mutation. This is an example by Arnaud de la Fouchardais in which we describe a BAP1 inactivated melanocytic nevus that is characterized by a first single driver anomaly that is BRAF S100E plus a BAP1 mutation as a second hit. This is a combined lesion with a lateral compound common, usually BRAF mutated, with an intradermal clonal expansion of melanocytes, with a low proliferative index, with the epiphyloid or also nevocytoid cytology, and we have also the so-called lymphoid infiltrate with the so-called kissing figure that are another morphological feature of the BAP1 inactivated melanocytic lesion. And we have BAP1 immunohistochemistry lost in terms of nuclear staining in this lesion. Look at it. We have the internal control positive of the nevus, the common component, and the loss of BAP1 in the component with the BAP1 mutation. This is always BRAF V100 mutation that is present in more than 80% of cases, and it's important to make a question: which is the frequency of germline mutation for which the patient can harbor a germline mutation? So we know that the frequency of germline mutation with one skin lesion is less of 16% of probability, but we know that the tumor associated with a BAP germline mutation can be very wide. We can have, for example, uveal melanoma, we can have mesothelioma, pleural and peritoneal, clear cell renal cell carcinoma, cutaneous melanoma ex BAP1 inactivated melanocytic tumor, leptomeningeal melanoma, meningiomas, multiple BCC, hepatocellular carcinoma, cholangiocarcinoma that arise at a younger age. So be careful to this one. Indeed, Arnaud de la Fouchardais make a very important recommendation. We recommend following the diagnosis of a melanocytic tumor with loss of BAP1 expression to perform a BAP1 immunohistochemistry in all other cutaneous melanocytic tumor, remove previously or simultaneously and the whole skin melanoma to detect the potential possibility to have a germline mutation for BAP1. This is 4-step progression scheme of BAP1 inactivated melanocytic tumor. Look at it. We can have common nevus, we can have BAP1 inactivated nevus, we can have BAP inactivated tumors, and finally we can have melanoma ex BAP1 inactivated nevus. That is, quite rare, but can be possible to see. This is area 1, common nevi. In more than, as I already say, 80% of cases, there is a mutation for BRAF WES100E, area 2, in which it's possible to see BAP1 inactivated, melanocytic nevus. Look at it, very epithelioid morphology. Area 3, BAP1 inactivated melanocytic tumors with a higher grade of cytological atypia. Look at it. And this is area 4, melanoma X BAP1 inactivated melanocytic tumor. Lost for BAP1, BRAF, and so on. And to finish my presentation, I think that could be very interesting to say something, only 2 or 3 slides, about the implementation of AI in melanocytic lesion, because I think that this is one of the other important field in continuous expansion. And for example, in this paper, very recent paper, the author tried to use artificial intelligence-based triaging for cutaneous melanocytic lesion. And the author tried to employ an AI model, to train an AI model to classify melanocytic skin lesion in low and high grade complexity categories using a huge number of whole slide imaging. And what were the most important thing about the melanocytoma trying to use this kind of AI-based algorithm? That the WNAT activated and BAP1 inactivated melanocytoma were among the most complex lesion, still requiring expert histopathological and molecular evaluation, also for AI. So the concept that I wanted to give us is that also AI can have difficulty, high or less difficulty, to properly categorize this lesion, because these lesions are very difficult to diagnose. And also AI can be useful for the dermatopathologist, but is not able actually to make the correct diagnosis without any interaction, obviously, with the pathologist. And I want to finish my presentation with these sentences by Albert Einstein. There are 2 ways of living life: one of thinking and nothing that is a miracle, the other of thinking and believing that everything is. Thank you very much for your attention, and for any kind of question, collaboration, or simply speaking, we can reach to my email and speak with me. Thank you very much, and good luck for the remaining World Symposium Day by OncoDaily. Bye bye.
Thank you, Dr. Cazzato, for this amazing presentation. Now I would like to welcome our next speaker, Dr. Jafar Al-Mondiri from Iowa Shore Cancer Institute, who will present TIL therapy in melanoma. The floor is yours.
Good morning, everyone. My name is Jafar Almondri. I'm a medical oncologist at the Melanoma and Skin Cancer Program at Nova Shore Cancer Institute, just outside of Washington, D.C. I'm also an assistant professor of medical education at the University of Virginia School of Medicine, and I'm so excited to be taking part in World Melanoma Day at this global virtual symposium put together by OncoDaily. My thanks to to all the organizers, and particularly the co-chair of this event, Stephen O'Day, who's been a wonderful mentor to me, and many thanks to my esteemed co-panelists on this day's presentation. So these are my disclosures. I have nothing to report. And so we'll begin by talking about our goals and objectives for today's talk, and that is first to discuss the design, manufacturing, and delivery of novel adoptive cell tumor infiltrating lymphocyte therapies in melanoma. I'll then briefly outline the data supporting TIL efficacy as a new standard of care in advanced treatment refractory melanoma, with special attention to major toxicities. In doing so, I'm going to highlight 2 major trials which support its global use currently. Third, I will review the factors limiting widespread use of TIL therapy and areas for improvement as we move forward. So in best learning principles, we're going to start with our key takeaways that I want everyone to come away with from this talk this morning, which is that TIL therapy is the first FDA-approved autologous adoptive cell therapy for solid tumors and represents an important breakthrough in the care of patients with advanced metastatic melanoma. It provides a pathway to restore exhausted T cell functionality and produce durable responses through a single infusion with little to no long-term toxicities. However, wait times during TIL production and acute toxicities of lymphodepletion and high-dose IL-2 or interleukin-2 limit widespread patient use and adoption in clinical practice. I would like to say that modification of TIL selection, processing, post infusion conditioning may greatly improve the efficacy of TIL therapy while reducing toxicity. And we'll talk a little bit more about what is being studied currently in that space. So first, we want to begin by understanding, well, what is tumor-infiltrating lymphocyte therapy? Well, essentially, it is an autologous T cell population that is first obtained through metastatectomy or surgical removal of an area of tumor in a patient's body, at least 2 centimeters in size, maybe in many different areas of the body, including skin, lymph nodes, subcutaneous, soft tissue masses predominantly. However, there have also been more visceral selection of lung, liver sites that maybe have some virtue, which site we choose, but that's an area of active investigation. So this surgical tumor sample is then taken to the lab where it is enzymatically and mechanically digested and fragmented, ultimately becoming a single cell suspension. This is then fed with interleukin-2 for a period of 2 to 4 weeks, where the T cells in the single cell suspension really proliferate and start to expand in ex vivo. Then it enters a rapid expansion protocol where additional IL-2, anti-CD3 antibodies, and peripheral mononuclear blood feeder cells are given into the suspension, which further allow for proliferation of those T cells, ultimately becoming a final T cell infusion product, which contains anywhere from 10 to 50 billion cells in total. The patient, once this is completed, is given lymphodepleting chemotherapy, most often fludarabine and cyclophosphamide in the manner that's given for hematologic malignancies over a course of 5 days. The patient is then hospitalized and the TIL infusion is given on day 1, and then additional high-dose interleukin-2 is given for up to 6 doses at 600 to 720,000 international units every 8 to 12 hours for, again, up to 6 doses. And this allows for the survival, expansion, and navigation of those TILs inside of the patient's body to allow for and expand its anti-tumor efficacy. We say up to 6 doses of IL-2 because we know that this is a very challenging process. The patients are already undergoing the toxicities of that pre-infusion lymphodepletion, and then we add to it what we know is to be a very difficult treatment. We know high-dose IL-2 can cause a lot of hypotension, capillary leak syndrome, a lot of cardiopulmonary rigor. And so there's a lot of support that's needed for patients during this hospitalization, which is often 2, 3, or 4 weeks in duration, and may involve a high ICU level care and support. So when thinking about TIL therapy, it's helpful to distinguish it from the other adoptive T cell therapies that are in current clinical practice now. Again, we talk about TILs as an autologous collection from a patient's tumor, and this includes within a heterogeneous population of lymphocytes, meaning that we don't pre-select for any particular lymphocytes except for those that have shown the phenotypic ability to infiltrate that tumor. And we do know that that's an important quality in a T cell, and really one which we want to expand and offer that patient, because we know that these have shown a certain ability that we think is important for anti-tumor efficacy. Importantly, with a heterogeneous population of T cells, there's the advantage of having T cells which target multiple tumor neoantigens. And this is an important advantage, particularly when thinking about tumors with a high tumor mutational burden and multiple unique neoantigens like melanoma. And this ability to really scour the landscape of tumor antigens is something that we believe is important for those who can obtain a long-term complete response through the ability to see the tumor in all of its sort of neoantigens and faces, if you will. This is to be contrasted with engineered TCR T cell therapies and CAR T cell therapies, which use an engineered T cell receptor that's given through a lentivirus vector and really selected for a single tumor antigen, usually one that's well conserved and what we call a cancer testis antigen, but still only a single antigen. And these may have shared on target but off tumor toxicities to the patient, as some of these antigens are still expressed in other areas of a patient's body. Moreover, TCR T cells are limited by MHC class HLA typing, meaning that not all patients are going to be or eligible for a given therapy, most of which now focus on HLA-0201 subtypes. So they're an important disadvantage to think about in this when contrasting it against TILs. We do have to note, however, that TILs do have some limitations in that a given tumor taken from a patient's body is going to have some spatial heterogeneity when we compare it to other areas of tumor in that same patient, meaning that a given area excised from the body may have private mutations or non-representative antigens, and even some exhausted T cell sampling that is in some ways luck of the draw. We still don't have a good selection process for knowing or really the ability to find a tumor that's going to necessarily represent the entirety of a patient's malignancy. Again, thinking about the TIL, this is another diagram sort of showing the TIL process from tumor extraction to digestion and expansion. But when I really wanted to use this slide to highlight that there's a polyclonal population of T cells in that final TIL suspension, meaning that it's both CD4 and CD8 positive T cells directed at both tumor antigens, neoantigens as we call them, but also some that are targeting shared antigens in the patient's body and non-malignant cells. And there's also included within this bystander T cells directed at virus-infected cells and other peptides directed at viral antigens. And so this is a highly individualized product, but again, a very heterogeneous population, some of which in these bystander T cells in particular may be actually providing an inhibitory role against the ultimate anti-tumor efficacy that we hope to cultivate with the TIL product. So now I'm going to switch gears here and talk about the data supporting TIL efficacy. And I want to spend more time talking about the article from Jason Chesney and colleagues in the Journal of Immunotherapy of Cancer in 2022 that looked at the efficacy and safety of lifileucel as a one-time infusion for patients with advanced melanoma after progression on immune checkpoint inhibitors and targeted therapies if they were BRAF positive. This was the trial that really supported the registration and FDA approval of lifileucel or Antagvi as produced by Iovance Biotherapeutics, and so a very important trial to consider when saying where we're at today. So looking at the C14401 trial, this was a phase 2 multi-cohort, multi-center study of lifileucel in patients with advanced unresectable melanoma after who have experienced progression of their cancer with at least one prior treatment with an immune checkpoint inhibitor, and if BRAF V600 positive, they must have received BRAF and or MEK plus or minus MEK inhibitor therapy. The final registrational cohort was cohort 4, but because of the identical eligibility, they report here on cohorts 2 and 4 of cryopreserved lifileucel. And it began with 189 patients who successfully underwent tumor harvest, ultimately 153 of which received the infusion and were used for the final analysis and efficacy data set, as well as the safety data set. Now, it's really important when thinking about TIL therapy to think about those who dropped out of this process, meaning that both in this trial and particularly in the real world, there are going to be a significant number of patients who do not actually receive lifileucel even after tumor harvesting. And this is for a number of reasons, but predominantly because of progressive disease. Again, this is a patient population that has a treatment refractory or relapsed cancer, so very high risk population. And so we saw that even in this trial, there were a number that could not make it to TIL infusion because of progressive disease, adverse events, death, or a new anti-cancer treatment which needed to be started more urgently. And so, and there was also a number of patients whose lifileucel did not meet the manufacturing requirements, meaning that there was not enough cells, it didn't meet quality specifications. And this is an important barrier that we see in this process, that there are some patients which, even with successful tumor harvest, the manufacturing is going to fail for a significant minority. So looking at the patient demographics in the study, we just want to say that this was a very representative sample of patients with advanced melanoma, and they were first, well represented amongst both cutaneous and an important subset of mucosal and acral melanomas in this full data set. An important group of rare melanoma subtypes which don't often get represented in trials. So it was very helpful to see them represented here. About half of patients did have liver or brain lesions, no active brain metastases, but still a group with, we know, high-risk disease. Over 3/4 of patients had over 3 target lesions. Over half of them had an elevated LDH at baseline. This, we know, is a very poor prognostic factor. The median number of therapies in this trial was 3, but all the way up to 9 in some patients. And this is to say that this patient population included in this trial were, very high risk disease, very a fair analysis of whom we'd want to treat and who we really worry about in the treatment space. So looking at the waterfall plot here, the overall response rate was 31%, and that included about 5% with complete responses, as you can see in the green all the way off to the right. But the number of patients who experienced any tumor reduction was almost 80%. So there was only a small number of patients who experienced primary progression on the treatment after infusion. And importantly, we want to say that these were brisk, durable, and deepening responses over time, meaning that the median time to response was only 1.5 months. And the median duration of response, now that we have 5-year follow-up, as published by Medina and colleagues in the Journal of Clinical Oncology last year, median duration of follow-up or duration of response was seen to be over 36 months or over 3 years. Importantly, over this, you can see in this swimmer plot that actually a lot of patients who started off with a partial response. This is an analysis of all the responders in this data set. We saw that many of them actually moved from having stable disease initially to having ultimately achieving a partial response later on, or those who started with a partial response, as seen in the swimmer plot, many of them converted to a complete response later on. And so this is, again, on a single infusion treatment, meaning that they did not receive any other therapies after their TIL infusion. They were just monitored and cared for in a supportive manner. And so we saw that some continued efficacy over time, and particularly in that first year. It is notable, however, that up to 45% of those initial responders did later experience progressive disease, but that, now looking at a median follow-up of 57 months, we're seeing that many, if not most of these responses are durable. And important to say that when they broke down subgroups in this, benefits were maintained across nearly all subgroups. So when we look at this forest plot, there are some important subgroup disparities that are worth highlighting here, in that those patients with an ECOG performance status of 0 as opposed to 1 or greater seem to enjoy a little bit more benefit. Particularly those with lower burden of disease, meaning a baseline target lesion, sum of diameters that's less than 98 millimeters. Those patients seem to get much more benefit. Those patients with a baseline number of target lesions under 3, again, more benefit seen there. And those with a normal LDH at baseline also seem to get more benefit. So just to say, we could summarize this by saying that the patients who experienced the most benefit on this trial were those with that were not as sick, that had a lower tumor disease burden. And those conversely who were sicker and had a higher disease burden or a higher LDH seemed to get less benefit. There also may be some insights as to the responders seem to have a higher total number of TIL viable cells in their final infusion product, 30 billion as opposed to 21 billion in the non-responders. And perhaps those with baseline liver lesions received some less benefit, which is maybe expected as we know these are high-risk prognostic factors. So looking at our overall survival and progression-free survival Kaplan-Meier curves here, we see that very characteristic of patients on immunotherapy, we have this long tail to the curve, meaning that there are a significant number, about 20 to 30%, who seem to be achieving a long-term response with little decrement over time. The 5-year median overall survival was about 20%, and median overall survival was 14 months. Median progression-free survival was 4 months. So certainly a lot of patients who didn't get to experience the benefit here, but for those that did achieve a response, most, or at least the majority of them did have a durable response over time. Looking at safety, it's important to say that there were a lot of concerns in the first month after treatment, meaning that nearly all patients experienced some degree of cytopenias, as we would expect. Really thinking about lymphodepletion as it sounds, the goal of which is to induce at least grade 3 lymphopenia, and indeed 100% of patients achieve that, but at the cost of a lot of grade 3 and 4 thrombocytopenia, neutropenia, febrile neutropenia, and fatigue, hypotension, diarrhea, fever. All of these were concerns for this patient population. And this included ultimately 12 deaths on the trial, 7.7%, and roughly half of those were treatment-related adverse events or deaths reported to be due to the TIL infusion. There were some treatment-related adverse events of special interest, but of note, there was very few patients that had cytokine release syndrome or immune cell-associated neurologic syndrome, so very different than bispecific or CAR T-cell therapies in that regard. And important to just say that, again, most of the safety issues were in those first 30 days with little to no long-term toxicities, as you can see in this adverse event plot here, and that there were no new or late onset adverse events that have been seen in the long-term follow-up of these patients. So I'm going to switch gears here and talk a little bit about another trial that has supported TIL efficacy in the greater world space. And this was the M14 TIL trial as published in the New England Journal, comparing tumor-infiltrating lymphocyte therapy against ipilimumab for advanced melanoma in the second-line setting. And in this case, it's a slightly different TIL product. It's TM001, which is a non-commercial and fresh, meaning non-cryopreserved autologous TIL product that was developed at the Netherlands Cancer Institutes and produced at academic centers in the Netherlands and Denmark, and available in that region of the world under hospital exemption programs. Now, this included about 169 patients, and they were randomized 1-to-1 against TIL treatment versus ipilimumab in the standard dosing of 3 milligrams per kilogram every 3 weeks for a max of 4 doses. In this case, they screened and included only patients with one prior line of therapy that could not have included ipilimumab. And they specifically excluded patients who had a LDH that was over 2 times the upper limit of normal, and specifically patients with a performance status of 0 to 1. And indeed, they saw that 80% of 8 patients in this trial had a normal LDH. 86% were here after progression on a PD-1 inhibitor. And so this is a far different patient cohort than the one that we just established in the Chesney article, meaning that this is a less sick and less treatment refractory group. So right away, we see that the progression-free survival was clearly better in the TIL group with a hazard ratio of 0.50, highly statistically significant, about 7.2 months versus 3.1 months in the ipilimumab group. And overall survival, while not reaching statistical significance, really seemed to favor the TIL group. Importantly, we saw that the overall response rate in this trial was about 48.8%, and that the number of patients receiving any amount of tumor reduction was 68%. And this is to be contrasted against ipilimumab, which had a response rate of about 20%, and only about 40% of patients received any amount of tumor volume reduction. And this is consistent with past reports of ipilimumab standard efficacy in the second-line setting. Important to bring some attention to the plot here in the middle, where they, in this cohort, looked at global health-related quality of life scores, as well as physical and emotional functioning. We took some time to really talk about the rigor of TIL therapy. And it's important to say that at least in this group, they did not see any major decrement in quality of life, physical or emotional functioning when you compare the TIL group versus the ipilimumab group, in spite of that very rigorous lymphodepletion and high-dose IL-2 that we had mentioned before, that really does require prolonged hospitalization and really could be seen as a real cost for patients. So important to see that that didn't suffer in this trial. And so thinking about, the rigors of TIL therapy, it's important to highlight really why is lymphodepletion important. We're going to switch gears here now and finalize what are the factors that limit use and areas of improvement for TIL therapy. And so we begin by thinking about the toxicities of TIL therapy. And so this brings up the question, well, why is it important for us to give this lymphodepletion? And it's a few proposed mechanisms. Probably the most important is that we need to deplete that immunoinhibitory immune cell population, including T regulatory cells and myeloid-derived suppressor cells, which may really limit TIL efficacy after infusion. And this limits the cytokine sink that we see from these other immune cells. And so importantly, that patients after lymphodepletion can demonstrate much higher circulating levels of IL-7 and IL-15, which we think are really important for the survival engraftment and anti-tumor efficacy of TILs. There's also the proposal that the mucosal immune cells and the disruption of GI immunity does allow for even further cytokine release. So an important thing to mention there. Importantly, we also know that from looking at TILs over time, it's important to say that TIL therapy is not truly new. It's been studied since the 1980s with Steve Rosenberg and his colleagues at the National Institute of Health here in the United States, and that many different lymphodepletion regimens have been tried, and that increasing the intensity of lymphodepletion doesn't seem to improve efficacy, though it does certainly increase toxicity. Generally, again, we've been stuck with cyclophosphamide and fludarabine in the doses as seen here, which really do reliably achieve a cytopenia nadir, and patients are hospitalized until infusion is given at that time. Now, thinking about eligibility for TIL therapy, it's in many trials and in many times when we adapt a new therapy from the clinical trials which supported their efficacy, we think about adapting them for a broader patient population that may not have fit into that eligibility criteria for that particular trial. And while that's tempting to try and expand access to TILs to more patient populations, it really bears saying that the bottom line is that the patients who seem to benefit from TIL therapy are those who have a good performance status, good cardiopulmonary reserve, are generally younger than 75 years of age, though there are some exceptions to that. We see people aging with better and better health into their later years. But these are the patients who are going to be able to really take on those toxicities and really need to be carefully selected when thinking about who's appropriate for TIL therapy. Likewise, we need to think about surgical morbidity of harvest, meaning that resectable tumors over at least 2 centimeters in size, usually greater than that, are going to be the ones that really need to be selected for when thinking about referral for TILs. And lastly, there's a lack of data around active or untreated CNS metastases. They were not included in the patient population in the trials mentioned. And we know that symptomatic brain metastases that require ongoing steroids could really inhibit efficacy of TIL therapy and should be avoided thinking about this. Moreover, untreated CNS metastases, when given this lymphodepletion, may start to experience hemorrhagic changes with the severe thrombocytopenia that we see after lymphodepletion. So thinking about the whole TIL process, where are we looking at optimization and improvements and ways to improve access or improve the efficacy of what we've achieved so far? Well, I think it begins all the way upstream when we talk about the optimization of a resection site. There's growing data that certain sites of harvest, like skin, subcutaneous tissue, and lymph nodes, may be superior to lung or liver. But that needs to be further studied and will be an important area where we see more data driving our practice patterns. But this is often limited by what the given patient has as a resectable site going into TIL therapy. Thinking about the cell manufacturing process, this is an unselected T cell population, as we mentioned before, but there may be some value in providing some selection bias towards effector CD8 positive CD27 T cells, which maybe have higher anti-tumor efficacy, and likewise stem-like CD39 negative and CD69 negative T cells that boost T cell functionality and increase efficacy. Thinking about the lymphodepletion, we mentioned its toxicities at length. There are some ongoing trials looking at reducing the doses of cyclophosphamide. Likewise, there's some engineered T cells which simulate the TIL therapy process but don't require IL-2. So I'll mention OBX-115, which is undergoing a lot of study and a lot of research interest, which has an inducible membrane-bound IL-15 that doesn't require that high-dose IL-2 conditioning that's traditionally given with TIL therapy, meaning that in this engineered T cell, they're able to induce IL-15 through a medical trigger, in this case, acetazolamide. Likewise, there's a Dutch trial ongoing that's looking at TILs plus nivolumab, an anti-PD-1 antibody, with pegylated interferon alpha as the conditioning regimen, a far better tolerated conditioning regimen than high-dose IL-2. All of these represent key areas for improvement and are going to enrich the data sets as we move forward into the future. Finally, I'll bring your attention to the bottom of the screen here. There are some real just logistical referral pathway issues. And since the FDA approval of lifileucel in February of 2024, we're gaining more and more real-world experience with it. And there was a study out of the Oregon Health and Sciences University that looked back at their patients that had been treated there. They looked at a data set of 45 referred patients. And importantly, they saw that only 51% of them completed TIL infusion, and only about 62% ever even completed the harvest for it. And this brings us back to those barriers that we mentioned before, meaning small tumor size, rapid disease progression, or out of specification TIL products, meaning those TILs that failed to really expand ex vivo, all limited the ability for these referred patients to ultimately receive this therapy. I know we're running short on time here, so I'll just end by saying, there's a lot to be said about, well, where do TILs fit into the overall armamentarium of advanced metastatic melanoma treatment? And there are some trials ongoing to bring it earlier on and look at TILs in the first-line setting as combined with pembrolizumab in this case. And so we'll look out for this major phase 3 trial, TILVANCE 301. And its data in the first line setting. And it's important to say, some early phase 2 data that suggests that TILs in the first line setting and combined with immune checkpoint inhibitors may have a much higher overall response rate, at 86% in one small trial. But that the overall survival benefits of giving this very rigorous therapy in the frontline setting are really to be debated, meaning that a meta-analysis that have looked at ICI naive versus ICI experienced patients didn't see an improvement in the median overall survival. I will say that in terms of timing, early referral to a TIL authorized treatment center is going to be of major value for patients because of the logistical hurdles of finding time for surgical resection, then getting those cells off for production, bridging chemotherapy or other bridging treatments for that patient, because we know this is a patient population that can experience progression of their disease while awaiting TIL therapy. All of these need to be thought of much earlier upstream. And I'll say that in my own practice pattern, we have to think about it almost immediately after first line therapy. So we'll conclude here by saying some of our key takeaways, again, just to really drive it home, that TIL therapy is, again, the first FDA-approved autologous adoptive cell therapy for solid tumors and represents a very important breakthrough in the care of patients with advanced metastatic melanoma. It can produce durable responses in 30 to 40% of patients through a single infusion with little to no long-term toxicities. And important to say that this can be enriched through careful patient selection, meaning that really we saw that most of the benefit was experienced in those with lower tumor volume, fewer or non-visceral disease sites, normal LDH, and good performance status, which again supports us thinking about TILs earlier and earlier in the treatment armamentarium. Wait times during tumor harvesting and authorized treatment center referral for TIL production and acute toxicities of lymphodepletion and high-dose IL-2 still limit widespread use. But modification of the TIL selection process and the selection of certain T cells and the pre and post infusion conditioning may greatly improve efficacy while reducing toxicity. And it's a lot of data coming up ahead of us. And so a very exciting time to be in melanoma. I thank you all for your patience and your listening this morning, and I'm so excited to hear your questions. Thank you so much.
Thank you, Dr. Al-Mondiri, for this fascinating presentation. Now we'll have a 20-minute break and we'll resume shortly.
Biotech is moving fast. New breakthroughs, major clinical updates, company moves, regulatory decisions, and industry shifts are happening all the time. But keeping up with what actually matters can be difficult. That's where OncoDaily Biotech comes in. We bring you timely, relevant, and engaging biotech news in one place. From innovation in cancer care to broader developments across the biotech space, including research progress, funding news, partnerships, emerging technologies, and the stories shaping the future of medicine. Whether you're a healthcare professional, researcher, biotech leader, investor, or simply someone who wants to stay informed, OncoDaily Biotech helps you stay connected to the news that matters. Follow OncoDaily Biotech and join a growing community exploring the future of biotech one update at a time. Artificial intelligence is quietly reshaping oncology, not in theory, but in how we think, how we work, and how we decide. Across the world, researchers and clinicians are moving with it. Different places, the same moment. A pause, a realization, a decision, and then they move. On May 30 in Chicago, during the ASCO 2026 annual meeting, these paths come together. OncoDaily Grand Rounds, AI and Oncology Edition, organized by OncoDaily with ZS as exclusive partner. Become part of the AI oncology community. Register now. Biotech is moving fast. New breakthroughs, major clinical updates, company moves, regulatory decisions, and industry shifts are happening all the time. But keeping up with what actually matters can be difficult. That's where OncoDaily Biotech comes in. We bring you timely, relevant, and engaging biotech news in one place. From innovation in cancer care to broader developments across the biotech space, including research progress, funding news, partnerships, emerging technologies, and the stories shaping the future of medicine. Whether you're a healthcare professional, researcher, biotech leader, investor, or simply someone who wants to stay informed, OncoDaily Biotech helps you stay connected to the news that matters. Follow OncoDaily Biotech and join a growing community exploring the future of biotech one update at a time. Artificial intelligence is quietly reshaping oncology, not in theory, but in how we think, how we work, and how we decide. Across the world, researchers and clinicians are moving with it. Different places, the same moment. A pause, a realization, a decision, and then they move. On May 30 in Chicago, during the ASCO 2026 annual meeting, these paths come together. OncoDaily Grand Rounds, AI and Oncology Edition, organized by OncoDaily with ZS as exclusive partner. Become part of the AI oncology community. Register now.
Welcome back, everyone. Thank you for rejoining us. We're ready to continue with our program. Now we welcome Dr. David Savage from the University of New Mexico Comprehensive Cancer Center. Dr. Savage will present on melanoma survivorship. Thank you for joining us today, Dr. Savage. The floor is yours.
Thank you very much. And thank you so much for having me. It looks like you can see my slides okay, and I just want to check when I advance it. Does that work? Yeah. Okay. Thank you. So thanks for having me. And I'm a melanoma oncologist at the University of New Mexico. You're going to see lots of excellent presentations today about conventional treatments in 2026 for melanoma, from immunotherapy to cellular therapy to targeted therapy. And I think these are all excellent presentations. Because of this, I'm going to speak a little bit about what melanoma survivorship looks like in 2026. It's something I think about a lot because, as I will show you at the end of this as a segue to the rest of your presentations, the survivorship for some people with melanoma has really become excellent. And I think that survivorship is something that all of us who take care of people with melanoma should be thinking about. I'm going to start by saying that on account of this being a month that really focuses on melanoma and a day that really focuses on melanoma, if there are presenters watching this today who are survivors of melanoma or people who are going through a melanoma treatment journey, I just want to say, first of all, we think about you a lot, and I want to congratulate you because that's a really hard thing that you're doing. And I hope that if you're not just a person who treats melanoma, but you're somebody who has experienced it firsthand, that you learn a few things from this presentation that can be a benefit to you. For all of our healthcare providers who are listening to this, I hope that you learn and appreciate some things that will help you better educate some of the people that you encounter and treat with melanoma. I think about several different long-term problems for people who may experience melanoma. One of them is the financial toxicity of treatment. I'm going to show you some numbers in a moment that are staggering about what this kind of treatment costs, at least in the United States. And it's something that I think that we don't think about it often enough because people come to us with insurance of some kind. A lot of times that the care is covered, but occasionally a patient will bring up the copays that they're experiencing, even despite the health coverage that they have. And that can be really a huge burden for many patients. And sometimes it leads to people stopping treatment because they simply can't afford the treatment that they're undergoing. Number two, I think about the side effects that people experience. In the age of checkpoint inhibitors, sometimes immune-related adverse events don't just happen one time. They happen and they persist for months, years, sometimes forever. And these can be a big impact on a survivor. And the third thing is the mental health, because I think that the worry of melanoma returning is significant and is not something to be taken for granted. So there are a number of expenses commonly associated with melanoma treatments and the studies that we do for surveillance and treatment monitoring. In the top part of this slide, I have the brand names of a lot of our checkpoint inhibitors and our targeted therapies that we use. And I think we don't think about enough that these treatments can cost in the range of $10,000 to $20,000 per month. Now that's the billed charge. That's not necessarily what the patient pays. But if you have a person who has no insurance at all, that makes a lot of these conventional treatments out of reach. And I work at a university that oftentimes can get these treatments regardless because of charity fund that we have to support our uninsured patients. But this is a lot of times a big problem. Second, if you just look at the scans that we have to do for people, PET scans can be upwards of $2,500. Full body CT scans can be upwards of $2,000. And these are things that we do for people every 3 or 4 months while they're on treatment, and sometimes every 3 to 6 months when they're in their survivorship journey. And this can add on to the cost of care, and it might lead to somebody stopping with their surveillance scans. And then the newest player on the block for us is cellular therapy, specifically tumor infiltrating lymphocyte therapy with lifileucel. And I have several patients that have gotten this treatment. I think that it is really the right choice for many people, but it can cost upwards of $500,000 for that 2-month journey of getting that particular treatment. This puts certain kinds of treatments, even though they're phenomenal, out of reach of certain patients. And I think we really do need to appreciate that. Even if a person has insurance, they have a cost burden that could lead to them draining their financial resources. It could lead them to drain their retirement accounts or long-term savings in order to get treatment. And a survey that was done of cancer survivors, it was shown that 51% carry balances over $5,000 in United States dollars, and 2/3 of them hold their debt for more than a year. And this just goes to show that even if a person has insurance, they may take on a significant amount of debt in terms of co-pays and co-insurance costs for both scans and for treatment, that even when their cancer is done or their cancer treatment is done, could lead them with a really big burden of debt that can take them a lifetime to overcome. And so this is one of the long-term potential financial toxicities of conventional melanoma treatment, is that you have people that are needing to use all the resources they have, even despite insurance, in order to get their care covered. And this, understandably, and I have this conversation a lot with patients, causes a lot of stress because they say, gosh, I know it's the start of a new year. I'm still on treatment. I'm back at $0 with my yearly maximum for my out-of-pocket costs for my insurance product. And I just can't afford that because I have rent to pay or a mortgage to pay or I have costs for my children. And I think that all of us, it's incumbent on all of us to be thinking about how that impacts them here in this moment and how that could impact them for the remainder of their lives as long-term survivors of melanoma. The treatment costs are a known burden for people with melanoma, but I think that younger patients who become survivors are impacted even more because they have such a long time horizon between their treatment and the end of their natural lifespan. And this can affect their quality of life significantly. Insurance worries remain among one of the top concerns of people with cancer, and this includes people with melanoma. And unfortunately, we don't do as good of a job as we could at talking with our patients about this. Only 28% of patients reported in one such study that their healthcare team spoke with them about the financial costs of their treatment, and 42% desired help with financial assistance with their treatment. And the financial impact was associated with an increase in distress for people, especially with a net income below $60,000 because of their cash-strapped financial resources. And these numbers really have a big impact on me. In this study, 57% of people reported depleting their savings completely in order to get cancer treatment. 20% borrowed against their retirement accounts. Another 20% needed some financial assistance from a pharmaceutical company. 13% skipped taking medication dosages like targeted therapies because they just couldn't afford the next prescription, and 17% postponed filling prescriptions entirely. So the financial toxicity of conventional melanoma treatment can be appreciable. A second toxicity that I think we should think about is that immunotherapy, checkpoint inhibitors that we use all the time as people who see and treat people with melanoma, can have lasting long-term negative side effects on a person. In this study that I cite a lot with my patients, we see that there are a variety of possibilities, and you'll see a talk later today specifically on immune-related adverse events. IRAEs, as we call them, can happen anywhere. This little heat map shows the kinds of immune-related adverse events that are most common. Skin and mouth toxicity is by far most common, followed by GI toxicity. And the heat map, the blue circles show you the areas where you have the highest incidence. So the bigger blue circles are a higher incidence, and then the red on the heat map is where you might have grade 3 and grade 4 toxicities in those domains. And what I have appreciated with the people that I treat is sometimes they'll get an IRE like a chronic rash or arthritis or intermittent diarrhea or thyroid dysfunction that's permanent. And even though their treatment comes to an end and their scans look really reassuring, the cancer has subsided, they may still keep some of those side effects, like the arthritis or like the primary hypothyroidism, for the rest of their lives. And if we counsel our patients ahead of time that these are possibilities, I think that it is a little bit easier to kind of stomach and for them to say, okay, I knew this was a possibility. But I think even then, when you have somebody that could be on and off steroids or some kind of immune suppression strategy for years or even for the remainder of their life, that becomes a big life-changing thing that I think we as people who treat melanoma should certainly be thinking about. There are a number of immune-related adverse events that become chronic and can last more than 12 weeks. And this is yet another heat map from a more recent study that shows you what those toxicities are. Of course, when we have somebody who has primary hypothyroidism from checkpoint inhibitors, we know that that's going to be a long-term chronic change. And so 40% of the people who have chronic IRAEs are endocrine in nature. It could be hypothyroidism, it could be adrenal insufficiency, et cetera. And then 18% are going to be skin. And then I would say I have an appreciable number of people who have arthritis that they have to be on long-term low-dose steroids or intermittent steroids in order to treat flares that happen along the way. These can understandably be life-changing things. There's also other chronic effects of melanoma treatment that I think are certainly necessary for us to think about. People can get chronic pain syndrome, sometimes from an immune-related adverse event. They can have their mobility impaired, not just from the drugs that we give, but maybe from the surgeries that they've received, or if they've got lymphedema in an arm or a leg because they had at one point a lymph node dissection. That may be a really big impact on their quality of life, even after medical treatments are over. Sometimes if they have a hereditary risk syndrome, like a high-risk genetic mutation, like the CDKN2A mutation that increases the risk of future melanomas, that causes a lot of stress. What I've noticed in many of my patients who have had histories of melanoma is that they now have a fear of sun exposure, and it really affects their ability to go outside and do things and work. Some people have a struggle to maintain gainful employment because of all that they've been through. And people really report a nature of scanxiety, where they worry about that next scan, and they worry about the shoe to drop, where the next scan is going to show some bad news that hasn't been there in a long time. There's also potential reproductive health effects of immunotherapy. We know that checkpoint inhibitors in a minority of cases can cause primary and secondary hypogonadism. There can be a toxicity to a fetus. I have had one patient who was pregnant while also needing to get treatment for melanoma. And this can be a problem because checkpoint inhibitors can cause placental failure. And then third, checkpoint inhibitors can affect long-term libido, especially by affecting the sex hormone axis. And this is something that I think all too often we're not thinking about because we just are so happy for our patients that they have overcome melanoma. And the fertility implications for men and women, I think, we're thinking about. People who have received immunotherapy who are men may have some libido or sex hormone changes. For women who are of reproductive age, we should certainly be talking to them about means of contraception because of the risk to a fetus and a placenta because of checkpoint inhibitors. And there might be some long-standing effects of checkpoint inhibitors on future fertility. And then the next domain of financial and overall toxicity to a patient with melanoma is their mental health. People experience depression, anxiety, fatigue, and cognitive concerns because of both the worry about melanoma and the treatment journey, and sometimes even the survivorship journey. Worrying about late recurrences can also add to the anxiety that people face. We do scan or surveil people for 5 years, and what that surveillance looks like in years 2 through 5 for a person with stage 3 and stage 4 melanoma involves an informed conversation. But what happens after this? A study that I participated in that I've cited on the slide below, we found that late recurrences do happen, especially with people with early stage melanomas, and they often will present with symptoms like respiratory symptoms and neurologic symptoms. And so how do we counsel a person who is through their treatment journey, but still 5, 10, 15 years later could get a recurrence? And that is something that I appreciably realize that many patients do worry about, because we know late recurrences happen. But today is not just about the bad news and the financial toxicity of melanoma treatment. There is good news. And I think you will see this slide as a part of other people's presentations, which is that the good news is that, especially in the area of checkpoint inhibitors, long-term overall survival has improved, especially with immunotherapy. And if you look at the cohort in the ipilimumab, nivolumab combined treatment group with over 10 years of data, you've got people who are long-term survivors. Half of people could anticipate to be long-term survivors with these conventional treatments. So I think that we do need to manage and mitigate the anxiety, the financial toxicity, the long-term IRAEs that come from these treatments, but it's certainly worth it in the long term for many patients. And overall survival remains really, really good, especially in this cohort treated with ipilimumab and nivolumab. So important considerations for melanoma survivors are that people with advanced melanoma are living longer than ever before. That's amazing. The potential long-term negative effects can include impacts on mental health, reproductive health, and overall quality of life. And how do we mitigate these risks? Well, one is through research and education, and you're going to hear a lot of talks in this path today. The Melanoma Research Alliance does some really excellent research in this space. The Melanoma Research Foundation does some excellent research in this space. There are community organizations and community-based organizations. Aim at Melanoma is one that I've worked with a lot. The YMCA Livestrong program provides a lot of resources for melanoma survivors. And there's also local survivorship clinics. At the University of New Mexico, where I am, we have a really excellent survivorship clinic that provides resources and sometimes even a primary care home for people who have survived beyond 5 years. Everyone, all doctors, all healthcare providers should maintain a high suspicion for late IRAEs, immune-related adverse events. And then all of us should be aware of and should be talking with our patients about the potential costs and financial toxicity of the drugs and the treatments that we're proposing for them. And we should look for strategies to help people who need it find financial assistance resources so that they're not draining their long-term retirement or their long-term savings in order to get the treatments that we have recommended to them. So again, for the organizers of this meeting, I want to say thank you so much for including me in today's agenda. I want to say congratulations to those who are watching who may be a melanoma survivor or a person who is undergoing the melanoma treatment journey right now. And for those healthcare providers who are listening, I really hope you found something useful out of this. I have my email address here, dasavage@salud.unm.edu, as well as my web address, in case you'd like to reach out and continue a conversation beyond today's presentation. Thank you.
Thank you, Dr. Savage, for this insightful presentation. We're now honored to welcome Dr. Rebecca Hartman, Associate Professor at Harvard Medical School, Director of Melanoma Director of Melanoma Epidemiology at Brigham and Women's Hospital, USA, and Chief of Dermatology section at the VA Boston Healthcare System. Dr. Hartman will present on novel diagnostic technologies, including AI. Thank you for joining us today. Please go ahead.
Great, thank you so much. Oh, perfect, you can see my window. So I'm very excited to be here today to speak to you about novel diagnostic techniques in melanoma. I have the following disclosures, none of which are relevant to this talk, except I'm an uncompensated advisor for Lumo Imaging. I will be talking about their device, and I also have served as PI for in clinical trials for some of the devices used that we'll discuss. So I'd like to speak first about FDA-approved devices and then talk about emerging technologies in melanoma detection. So the problem we face is that early diagnosis of melanoma improves prognosis and reduces morbidity. However, many benign lesions are biopsied to detect one melanoma. A recent systematic review estimated it can be almost 8 lesions for dermatologists, 13 lesions for dermatologists combined with advanced practice providers, and nearly 15 lesions for Australian primary care providers. We know that 5-year survival is significantly improved when melanoma is caught early. Localized survival from the SEER database is almost 100%. But if melanoma is caught at a distant stage, survival prognosis is much worse. So we want to detect melanoma early. And there are also several studies to show that it can be hard to get in to see a dermatologist in the US. Wait times can be high, even for a changing mole. And this is worse in rural areas where there's a lower distribution of dermatologists, and that waiting in and of itself can be a source of patient anxiety. So getting answers sooner can help reduce patient anxiety. So we'll talk about FDA-approved devices to try and address this gap. The first one I'd like to talk about is electrical impedance spectroscopy. This is a device that uses an electrical impedance spectrometer and an AI algorithm to determine if something, to decide if something is likely melanoma or not. The indication, it's approved in the dermatology clinic. It was recently expanded to be used not just by dermatologists, but also by advanced practice providers working with the dermatologist. It has very high sensitivity of almost 97%, but like many of these devices, the specificity is worse at about 34%. And it's quite expensive. So the cost of the device is $7,500, and there's a $50 consumable tip for each use. There is a code, a Medicare billing code that can be used to try and get reimbursement with the device. And the graph on the right is just showing the different spectral scores for different lesions. So you can see, especially for more aggressive melanomas, there's a very big difference. Try to get my pointer. A very big difference in the score over here for T3, T4 melanomas, even for T1 melanomas compared to a benign nevus. So the goal is to use this score to help in the decision making if something is a melanoma or not. And again, this device uses electrical impedance as well as AI. So the device is called Nevisense, and the FDA approvals indicated that the device is approved for when a dermatologist, or as I mentioned, recently expanded for an APP in a dermatology office, wants to obtain additional information when considering a biopsy. However, it should not be used on clinically obvious melanoma, and the result is one element of the overall clinical assessment. So it's not like a standalone test to determine if something's melanoma or not. It's another tool in the dermatologist toolbox to help with their decision making. And then there's another FDA-approved device. This one I was part of one of the clinical trials for that uses elastic scattering spectroscopy. So this involves shining photons into the skin and then seeing how they return back. And the path with which they return back can indicate what's underneath the skin. And then it also uses AI to try and re-stratify. And this curve is just showing the different results for different types of lesions, the red being the red being malignant and the blue being benign, and showing that you get different spectral curves depending on the lesion type. So as I mentioned, it uses elastic scattering spectroscopy and an AI algorithm. It's FDA approved for primary care physicians, not for dermatologists, for skin cancer detection. And again, the sensitivity is quite high at almost 96%, and the specificity is lower at 33% for melanoma. the cost, it's based on a subscription that the primary care provider signs up for, and I'm not currently aware of a way to get this further reimbursed. So that is problematic. The primary care provider has to agree to pay these costs. And then the result is given as a score. So it can be monitor if it favors a benign lesion, and then any score basically from 1 to 10 can be given for investigate further, meaning refer to a dermatologist. And if the score is high, like towards a 10, then there's a higher suspicion that something's malignant. This was a table from the study that we conducted with this device showing the test performance for high-risk melanocytic lesions. And again, this shows the sensitivity and specificity that we mentioned, as well as a high negative predictive value of 98%, which is useful in a rule-out device, a lower positive predictive value of 16%. So less likely, if it's positive, to necessarily be a melanoma, but still to warrant a referral to a dermatologist. And this was interesting looking at the device performance for the area under the curve of the ROC. We can see actually that it performed no different than the dermatologist in this specific study, where we looked at pigmented lesions in a referral, tertiary kind of referral centers. But you can see the area under the curve was similar for the device and the dermatologist, both for the outcomes of melanoma and melanoma combined with severely dysplastic nevus. I think one challenge with these studies is it's hard to know what is the gold standard of the outcome, since there's diagnostic uncertainty with the histopathologic diagnosis of melanoma, and so there are some gray areas. So anyway, they looked at two different outcomes, melanoma alone and combining it with severely dysplastic nevus. This is showing the spectral scores that I mentioned, that you can get a 1 to 10, and a higher score is more predictive of a malignant lesion. So for melanoma, if they grouped the spectral scores, when they looked at 6 to 10 lesions that had a 6 to 10 score, the positive predictive value was much higher. It was 32%, and lesions 8 to 10, it was nearly 50%. So a high spectral score, is more suggestive of a melanoma and would potentially could warrant more prompt referral to a dermatologist and earlier diagnosis. This is the FDA approval of this device. It's actually approved for all skin cancers, not just melanoma, or I shouldn't say all skin cancers because they're rare skin cancers, but it's approved for melanoma and basal cell as well as squamous cell in patients 40 and above. That's because the pretest probability of having a skin cancer is higher in someone who's older. And it's used to decide to refer someone to the dermatologist from a primary care physician who's not a dermatologist. So it's not approved for advanced practice providers, and it's not approved for dermatologists. And again, they have kind of similar to the Nevisense approval, the DermaSensor device should not be used as the sole diagnostic criterion. And this was just showing, as soon as it was approved, I had a colleague that knew I worked on the trial, and he had gotten one of the devices to play around with, and he showed me this photo of an obvious kind of large melanoma with a large radial component. And he put the device on the lesion and it missed the melanoma. But again, kind of like the Nevisense, we don't want to use it on lesions that are obviously melanoma. It's intended to be used on lesions that are indeterminate. And specifically in the approval package, it's not meant to be used on lesions that are wider than 15 millimeters in diameter. And this is because the device has a little teeny tip. You put it on 5 times in the lesion. And if the lesion's so large, it can't really get a good sample of the whole lesion. Okay, let's talk about, so those are the 2 FDA approved technologies. Let's talk about emerging technologies. This is from a company called Orlucent. It uses skin fluorescent imaging. So it involves a topically applied RGD peptide that binds to an integrant in the skin. And then fluorescent photographs are obtained and analyzed also using AI. And this is showing from a trial lesions going from, a benign nevus to an obvious melanoma, and seeing the difference in the fluorescence photography when this topical is applied. It gives a score similar to the other devices, and depending on the cutoff used, it affects the sensitivity and specificity. So the sensitivity with both of these proposed cutoffs is a little bit lower, but what you'll see is the specificity is much higher than the other devices I mentioned. So that's a plus in terms of high specificity is good for ruling in a melanoma, right? High sensitivity is helpful to rule out. So the specificity is much higher. And this is again showing the different scores, the fluorescent scores with this photography and AI interpretation. It's clearly different among melanomas and lesions with high-grade dysplasia compared to benign lesions. So more to come. I think they need to do more clinical studies and go down the approval pathway, but hopefully this could be another technique in our toolbox to diagnose melanoma. And then I want to talk about liquid biopsy, which is very popular in the press right now. There are these multi-cancer early detection MCED tests. What they do is they're looking for circulating tumor DNA in the blood. So the tumor gives off parts of DNA, and it can, in theory, be detected from a blood sample. And these tests are built to detect many different types of cancer, but it seems like they're not very strong performers for early diagnosis of melanoma. And again, that makes sense. If there's nearly 99% survival with localized melanoma, there's probably not a lot of circulating tumor DNA. The tumor is localized. It seems like the utility is high, has been shown to be higher in melanoma specifically. I'm not talking about for other cancers, but in melanoma specifically for prognostication and relapse predictions. So there were a couple of recent studies looking at later stage disease or more advanced stage disease, and then looking at prognosis when there's circulating tumor DNA present. And there's so much worse prognosis for having a relapse, basically, with hazard ratio here of about 3, and here even higher, 25. So I think that is currently where this technology has more promise, is in terms of detecting relapse and prognostication, not necessarily for diagnosis in someone who's asymptomatic. Because again, with such a localized tumor that has such an excellent prognosis, we wouldn't expect to have high levels of circulating tumor DNA. And then let's talk about smartphone applications. So there are actually a ton of applications that patients can just download on their phones and take a picture of a mole. This was a relatively recent review looking at these applications, and it found a lot of concerning features. So nearly all of them lacked supporting evidence or had disclosure on their approval status. Nearly half in the light blue didn't have dermatologist input. And nearly half also, or more than half, I'm sorry, didn't have dermatologist input, and nearly half didn't specify what they do with user images. So this study looked at 41 different apps, and I think basically I wouldn't recommend them to patients. There's not enough supporting evidence. We don't have data on how they're used. We don't have clinical data or studies, prospective studies to look at their performance. So to me, it's concerning that they're out there and patients are using them without this data. But that doesn't mean there's no potential for AI and image analysis. I think that's actually been very well shown at this point, especially looking at retrospective images of dermoscopic images.
Excuse me, Dr. Hartman. It seems like the slides aren't working well. Is it possible to reshare them?
Sure. Sorry about that. Let me try again. Is that better? Oh, screen sharing is not allowed. Huh. Not sure what the solution is. I'll try again. Can you see it now?
It seems like it isn't shared, but if you could change it like manually, it would be great.
Can you see now?
Yeah, we can see the slides. Yeah, it's great. Thank you.
Okay. Sorry about that. Thank you for letting me know. So there's a lot of data to suggest that AI can diagnose melanoma on images, especially dermoscopic images, very well. So our dermatoscope is a device we use that magnifies and polarizes the skin to help us see kind of structures underneath the skin and at the surface. And there's a lot of studies that suggest AI can perform better than the dermatologist. And there are also a lot of studies on retrospective data to show that AI can help clinicians when they work together. So this study looked at AI for telemedicine support in dermatology using dermoscopic images. And what you can see here, all participants is just the baseline. And then when they added the neural network or the AI, that performance overall improved. And the greatest gains are seen among people with less experience. So for those with less than 1 year experience, the AI made a big improvement. For those with more than 10 years experience, the AI didn't make quite as big an improvement. So I think the potential is definitely there. And more studies are coming out showing this. This was a really recent systematic review and meta-analysis that focused on prospective studies, which I think is really important because we have a lot of retrospective studies, but what we really need is prospective studies. What happens in the clinic when we bring this into the clinic to make sure that performance is robust, that it's reproducible, right? Just like with any of the devices I showed you, they had to go through FDA approval and demonstrate their device was reproducible. It would show the same result on the same lesion, and it was accurate across multiple lesions. So anyways, these are prospective clinical trials, and the brown is the AI, the blue is the dermatologist, and the last bar is the dermatologist plus AI. And we can see that kind of test performance metrics are better across most of these when the dermatologist is combined with the AI. The caveat is the dermatologist plus AI was done out of only one study, which I'll talk about in a moment. But overall, these findings suggest that the AI systems perform at comparable level to dermatologists in melanoma diagnosis, and they may enhance performance when used as a decision support tool. But there's still a very small number of studies with a lot of bias and limited generalizability, so they still need broader validation, I think, in larger populations. And this is the Prove AI study, the prospective study that I was mentioning. It was done by colleagues at Memorial Sloan Kettering. They prospectively enrolled those undergoing a skin biopsy to rule out melanoma, and they looked at dermatologist management pre and post AI on dermoscopic images. And what they found was kind of similar to the devices I highlighted earlier. Sensitivity was quite high at 97%. Specificity was lower at 37% with the AI alone. When they did the AI plus derm, the performance was actually slightly worse than just the AI alone, with sensitivity at 96% and specificity at 34%. What this would amount to, if implemented in the clinic, was avoiding skin biopsy in nearly 30% of cases, but 4% of melanomas would be missed. We have to decide if that's a trade-off that we feel is acceptable. It seems reasonable to me. And that the test performance, the area under the curve, was better post-AI than pre-AI, 0.82 post-AI and 0.78 pre-AI. These are just showing the area under the curve. As you can see, actually, the purple, the AI alone actually did the best. And then the orange, the AI plus dermatologist, was second best. But this was a really, I think, well-done study. It was prospective. It really evaluated what would happen in the clinic, and we need more studies like this to be able to move this forward, I think. And then looking more closely at the data, there were some differences in specificity. Specificity was worse in older patients, head and neck lesions, large lesions, and lesions with photo damage. So perhaps that, clouds the picture for AI image analysis. And then the device or the technology, the AI, was most helpful in this area in discerning, which is kind of the area we want, in discerning nevi from with atypia and benign nevi from melanoma. It's not as useful if we already favor like an obvious melanoma, right? Or they also looked at other outcomes for non-melanoma skin cancer. But this is probably where you want the device to be helpful, to avoid biopsies of benign lesions, because I mentioned at the beginning we're biopsying like 9 benign lesions to pick up 1 melanoma. And then I think the next step is moving from a lesion basis of AI to kind of total body imaging to automate kind of the skin screening exam. So this was a study, they didn't involve AI, they just did total body photography using this machine called the Vectra machine, which has 96 cameras and can take full body imaging in 3D. And they looked at if this made a difference in skin cancer outcomes when patients underwent the full body imaging. And what they found was not surprising, that patients who underwent the intervention had more things cut out. They had more benign things cut out. And they actually didn't see a difference in the number of melanomas per person. However, they did see a difference in the incident rate of melanoma over time, in that fewer melanomas were diagnosed in the intervention group. So that potentially suggests that the intervention is diagnosing kind of precursor severely dysplastic lesions. And I think more data is needed. And you can see here the blue line, the control group, and the orange line, the intervention group. These, again, were not statistically significant, the mean difference in number of melanomas, but over time, but you do see the curve separating. So I do think potentially with larger data sets of more follow-up, you may see a difference. And then they saw a lot more non-melanoma skin cancers and keratinocyte carcinomas diagnosed. And when the United States Preventative Service Task Force made their recommendation of insufficient evidence to do routine screening for melanoma, they saw the keratinocyte carcinomas as a downside. I guess they felt like they aren't likely to kill someone and you're doing more procedures. So that is something to consider. And then I think the next step, again, building on this, on the lesion basis, is multimodal AI, where we don't just use the dermoscopic images, but we use multiple different data inputs. So you can use the 3D total body photography images, you can use clinical images, and you can use dermatopathology images. And this group out of Australia found really impressive performance. So the AI doesn't tend to do as well on clinical images, like from this total body photography device. The sensitivity was only 71%, but when they added in the metadata, it almost went up to 90%. And it actually outperformed humans by 10% in looking at melanoma detection on sequential digital dermoscopic imaging, and enhanced clinician accuracy as well on dermoscopic melanoma detection. These are, again, not like, it was not prospectively trialed in a clinical setting, which I think is the next step. This was all kind of on images shown as a test, but I think this is quite promising. And again, it had similar accuracy for skin cancer diagnosis for AI alone versus human collaboration. And the other cool thing was that the AI actually was helpful to predict outcomes. So there's a lot of different studies being used to try and predict melanoma outcome. There are different genomic tests you can order, but the AI was able to distinguish a low risk group for recurrence and a high risk group. And the AI metastasis prediction had a 5.6 hazard ratio, much higher than other features in staging like thickness and ulceration that we think about. So I think the ultimate goal is if we can combine total body imaging with AI and ideally multimodal AI. And there actually are several devices coming to market. This is one from Lumo Imaging, who I work with. This is another company, Square Mind, that has a Swan device. And then this was published in JAMA Dermatology, the DeviScan, a device out of Spain. And all three claim to be able to image total body photography with near dermoscopic quality. So I think that's quite promising. So in conclusion, it's a rapidly changing landscape. There are 2 currently FDA-approved devices for melanoma detection with many more on the way. Non-experts benefit the most from AI. AI currently performs very well at the lesion level with dermoscopy in controlled settings, but there's promise that multimodal AI can improve performance on non-dermoscopic images. And there's also promise that integrating total body photography with higher level image quality will allow us to kind of get to the next level of being able to use AI to help patients detect melanoma on a full body basis. We really need prospective randomized controlled trials, though, and real world data, just like we would for any other device, to make sure that the device is reproducible in terms of its output and that it performs well in the clinical setting. And I'd like to thank you so much for your time and thank my funders. I really appreciate the opportunity to speak to you today.
Dr. Hartman, thank you very much for this interesting and amazing presentation. Now we welcome Dr. Andrea Boutros, who is a medical oncologist and assistant professor at the University of Genoa, Italy.
Hello everyone, can you hear me?
Yes, we can hear you.
I'm proceeding with sharing my screen. Let me know. See, there are some apparently some technical issues.
It's okay. Can we help with anything?
It says I need to update my system permission to allow my screen recordings. Not sure how we do it. If you know if you have any advice,
We can go on a small break while this issue is resolved. Is it okay with you?
Yes, sure, thank you.
Thank you, Dr. Boutros, for staying with us. You can proceed with the presentation.
Hi everyone, so I think you can now see my presentation in full screen. My name is Andrea Boutros. I'm a medical oncologist and assistant professor at the University of Genova in Italy, and I work in the skin cancer and melanoma unit in the San Martino Hospital. And I'm very glad today to present you some of what we do today with the neoadjuvant immunotherapy for resectable melanoma. This is a very important topic in melanoma because we used to have adjuvant immune therapy for high-risk resected melanoma, and these are the main data we used to base our clinical practice on. So we can see nivolumab, pembrolizumab, and dabrafenib and trametinib, 1 year adjuvant treatment after resection of high-risk melanoma, which means mainly stage 3. We also do have adjuvant immune therapy for stage 2 melanoma, but mainly stage 3. From stage 3A with deposit in the sentinel lymph nodes major than 1 millimeter to stage 4 resected melanoma for nivolumab. As you can see, adjuvant therapy gives you an absolute benefit of around 10 to 12%, 10 to 15% in relapse-free survival. However, no one of these adjuvant treatments have ever proved any overall survival benefit. As you can see, also immune therapy can cause chronic side effects, can cause mainly adverse events, immune-related adverse events in around 10 to 15% of the patients, with up to 25% of chronic endocrine disorders, which is very important to take into account when we offer this treatment to patients. And in the COMBI-AD studies, we had dabrafenib plus trametinib adjuvant therapy also for 1 year, same benefit, but with a quite high treatment discontinuation rate, mainly due to pyrexia fever, which is quite impacting side effects. So, just to recap, adjuvant is a post-surgical treatment, mainly immune therapy, but also for BRAF V600 mutation, also target therapy, 1 year long treatment with some improvement in relapse-free survival, but not really in overall survival. So what was the revolution after that? That was the neoadjuvant immune therapy, the introduction of neoadjuvant immune therapy. As you can see from the cartoon at the sides, at the left side, you can see that when the tumor is on site, the immune therapy with the immune checkpoint inhibitors, anti-PD-1 or anti-PD-1 plus anti-CTLA-4, can better enter into the tumor microenvironment and enhance the systemic immune reaction. Also, after surgery, we can objectify and see with pathology the response rate. So we literally know when it worked and when it didn't, which is a very important advantage compared to adjuvant immune therapy. As you can see on the right side, we do the treatment after surgery, so we do not have any macroscopic melanoma left there to help the immune system enhancement and reactivation. So these are results of limited systemic surveillance. So based on this rationale, 2 main studies were designed. The first one is the SWOG 1801 study comparing adjuvant standard treatment with 1 year of pembrolizumab compared to neoadjuvant pembrolizumab given up to 3 cycles before surgery and followed by 15 cycles of pembrolizumab to complete 1 year of therapy. And patients were eligible if they had stage 3B to 4 resectable melanoma. The primary endpoint was the event-free survival. As you can see, there are some difference in the definition of event-free survival compared to the second study, the NADINA study, which is quite more interesting in the study design because it included a similar population, high risk resectable, stage 3 melanoma, randomized patient to receive standard surgery to the all the nodal basin, which is therapeutic lymph node dissection, followed by 1 year of anti-PD-1 with nivo in this case therapy, or 2 courses of neoadjuvant nivolumab plus ipilimumab, and then surgery, and then based on the pathologic response rate, we could have or just follow-up, so no treatment, no more treatment in case of major pathologic response, and I will show you what does that mean exactly, or in case of non-major pathologic response, we had subsequent courses of nivolumab to complete 1 year of treatment, or in case of BRAF V600 mutation, dabrafenib and trametinib. As you can see, event-free survival was as well the primary endpoint. The definition of the event was disease progression, precluding surgery, recurrence after surgery, or death from any cause. So these are the 2 studies. On the left side, the pembrolizumab SWOG 1801 study. On the left side, the nivolumab, ipilimumab, NADINA study. As you can see, dramatic improvements in event-free survival in both cases. But what about the pathologic response? And we will talk about the meaning of pathologic response better later. So you can see with the pembrolizumab, we had around 38% of pathologic complete response, with the major pathologic response of the 53%. This is an impressive result because with only 3 cycles of pembrolizumab, we had around 40% of patients with no residual disease left, and a toxicity profile of around 20% of grade 3 and 4 immune-related adverse events, which is quite similar to the adjuvant previous studies. As you can see, pathologic complete response and near pathologic complete response were highly associated with overall survival, which is very, very impressive result. In the NADINA study, we had the benchmark that we have today is around the 60% of major pathologic response. So around 60% of patients could achieve durable benefit in their lives, and that's also very interesting information we can see here. Based on the response, we have completely different prognosis. As you can see here, around 98% of patients with no distant metastasis compared to 55 in patients with no pathologic response. So once we know that, we need also to underline something very important, that the meaning of pathologic response is not the same between immune checkpoint inhibitors, which is highly related to long-term benefit, and BRAF/MEK inhibition, where the values and the rates of survival curves are quite similar to what we see with adjuvant BRAF/MEK inhibition. So when we talk about major pathologic response and the hope for a durable benefit, we only talking about immune checkpoint inhibition, neoadjuvant therapy. So how we can implement neoadjuvant immune therapy in our centers, in our sites all over the world? First of all, we need to know the definition of the International Neoadjuvant Melanoma Consortium. PCR, or pathologic complete response, means 0% of residual viable tumor. MPR groups both pathologic complete response and near pathologic complete response, which means residual viable tumor of less than 10%. Pathologic partial response means residual viable tumor of 10-50%, and pathologic non-response means more than 50% of residual viable tumor. So what clinicians should do before sending histopathology for analysis? They at least should clearly indicate that the patient received neoadjuvant immune therapy. At least it would be impossible to analyze the entire tumor bed. And as you can see here, what we should receive is in the pathology report should be the rate of viable tumor, the rate of tumor melanosis, if it's present or absent, and their extent on the tumor bed, which is defined as the previous tumor bed minus the other areas of viable tumor, necrosis and fibrosis. So the sum of the four components, viable tumor, necrosis, tumoral melanosis, and fibrosis, should be equal to 100% of the tumor bed. So that's very, very crucial, and that's very important to assess in all our pathology departments, and as oncologists, and mainly as oncologists working with melanoma patients, we should ensure this is available in our centers to be able to stratify patient prognosis. So what if we do not have an available pathology for assessment? Maybe we do have a PET or FDG PET metabolic nuclear medicine or nuclear medicine division. I say that because in a recent study published in the Journal of Immunotherapy of Cancer, we assessed that we can see that the metabolic response is highly related to the long-term outcomes. As you can see here, around 92 to 100% of recurrence-free survival in patients with partial and complete metabolic response. That's a huge difference if compared to RECIST CT scan response, where this correlation is not really accessible because most of patients only have stable disease as per RECIST criteria. So that's very important tool we can use in our clinical practice if we do not have access to pathology. I just want to finish with one important study, the Prado study. This is actually very interesting and should be implemented soon with an ongoing study called MSLT3, where neoadjuvant regimen similar as the Nadina one was administered, and but patient did not undergo total or therapeutic lymph node dissection. They only underwent index node resection. The index node is a node we identified at baseline and we marked, and then we resected after neoadjuvant immune therapy, and only based on the pathologic response in the index node we could stratify our treatment. So in case of major pathologic response, patients did not even receive complete lymph node dissection nor adjuvant or post-surgical treatment. That's very interesting study, and it showed amazing results, similar as in the Nadina study, 60% of major pathologic response, and patient with major pathologic response also achieved around 100% of melanoma-specific survival and relapse-free survival. So just a case example, this is one of my patients I treated in Italy. The patient is a 76-year-old. He presented in January 26 with this huge lesion with bilateral lymph nodal involvement in bilateral axilla. And we started the Nadina regimen with the ipilimumab and nivolumab as per Nadina protocol. Patient received only one cycle because at pre-cycle 2 visit it reported a low-grade colitis, and I didn't want to risk any complications or high-grade colitis, so we decided to withdraw treatment. But after a few weeks, the lesion continued to shrink, and the FDG PET assessment showed a major metabolic response. And the pre-surgery and the lesion, the main lesion, was completely gone. Patient then underwent surgery on the primary, and on one index node we had this predefined at the baseline, and the patient achieved eventually a pathologic complete response and is now on clinical follow-up on active surveillance. So I just conclude with some take-home messages. So in stage 3 resectable clinical stage 3 melanoma, neoadjuvant immune therapy is better than adjuvant. That's because of many biological features that allow our immune system to better recognize the tumor. And we have two options for neoadjuvant: anti-PD-1 monotherapy or combination anti-CTLA-4 plus anti-PD-1. The choice of neoadjuvant therapy should never be driven by the center's willingness or ability to perform pathologic response assessment, but should be based on clinical and pathological features and molecular features. PET is a very good surrogate for pathologic response and for RFS. So if we have PET, we encourage using PET. Also, surgery should be or may be escalated in selected cases, also as well as post-neoadjuvant treatments, as shown in the Prado and in the Nadina trial. And yes, of course, the post-neoadjuvant and post-surgical treatment should be really assessed case by case in our multidisciplinary teams. For example, for patients with the major pathologic response, we probably could avoid adjuvant treatment, or in case of non-pathologic response, we may change strategy in, for example, BRAF V600E mutant diseases. And I thank you for your attention, and I am open to any question.
Thank you, Dr. Boutros, for this amazing, insightful presentation.
Thank you very much.
Now we'll take a short 5-minute break. Thank you for staying with us. We're back, and now we welcome Dr. João Paulo Lima, medical oncologist in the melanoma unit at AC Camargo's Cancer Center, Brazil. Dr. Lima will present on personalized and viral-based immunotherapies. Thank you for joining us today. The floor is yours. Excuse me, Dr. Lima, I think the camera and the sound is not on. We can't hear you yet.
Sorry, my bad.
Yeah, no, no problem.
Okay, sorry for that. So those are my disclosures, and I will briefly discuss personalizing viral therapy in melanoma. And I understand as personalized medicine two different topics. One is tumor infiltrating lymphocytes, adoptive cell therapy. You already had a very excellent presentation on this topic, and I hope now I will add a bit more on a medical oncologist perspective. And tumor infiltrating lymphocyte is rather very interesting, but not new. It's an established idea from the 80s, but it has had many hurdles to cross. So we need to extract live lymphocyte, then so we need live tumor, fresh tumor, so it's not easy for being performed in every single cancer center or in general hospitals. Those lymphocytes, they need to be selected and expand ex vivo and extremely demanding. Very few sites worldwide can do that. Then those lymphocytes need to be reinfused on the person, and they need to have room for the growth. So then the patient needs to go for a non-myeloablative chemotherapy regimen, which is rather toxic. And after that, the patient will receive high-dose interleukin-2 to improve the lymphocyte survival. Then it's not a trivial therapy. And once we harvest those lymphocytes, try to increase their numbers and improve their efficacy, what sort of lymphocytes we received after all these ex vivo procedures? In general, you can receive 3. It's a bystander T cell that's just reactive to virus infected cells, which is not relevant for the melanoma or cancer control. A second type, it's a lymphocyte that's reactive to share antigen. That's relevant because it can target non-malignant cell, then it can cause graft-versus-host disease or other autoimmune issues. And finally, we've got T cells that are reactive to new antigens, and those are the ones that are willing to have as much as possible because they're the ones who's gonna do the trick to try to control the cancer. And they must recognize the new antigens from the cancer cells. There are ways to increase for these specific lymphocytes. It's called screening selection for new antigen recognition. There isn't yet a published melanoma trial with this approach, but there are at least 2 on colorectal and esophageal cancer with very interesting results showing that further selection of T cells is something that's quite promising. And going for prospective evidence. Before going to number 1, 2, 3, describing what are the steps of the 2 retrieval, improvement, enhancement, and infusion, we need to ask ourselves from the medical oncologist point of view, who are the candidates? In general, those are patients with relapsed disease that may have at least 1 lesion unable to resection that can be fresh frozen and sent to central lab to retrieve the lymphocytes. And also, those patients are not in need to urgent therapy. Some newer trials are trying to bridge the gap between the time from having the lymph nodes, the lymphocytes removed from tumor to the infusion. So you need to bear this in mind that not all patients will be eligible for TIL therapy. And we've got two trials, one prospective randomized trial and a one phase 2 trial. Both trials led to approval in their original countries. This one I'll discuss is a Dutch trial, M14-TIL randomized trial, which selected melanoma patients with stage 4 or unoperable stage 3, whose patients had a melanoma which failed at least one line of therapy, either adjuvant therapy or first-line therapy. They had not received previous ipilimumab. They had at least one lesion resected of 2 centimeters that will be used to retrieve the lymphocytes. They must have residual RECIST 1.1 disease, and they were fairly fit. And they were randomized to standard ipilimumab 3 milligrams per kilo, 4 infusions every 3 weeks, or the sequence of tumor resection, non-myeloablative chemotherapy, 2 single infusion, and high-dose interleukin-2. And what this trial has shown is that, yes, tumor-infiltrated lymphocytes were very good at showing a disease response. Nearly 30% of patients had a RECIST-confirmed tumor response, far different from what we saw with ipilimumab monotherapy. Nevertheless, as I pointed before, the toxicity was not trivial. If we check for the chemotherapy, the non-myeloablative chemotherapy, and the TIL interleukin-2 infusion, a sizable amount of patients had a good amount of toxicity. If we go, for instance, for neutropenic fever, 86% of patients that had neutropenic fever while on chemotherapy, and again, 74% of patients had neutropenic fever while receiving TIL or interleukin-2. That's even though it's a promising therapy that has been approved and available in the United States, Netherlands, and Israel. This is not a common, easily adopted technology. It has had long-lasting responses, yes, indeed, but the toxicity is also limiting. Thence, the takeaways for TIL, from my perspective, is that it has been approved. Toxicity is not trivial, and very few sites in the world are ready for prime time. Moving forward for the second, amongst the very different possibilities of personalized medicine in melanoma, I'd like to address the personalized vaccine. And again, it's a very long path that has been fought and discussed and tried. And for the present moment, the ability to produce a personalized vaccine is still rather long. We need to have a tumor biopsy. In this case, it's best if it's fresh tumor, but it can also be paraffin-embedded, formalin-fixed tumor associated with peripheral blood, so no malignant tissue. And then the tumor and the blood, they both will be assessed for whole genome to then assess the HLA in the normal cells in the blood, and also assessing the types of mutations present in the tumor. Once you have those two, there is a huge and intense and time-consuming and relevant bioinformatics activity here to assess what mutations can be considered highly immunogenic, what mutations can be properly latched to HLA of the given patient, selecting what sort of epitopes should be the ones highly immunogenic, most likely good to be connected to HLA, and then the messenger RNA is produced to code these specific neoantigens. And for the time being, the present we've got here is for Moderna. They try to reach up to 34 different neoantigens. And once the vaccine is produced, after all this validation, it's going to be given to the patient as a regular jab as any given vaccine while on therapy. And it's not so easy to produce RNA, but it's even harder to make in a way that's not going to be destroyed by the regular bloodstream RNAs. So the way that happens is that these RNAs are encapsulated in lipid nanoparticle, and this is the final product, the final package that's going to be inserted into the cancer patient. And once it's inserted, it's going to be collected by the antigen-presenting cells that are prop on removing from the tumor microenvironment extracellular vesicles. And instead of removing extracellular vesicles with dying bits and pieces of cancer cells, they're going to grab this specific vesicle, which is loaded with RNA, and the RNA will going to be translated into antigens, and then the antigen will be fragmented, will be latched to MHC1, and it's going to be presented to the MHC2 and 1, and it's going to be presented to the CD4 and CD8 cells and trigger a response. So what the RNA vaccine logic tries is to expedite the antigen presenting by showing the APC, the RNA that's going to be used inside the APC cell to produce the most likely antigenic and immunogenic antigens. And there is a trial, a prospective trial on that, is the Keynote 942, which assess for patients stage 3B and 4, completely resected with no residual disease. In COG01, they are available by RECIST 1.1, but on this trial, they had no residual disease. And they were randomized 2-to-1 for pembrolizumab, 200 milligrams every 2 weeks for 12 months, or pembrolizumab plus the vaccine 4157, 1 milligrams intramuscular every 2 weeks, try to match the same pembro infusion up to 9 doses. For this trial, the patient would start pembrolizumab monotherapy while the vaccine was being produced. And once it's produced, the patient will carry on the combination of therapies. And this trial has shown that RNA vaccine does boost melanoma response and control, even though the fact that patients were eligible for 9 doses of vaccine, the median number of doses was 5. So it's not a common standard expectation to believe that every given patient will have the vaccine done, and the patient will have the vaccine done at a time to receive the 9 doses. Nevertheless, the results are fairly interesting, with an increase in 17% of recurrence-free survival at 18 months. And a most recent update for 5-year update, we haven't got improvement on overall survival, but the disease-free survival and also distant metastasis-free survival have also been improved. And that's, insofar, the only trial that has shown improvement of adjuvant therapy. We know that IPI and NIVO, they are both superior to placebo, and you know that PD-1 is the backbone for adjuvant therapy, but this is the single trial which had shown an improvement over the backbone of PD-1 therapy. So takeaways of the vaccine would be there is a very huge bioinformatics demand. People used to say that there is a 1,000 whole genome assessment and $100,000 bioinformatics to assess the production of vaccine. It's a joke, but it shows how hard it is to produce a very good bioinformatics pipeline to yield effective vaccines. And are expected with the increased use of vaccines for other tumors, not only melanoma, but also lung cancer, renal cell, urinary bladder cancer, that there will be a growing body of knowledge accumulated, and very likely those costs and ability to produce vaccine will be improved. Moving for viral therapy, I'd like to first address a bit how viruses would work and how they effectively work and improve the outcomes of melanoma patients. How viral therapy would work? Ideally, those viruses would infect tumor cells. They will replicate inside the tumor cells. They will lead to tumor cell lysis, which is death, which is already good. And they would release antigens that would be, again, collected by antigen-presenting cells that would recognize even further the antigenic of those tumors, and this will lead to a more intense immune response. And in general, for the viral therapy, what would happen is that there will be a spread of antigens that will be collected by APC. The APC would present those antigens, and these will trigger out the regular response. Again, that's how we believe that immune response occurs on a normal day-to-day basis. And what the oncovirus will do will, again, boost the presenting of these antigens to APC. And in general, the viral therapy prefers to use DNA instead of RNA virus because their life cycle is better known. So there are less mutations, more predictability. They've got a larger genome, which means it's easier to insert or delete genes. So they are bigger package to convey far more information than just RNA virus. They have, as their life cycle is better known, it's easier to delete certain viral genes, just like they can enhance tumor antigen presentation, just like some virus, they try to hide themselves from the immune system. So if you delete certain genes, we're gonna avoid this hiding. Also, we're gonna decrease a lot their ability to infect normal healthy cells. And we can add on some other genes that will be responsible for boosting the immune response, just like GM-CSF and other T-cell inducers. And viral therapy relies heavily on DNA and most heavily on episimplest virus. Most recently, nearly all the trials running some sort of oncovirus are using episimplest virus. And is it safe? It seems to be safe. If you go for a human virus, they are way safer than non-virus ones because non-human ones, because non-human ones, they show strong tropism for non-tumor cells. If we block the gene responsible for thymidine kinase production, those viruses will not be able to infect non-dividing cells. They will have their infection restricted to dividing cells, most likely cancer cells, precluding them to damage liver, kidney, and brain tissues. Also, we can increase their affinity to tumor cells, inserting some tumor cell latches. And if we go for intratumor injection, we also avoid some of the systemic symptoms, namely flu-like symptoms. And going for the prospective evidence on that, I'd like to briefly discuss two different studies, two different viruses. The first one is TVEC, a second line. TVEC has been approved by FDA as a therapy for recurrent melanoma, and it's a recombinant oncolytic herpes simplex virus 1. It has a reduced neurotropism by gene deleting. It has also been added GM-CSF gene to boost the activity of antigen-presenting cells. And for this specific trial, MasterKid 115, patients were recurrent melanoma 1s with stage 3B and stage 4, including brain mets treated. They had less than 2 lines of PD-1 therapy, so they could have failed on adjuvant therapy or neoadjuvant therapy or first-line therapy, and they were included on a single arm with 4 different cohorts, with Pembro 200 milligrams IV every 2 weeks, plus TVEC on an escalation approach, going by intratumor injection up to 4 mL for total infusion. And these patients, they were divided in different cohorts by their history. If they had primary resistance to PD-1, progressing while on that, acquired resistance to PD-1, progressing after having some clinical benefit, both on first line. If they have progressed after adjuvant therapy with less than 6 months of PD-1-free therapy, or if they have progressed more than 6 months after adjuvant PD-1 therapy. And this trial has shown a fairly interesting response for patients who had the disease progressing after adjuvant therapy, either more or less than 6 months. And not only the overall response rate of those patients are nearly 50%, but also the duration of response was fairly interesting. Sadly, for patients with primary resistance or acquired resistance, the results were they're very dismal, they're not very enticing, showing that this combination of therapy may show a very interesting result, not only response rates, but also on duration of response. A second option of oncovirus is the RP1, a second line, which has been tested on the IGNITE trial. It is also oncolytic herpes simplex virus 1, again with GM-CSF gene insertion, again with deletion of TINILATS and TAS, and with a further immunogenic activity by inducing a tumoral syncytial formation, which seems to be highly immunogenic. For these specific patients, the set of inclusion criteria was rather similar to the previous trials, also recurrent melanoma stage 3B, less than 2 lines of therapy, And again, this oncovirus was combined to PD-1 therapy. In this situation was nivolumab, 240 milligrams every 2 weeks IV, and the virus again was intratumoral injected. And they enrolled patients with primary or acquired resistance. And what we've seen here is an overall response rate of 36%, with a fairly interesting duration of response, a median duration of response of 33 months. And responses we're seeing here in this forward plot, either on the injected and non-injected tumor lesions, showing that the activity of the RP1 was not limited to the site where it was injected, but also it could elicit a distant immune response. So the takeaways for viral therapies is that mostly are DNA-based, they're easy genome editing, they're mostly episimple virus with no neurotropism, which render them fairly safe. They can indeed elicit, they can trigger local and distant metastasis shrinkage by the improvement of the immune response. They are not yet proved as first-line therapy. Maybe they're better positioned as second-line options, even though RP1 has not been approved by FDA. And their safety profile allows them to be used in combination with systemic IOs, most commonly for the time being PD-1. And there are more than 10 different viral therapies being tested. In general, they fall to be DNA-based, they follow to be episimple virus variations. And they seem to be yet so far a possibility as rescue therapy. Thank you ever so much for your time and attention.
Dr. Lima, thank you so much for this incredible presentation. Once again, thank you. And I wanted to say that we are moving to our next speaker, Vernon Sondag. Sondag is chair of the Department of Cutaneous Oncology at Lee Moffitt Cancer Center and holds the Richard Schultz Family Foundation Distinguished Endowed Chair in Cutaneous Oncology. Dr. Sondag, did you hear us?
Yes, thank you. I hope you can hear me.
Yes, yes.
And you're seeing my screen okay?
Yeah, yeah.
Very good. Thank you so much for involving me in this World Melanoma Day. You've heard a lot about neoadjuvant immunotherapy already, and I'm going to talk about a surgical perspective and some of the surgical decision-making that we're now having to deal with after neoadjuvant therapy for melanoma. These are my disclosures. And I want to start by saying, even though my title is Surgical Decision-Making After Neoadjuvant Therapy, actually, surgical decision-making needs to start before neoadjuvant therapy even begins. We really stress this in our multidisciplinary clinic, that the surgeon needs to be part of the team making the decision before the patient gets treated. And conversely, the medical oncologist needs to be part of the decision making before the patient gets surgically treated. We don't want to have a battle between the surgeon and the medical oncologist, but we have to take a comprehensive view of the patient and look at a patient like this. A PET scan in the middle shows a very extensive degree of disease in the axilla, as well as in a small amount of disease in the neck from a patient with a BRAF V600E mutated melanoma. And the question of whether surgery should go first or medical treatment should go first, and whether it's systemic therapy with immunotherapy or targeted therapy, needs to be made in a team fashion, in a collaborative fashion, and not an antagonistic fashion like this surgeon, maybe a little too aggressive perhaps. You've already heard, or you saw some of the earlier presentations about these two absolutely pivotal clinical trials that have established beyond any doubt that for a patient with stage 3 melanoma, similar to the one that I just showed, if it is resectable, then neoadjuvant therapy is preferred over adjuvant therapy. So that decision making has to begin before you do surgery, before any neoadjuvant therapy starts, because otherwise the person might have surgery first and not have an opportunity to undergo neoadjuvant therapy at all. So this decision making begins with the biopsy. What approach to the biopsy do we take that will facilitate neoadjuvant therapy? And that means not doing an excisional biopsy. Of course, we want to even be thinking 2 steps ahead, and we now consider placing a marking clip into sites of known tumor at the time of the biopsy. And of course, part of the decision making right from the outset is this patient a candidate for a clinical trial? So what can we do to make sure the maximum number of patients are eligible for the many benefits of neoadjuvant therapy, including, as we'll see, potentially less extensive surgeries? First of all, we recommend 2 attempts at needle biopsy before considering an excisional biopsy of an enlarged lymph node in a patient with a known history of melanoma. Sometimes the history of melanoma isn't known, where we have an unknown primary, like the case I showed. Those can be really challenging to recognize. But if we just all got into the habit of doing needle biopsies before ever considering an excisional biopsy for lymphadenopathy, I think that would be a big step forward. And at our institution, we pretty much routinely consider placing a marker in the index node at the time of the needle biopsy. We'll come back to that in a moment. Of course, again, we consider the clinical trial options right from the outset. And here's one of them that, again, you have to be thinking of right from the beginning. This is the new MSLT3 clinical trial, also has in the United States an S2601 number, that is going to test this index lymph node concept. I'm not going to talk about the trial right at this moment, other than to set the stage that if we didn't consider this right from the beginning and put a clip in, and if the patient had already gotten started on their neoadjuvant therapy, you can't go back and put them onto the trial. So we want to think about a trial like this right from the very beginning, as soon as we are faced with a patient that we think has potentially resectable stage 3 disease. For this specific trial, that means a minimum of 1 enlarged lymph node. As long as it is biopsy proven, it doesn't have to be a palpable lymph node. It just has to be a measurable, biopsy proven node, and it has to have a marking clip placed right at the very outset. And the one problem with this study that we have to point out is that this study is not going to be done anytime soon. It has only just started accrual, and final analysis will take place when all entered patients have had at least 2 years of follow-up. So it will be many years, 3 or 4 more years, before we have the results of this randomized trial looking at index node dissection. So until then, we're going to, if the patient is not on the study, we're going to have to make some decisions about what surgery to do. And we're going to come into that in more detail in the ensuing slides. Again, you heard this if you listened to the earlier presentation, whether we're talking about targeted therapy or immunotherapy, but especially with immunotherapy, pathologic response is so important. Only the surgeon in current practice can give us the tissue for the pathologist to give us a pathologic response. So today, we don't make pathologic response decisions based on biopsies or anything else, but at least a complete removal of known previously tumor-containing tissue. As you've also heard, we can't rely on CAT scans or PET scans to identify which patients have a pathologic complete response. As shown in this study, there were many more pathologic complete responses than there were complete responses on CT or by PET. And in this study, when they got into detail on individual cases, you see that even among patients who looked like they had a great PET response, most of them did very well. Most of them had a pathologic complete response or near complete response. So a good response on PET is the best non-pathologic surrogate we have. But you see here that there were still 2 cases that did not meet the criteria for even a near CR among the many cases that had a good PET response. So it's a great sign, but it's not perfect. And conversely, if you go, those are the 2 cases I'm talking about. If you look at the ones who seem to have a poor PET response, well, we see that there are partial responders and even 2 patients with near or complete responses and no PET evidence whatsoever of improvement. So we rely still on the surgeon to give us the tissue to help us make the decision about pathologic response and what to do next. So now we want to ask the question about this index lymph node, or what I like to talk about, omission of lymphadenectomy. And I want you to think about this question a little different than maybe you have before. Here's the question I want you to ask. Can we take this patient before we even start the neoadjuvant therapy and ask, is this patient a candidate to avoid a full lymph node dissection the way we now routinely avoid lymph node dissection in sentinel node positive stage 3 melanoma? Can we take palpable disease and magically transform it into sentinel node disease by giving neoadjuvant therapy? And there are 2 distinct concepts here. There is the index lymph node excision concept, but the larger concept is just omission of lymphadenectomy. When don't we do a lymph node dissection versus when do we only remove the index lymph node? So let's talk about this in more detail. Of course, all of this traces its roots to the pioneering work of the group from the Netherlands Cancer Institute and also colleagues like Alex Vanekoy now in Australia, looking at omission of a lymph node dissection in the Prado trial of neoadjuvant therapy. On this study, patients got 2 doses of ipi/nivo. They had only the index lymph node removed, the node that had a marking clip placed at the time of biopsy. And when that lymph node was analyzed by the pathologist, if there was a near or complete pathologic response, they did not have a lymph node dissection. So you see 59 patients out of the original 99 did not have a node dissection because they had an excellent pathologic response. There were another 10 patients who had a partial response, and 2 of those 10 didn't have a therapeutic node dissection either. They refused to do it, even though by the protocol standards they were supposed to. And if they had no response in that index node, they were taken back to surgery and had a complete lymph node dissection. So this was very much similar to the original sentinel node idea. You take out the sentinel node. If it's positive, you go back 3 weeks later and do a completion lymphadenectomy. This was trying to do the exact same thing. How did it work out? Well, as we all recognize that the patients with that pathologic complete response in the green or near complete response did extremely well, even though they did not have a complete lymph node dissection. And the bottom line, that meant that out of 99 patients on the study, 59 avoided a lymph node dissection. And there have only been a handful of nodal recurrences to date, none among the patients with only one positive node to begin with, at least as far as has been reported so far. So this is really an outstanding result, very influential and important. And as I alluded to earlier, the MSLT3 randomized trial is planned to compare the outcomes in a formal randomized way, taking those good responders and randomizing them to have no further surgery versus a complete radical lymphadenectomy. In a few years, we'll have some results from that. What do we do till then? What do we do outside of a clinical trial? Well, at our institution, we are already using this concept of omitting lymphadenectomy after neoadjuvant therapy. Outside of a clinical trial at our cancer center, this approach is considered for melanoma patients, particularly those presenting with only one clinically involved lymph node, who understand the limited data that supports this treatment strategy. 99 patients is limited data. Excision of the tumor-involved lymph node, or the index node, must be feasible without requiring or precluding a full lymphadenectomy being done later. How could that happen? Well, for example, we recently had a case where the index lymph node was in the pelvis, was an external iliac lymph node, and it was quite large in size despite the neoadjuvant therapy. We were concerned that if we just took out that lymph node, it would be very difficult to go back into that pelvis due to the scarring. And so we did a full pelvic lymphadenectomy, external iliac and obturator nodes, all at the same time. It proved to have a pathologic CR, even though he still had a large metabolically active tumor. I was absolutely certain at the time of surgery that this was viable tumor, and it was a path CR. After hundreds of operations following neoadjuvant therapy, I still can't tell who has had a good response and who hasn't with certainty any more than the PET scan or the CAT scan can tell. So how do we find this index lymph node? Do we need these fancy markers? I like to show this case because it's a case that was a little bit unusual. He presented with an ulcerated melanoma with a palpable node in the axilla, but because of some findings on the PET scan, he was thought to have metastatic disease and was treated on a clinical trial for metastatic disease for 6 months. And then the bone findings didn't change at all. And when they were reassessed, people said, you know what, maybe this is just benign changes. Maybe it was stage 3 all along. And they came back and said, can we do a limited surgery and then just take out that lymph node on this patient? And even though there was no marking clip, I said, yes, it's very obvious exactly where that lymph node is. I should be able to find it with no problem. I went in and found a lymph node that matched the size and the location I thought of the lymph node exactly. But then I looked at it and I thought, that just doesn't look like a lymph node that has had tumor in it after neoadjuvant therapy. I may not be able to tell if they're a complete response or not, but I can usually tell if it was ever a tumor-containing lymph node. So we did some more dissecting, and what do you know? We found another lymph node, the exact same size and shape, that obviously was a tumor-containing lymph node. And the pathologist looked at them and said, yes, that was a tumor-containing lymph node. That's now a pathologic complete response lymph node. So it's possible to find the lymph node even without a marking clip, but it's much, much more difficult. And you have to be certain if you're going to do this index node approach, you just have to be certain that the node you give the pathologist really had cancer in it to begin with, or else the information is not useful. So what do we do now to find the index node prior to starting treatment? Preferably right at the time we order the initial diagnostic biopsy, a marker clip is placed in the lymph node for subsequent localization. Since not all patients who have a localizing clip inserted ever have the node excised, the clip must be suitable for permanent placement in that patient for the rest of their life. Why wouldn't they have it excised? Perhaps they'll have progression of disease and develop widespread metastatic disease. So we're not going to go in and take out the index node in that scenario. That's just one example why they might have toxicity that's so severe that they never get to the OR. So has to be a clip that can stay there for the rest of their life. What are the types of clips that we have? These non-localizing, there are non-localizing radio-opaque marker clips that are often placed at the time of image-guided biopsy. The breast biopsy people always put these small little clips, but they're not useful to the surgeon. They are useful to the radiologist to guide the subsequent placement of a localizing clip after the completion of neoadjuvant therapy. So if we have a biopsy clip that was placed, we can wait, let them have neoadjuvant therapy, and then implant a localizing clip later. But if possible, we start with the localizing clip rather than with a non-localizing marker clip. There are three technologies: magnetic, radar reflecting, and radio frequency identification. Each one has advantages and disadvantages. The magnetic seeds are the ones that were used in the Prado trial. You see the size of that seed just sitting on the tip of the finger there. And many breast surgeons use it, so it's widely available at many centers. It has significant downsides. It can interfere with MRI scans, can leave a big artifact in the axilla. That means that if you don't do the surgery and they get progressive disease and maybe you need to do an MRI of their brachial plexus, you might have problems. Some of the newer generations of clips are being designed that have less interference. The first generation of these clips require non-magnetic surgical instruments that we don't always like to use. Again, later generations are planned that are trying to address some of these problems. The radar reflecting clips are what is used most commonly in in our institution and in many institutions, also widely used by breast surgeons. You see the radar reflecting clip here in this specimen with and compare it with the standard ligating clips, small and medium size clips. And you can see very readily that it can be hard to distinguish from those clips. So we try to use fewer clips on the specimen going forward than you might otherwise, so that you don't have a problem telling them apart. The radar reflecting property can be deactivated by cautery if it is used too close to the clip, and those points at the end of the clip make it prone to dislodge. It can get caught on a laparotomy pad or even an instrument. I've found the clip out of the patient and stuck onto my instrument on a couple of occasions. This is the reflector, that clip and the probe that we use, and it's somewhat similar to what you would use for a sentinel node biopsy. And this is another picture of the clip. You see how it's sticking out of the specimen and how that can make it prone to dislodging. The clip I like to use the best is the radio frequency identification clip. In the United States, it's called the SMART clip. It's the least widely used, but it is used by some breast surgeons. It has the advantage that multiple clips can be placed that are tuned to a different frequency, so you can tell them apart. It is exclusively designed currently for use in the breast and axilla, and so it's actually hard to use in the groin, hard to use in the neck, and impossible to use currently in the extremities. And it has the potential for interference by metal. You can't wear your ID card around your badge, around your neck. Metal of the operating table and the anesthesia equipment can interfere under some circumstances. But when it works great. Here is a case where we used it on the groin. You see, it's designed for the for the breast, so the image seems to show it in the middle of the abdomen somewhere, but it's actually in the groin. And the localizing probe sticks right onto a surgical instrument. You can stick it on the bovie. I stick it on an insulated forceps, and it is actually the most precise localization technology, much better than sentinel node localization technology. And when you remove it, it's immediately recognized by the system that you have removed your target. This is a picture of a clip showing the RFID clip down here and the standard ligating clips above it to show you the relative size. And it's when it works, this is the best approach. Here's an example of a patient who had a synchronous primary melanoma and a right axillary metastasis. We put a clip in, and you see he had a great PET response, both at the primary site and in the axilla, but not an absolute complete response. And we went in and were able to excise the clip. And we actually were also faced then with, what do we do about the primary site? What do we do about the, about that wide excision? And we actually did a narrower wide excision. Instead of a 2 centimeter wide excision, we were able to do a 1 centimeter wide excision in that patient because he had such a good pathologic and clinical response. So there's still some questions to be answered. When is it appropriate to consider this? Some of these will be answered eventually in the MSLT3 trial, but not all of them. N1 disease, I think this is a great approach. When there are multiple nodes, it's not so clear how often we should do this and what is going to be the results when we only take out one node when there are 2, 3, or 4 that were initially involved. What about if the patient had a prior positive sentinel node biopsy? So they already have one positive node. Now we're automatically into multiple positive nodes. And what if they've had prior adjuvant immunotherapy and they recur during or after that in the nodal basin? MSLT3 won't answer that question. Another question MSLT3 won't answer is, when is the completion dissection actually needed? We know now in sentinel node cases, we don't need the completion dissection at any point. Do we need it even in any of our index node cases, even if they show a poor response? We don't know that yet. We're certainly actively investigating it. Does neoadjuvant therapy make the surgery harder or easier to perform, regardless of whether you do a index node or a complete lymph node dissection? When do we do a pelvic lymphadenectomy? What about some of these surgical techniques to minimize lymphedema? And as I hinted, can we use narrower excision margins for the primary site? These are all questions that we still have to answer. These are questions that we don't have a lot of data. The data that we do have suggests that neoadjuvant therapy can make the lymph node dissection a little bit tougher, but not dramatically. As a surgeon, you appreciate more inflammation, some loss of the planes, but in terms of complication rates, in terms of measurable outcomes, no obvious major difference with or without neoadjuvant therapy. We no longer do pelvic lymphadenectomies electively, but if there is evidence of nodal disease, including on the PET scan in the pelvis, we don't hesitate to do it. We have not had any experience with lymphovascular anastomoses after our axillary or groin dissections to minimize lymphedema. It's just unknown as of yet whether that's appropriate. And we do have an emerging experience with using narrower excisions. And I think that there's good reason to further investigate narrower margins, 1 centimeter margins, in cases with an intact primary and a good response to neoadjuvant therapy. So with that, I will stop and thank everyone for their attention and thank the organizers for allowing us to be part of this. No.
Dr. Zondak, thank you so much. Thank you for this excellent talk and for taking the time to be with us. So we're moving to our next speaker. I'm sorry, we are going to short break. So yeah, stay with us. Welcome back, everyone. We hope you enjoyed the break. Our next speaker is Joseph Markovits. Dr. Markovits is an associate member in the Department of Cutaneous Oncology at the Liv Moffitt Cancer Center and Research Institute and the associate professor of oncologic sciences in the University of South Florida. Today, he will be speaking about AI-driven translation in melanoma care. Dr. Markovits, thank you for joining us today. The floor is yours.
Thank you, and thank you for the invitation to talk. Today, I'm going to give a brief introduction to how to use artificial intelligence, basically from translational research to clinical applications in melanoma. And just a few brief disclosures, and then a few thoughts to begin the AI discussion. And this is obtained from a very nice book of artificial intelligence that I provide the reference for below. And the first one is the best way to keep a prisoner from escaping is to make sure he never knows he's in a prison. One can think of this very interestingly from the standpoint of what we're hearing now about AI. And the interesting thing about each of these quotes is that the book uses each of these quotes to introduce a different area of artificial intelligence and how it then relates to generative AI. And then the second one is the theory of probabilities is at the bottom, nothing but common sense reduced to calculus. So the question is with AI, essentially the computer is bits, correct? A series of zeros and ones, one can think about it. And then how can we then use mathematics in order for the computer to learn? And then much further back in history, learning without thought is labor lost, and thought without learning is perilous. And one can think about this in terms of AI. There's obviously hallucinations and things of this sort, but really we want to put thought into how we're using AI, both general AI and also generative AI. And lastly, in terms of how to develop the agents, how to develop those items that are going to take the tasks on in our programs. Albert Einstein had a very interesting quote. It can be scarcely be denied that the supreme goal of all theory is to make irreducible basic elements as simple as a few as possible without having to surrender the adequate representation of a single datum of experience. So basically, we need to create simple models, but models that can incorporate and learn what is the environment in which they reside. So I thought I would start the conversation also with a bit of a discussion of how to use the tools. So this is a set of figures. Most people are familiar with these figures of what is artificial intelligence, and then how to use engineering prompts in order to develop figures and things of this sort. And one needs to be careful and think of some of the quotes we just thought about. The first iterations on the left and the last iterations on the right. And we see here we have artificial intelligence, which is how to use the computer to do some thought process, not necessarily generative AI. And then as you get more complex, you get machine learning, deep learning, and then generative AI. And you can see that the at the right-hand figure, that all of these circles, essentially ellipses, meet at the bottom, versus at the left-hand side, they do not. So it is interesting that you need to have multiple generations of questions sometimes in order for AI to actually get to the result that you're thinking of. So with some of these items in mind, what do we think about when we think about uncertainty? What is the ability of the program? What are the inputs into the program? Does the program have any preferences? And therefore, one can think of a program that completes a task like an agent. And that's the idea. And this is how we transition to generative AI. An agent is something that we can use in order to understand things, but each agent should perform a specific task. And so let me give a couple of examples, first starting from the more traditional artificial intelligence in terms of machine learning, and then we'll proceed from there. So this is an example from our own research. And in my research, I'm very interested in the role of nitric oxide in melanoma. And we can use the nitric oxide phenotype to predict relapse-free survival in patients who received adjuvant ipilimumab treatment. And what we do here is we have multiple markers, more than what's on the screen, but we do a k-means clustering and create a phenotypic tree. And we've developed methods in order to superimpose new flow cytometry sets onto the old phenotypic tree. And then if you then take a series of samples and measure it this way, we can actually tell who does very well and who does very poorly based upon the nitric oxide phenotype. And this is done by a simple k-means clustering. And then a second one. So nitric oxide then has a relationship to STAT1, as many people in this room understand. Interferon then stimulates the phosphorylated form of STAT1, which then goes to the nucleus to turn on multiple genes. The STAT1 is then nitrated. And what's very interesting is that if you increase the nitration of STAT1, patients do very well. And so this paper was published just a couple of years ago, but it serves to say that we can use machine learning to learn new things about melanoma. In this case, we learned that there's a dichotomy of nitric oxide. It has good and bad effects depending upon where it is, but it's and it's not just the bad effects on the T cells from nitric oxide produced by MDSCs, but there's a multiple of effects. And then we can use AI for tissue specimens. So let's just spend, and the reference for this paper will be on the next slide. And we have here a non-responder to anti-PD-1 therapy, and we have a responder. And note that the spatial geometry of the sample with regards to the markers are very different. It's not just that iNOS, the inducible nitric oxide synthase, which is one of the proteins that produces nitric oxide, is there in the tumor microenvironment. But the question is where is it located? And then what we were able to do is use machine learning to see the importance of iNOS. And you can see on the left-hand side where you use the SHAP score, think of it as a gaming score, that you can see for different cell subtypes what is, whether it's a good responder or a poor responder. And then what's very interesting, when you look at microenvironments that have immune cells, whether or not they're excluded from the immediate area, but within the microenvironment or within the environment itself, doesn't matter so much, that you can obtain much better receiver operator curve characteristics, and you can then predict better who is going to respond to immune therapy. In the previous case, this was for ipilimumab. In this case, this is for anti-PD-1. So now this is a general talk. And what I'd like to do is give some of the examples of AI tools used in the community, and not quite yet in the community per se, but under investigation to be able to then proceed perhaps in a few years to standard of care. Then in dermatopathology, there is a current effort to identify melanoma subtypes. However, it's very far from standard of care at the current time. And this is both from a deep learning perspective, and there is also some generative AI types of approaches. The second thing is that there's an active programs to identify melanoma lesions on skin exam from dermoscopy, and this is using multiple types of AI and also generative type AI that we were discussing. And I know there's a dermatologist who will be talking during this session, so I'll leave these topics for her. And then the question is then we did an immunofluorescence study, but how about just using H&E? We could try to predict response to checkpoint blockade using H&E and using neural networks and other types of techniques. And this is just one example. And you can see the map of lymphocyte infiltration and macrophages. And so some of the same ideas that we were seeing, other people are seeing too. So the question is then now how to use generative AI to bring things together. And then the other thing we can do, we're thinking of, okay, we want to know response, but in order to know response and do these studies, we need to be able to understand how to obtain clinical outcome data from the electronic medical record. And this was a very interesting study, because one can think of is that there's firewalls at all of our institutions. There's firewalls in private practice. So in this case, there's a Dana-Farber firewall, and then there's the MSK, Memorial Sloan Kettering firewall. And so at Dana-Farber, they created a model, and for it's a very nice description, and they call this the teacher model. And then this model can then be taken out of the firewall and then taken within the next firewall, and then create the outcome data within the firewall, de-identify it, and then that data de-identified can be taken out. Now, how to obtain the clinical outcome data, there's natural language processing, there's other techniques. That process is still a heavily researched area, but one can think of that you have these two firewalls, but there is a way to navigate between them. And then something that we can use the clinical parameters to predict survival. So these are curves where they were generated just by getting clinical parameters from the Flatiron database. And with these Flatiron databases, you can get the LDH, the lymphocyte to neutrophil ratio, and all these sorts of details. And so what can happen is you can put these in a truly machine learning type of model and choose which parameters based upon the model will give the best outcome, and then generate the curves. These can be improved, but this is a very interesting first step. And so just to think about this a little bit, AI is being used for research in melanoma. There's greater than 150 publications using AI yearly since 2001. The top 10 institutions currently, and China is catching up quickly, Germany, United States, Australia, Austria, and Pakistan. And what's the most important is that we really need to have collaborations, and that publications are entering mainstream scientific journals, but we need to understand and make clear ethics in order to move forward. Because one really needs to have guardrails on artificial intelligence, because otherwise it can hallucinate. And at the current time, I would argue that everything needs to be validated from artificial intelligence. So in this regard, one is hearing on all the news outlets that we can use AI for literature reviews. And in this case, we can use large language models. This is one interesting paper that used GPT-4 that started the literature search and used our well-known PICO type algorithms, where we have the patient, what is the question, what is the intervention, what do we want to do, what is the comparison? For example, in the old days, we would compare PD-1 to carbotaxol. And then what is the outcome that we want to see? Do we want to see progression-free survival? Do we want to see overall survival? And then we use a large language model to screen abstracts. And then we extract data with the large language model. And then it's summarized. And what's very interesting is that the precision and recall, although not the perfect, for melanoma, it was actually less than some of the other malignancies, the precision and recall being in the high 70%. So the European Union has started to develop some basic requirements for AI-based biomarkers. I think it's very important that we start to think about what are the classes of biomarkers, what is being generated by AI, and then how do we regulate this? So ESMO suggested just this past year that there should be 3 classes of biomarkers. Number 1, based upon the method that's new. Second, the inputs and the method are new. For example, we need to obtain the data for the model. And then the input, method, and result are new. So based upon these different classes, we'll determine what needs to be done in order to then go through regulatory processes. So in the European Union, this was a nice paper. This is the same paper as the reference on the previous slide, where you have the 3 classes of biomarkers. And let's go through these one by one, because I think it's important. In class A, we have a validation study that is basically concordance. And this, we need to just do analytical validation. The comparator needs to be blinded to AI, and also the expert needs to be blinded to AI, and AI needs to be blinded to the expert. And then in class B, we should do retrospective analytical validation. And the comparator is basically the gold standard tests in whatever you're trying to do. So if you're trying to do a clinical trial, then it needs to be a clinical trial, etc. Class C is when all the input, methods, and results are new. And then we have whether or not it's prognostic or whether it's predictive. If it is prognostic, then we can still do retrospective analysis. But if it's designed to be predictive and used in clinical care, then we should do a randomized controlled clinical trial. And then the comparator in the retrospective for the prognostic portion of validated prognostic markers, and then in the predictive portion of validated predictive markers if they're available. If not, there are other, this will need to be discussed with the regulatory bodies. So in conclusion, AI has multiple uses. We can use it in literature searching, predicting response to therapy, understanding the research landscape, diagnosing melanoma lesions, pathology, and dermatology, and then use of the EMR to evaluate clinical outcomes. How do we then extract the data out of the EMR within the firewalls? So the main conclusion is that we do need to develop guidelines, and the ESMO guidelines were a nice first step. So just in conclusion, I'd just like to stop with this nice slide that I generated with AI. And so obviously I reside now in Florida, so we have alligators. And the question is how to avoid hallucinations. And so AI will do whatever you ask it to do. And sometimes, as anybody who has studied computer programming knows, that sometimes what you think you're asking the computer to do may not be exactly what the computer will do. So with that, I will stop and I will take questions.
Thank you so much, Dr. Joseph Markovich, for this wonderful presentation. We really appreciate your time and insights. So we are now going to take a 5-minute break. Please be back in time as we will continue shortly. Welcome back, everyone. So our next speaker is Yana Najjar. Dr. Najjar is an associate professor of medicine and director of the Clinical and Translational Research Center at the UPMC Hillman Cancer Center. Today, she will be speaking on immunotherapy-resistant melanoma. Please join me in welcoming Dr. Najjar.
Hi, everybody. Thank you, Arpi. So today I will be talking about how we think about treatment of melanoma for patients who have progressed on immunotherapy. And you know that most patients in the current era receive immunotherapy first. These are my disclosures. So the systemic therapy landscape for patients with melanoma has really changed drastically. We went from 1975 to 2011 with a handful of approvals based on single-arm early phase data. And from 2011 on, we saw very rapid approval. I've put here in blue immunotherapeutic agents and green targeted therapies. And I hope you can appreciate that a lot of the firsts that we've had in immunotherapy and targeted therapy have come from the melanoma landscape. So the first immunotherapy approval for CTLA-4 and then PD-1, and then combinations of CTLA-4, PD-1, more recently LAG-3, PD-1, T-cell engagers and uveal melanoma, cell therapy with lifileucel, etc. And as is the cycle of science, when we found things were working in the metastatic setting, we said, well, if we're helping patients live longer with metastatic disease, can we prevent recurrence for patients with earlier stage melanoma? And the answer has been yes, first in stage 3 and more recently in stage 2B, 2C. When I think about emerging therapies of interest, there are certainly many, but in the interest of time, I tried to whittle it down a little bit. And this is a table that I made really with what comes to mind when we think about the current landscape. And so vaccine therapy is really currently sitting in the adjuvant setting. There's a frontline metastatic trial going as well. LAG-3 is also being tested, a different combination in the metastatic setting. But what I really want to focus on today is what do we do for patients who have been failed by immunotherapy, for whom immunotherapy is not working? And I think there are really 3 major buckets. One is oncolytic viruses, 2 is bispecifics, and 3 is cell therapy. And I've put the phase of the trial here and also whether enrollment is completed or still ongoing. And one thing I think is very interesting is we're starting to see predictive biomarkers that are required for inclusion in these trials. For example, we know with the bispecific T-cell engagers, a patient needs to be HLA-A*02:01 positive for the drug to work mechanistically. Same for Immatics's cell product. So what's the current treatment paradigm for treatment of a patient with metastatic melanoma? So Mike Atkins's pivotal EA6134 or DREAM-seq trial very firmly established that for a patient with metastatic melanoma, they are best served by getting upfront immunotherapy regardless of their BRAF mutation status. And so that's really set the stage for us. We also know in the frontline setting, there are different combinations that we use. You can use ipilimumab and nivolumab. That was the pivotal CheckMate 067 trial, which we recently saw 10-year data from. Melanoma-specific survival 10 years out is 55%. We think that half of patients who receive ipi/nivo are cured of their disease. Another option in the frontline setting is relatlimab-nivolumab or LAG-3 PD-1 combination. This comes from Relativity 047. And there are certainly still patients who get anti-PD-1 monotherapy. And those patients, at least in the US, tend to be patients with desmoplastic melanoma for whom we know we don't need a doublet, patients who have perhaps some contraindications to immunotherapy. Now, in many parts of the world, Opdualag or Rela-Nivo is not utilized. And so depending on where you are, your options may be ipi/nivo or PD-1, or you may be looking at the options of 2 doublets, ipi/nivo, Rela-Nivo, or PD-1. So in other words, the frontline setting is pretty good, right? We have good options. But what about patients who don't respond to frontline therapy? Well, what we do for patients then really largely depends on what they got first. So I tried to break it down here. If a patient got frontline ipi/nivo, if they are BRAF wild type, your options are pretty limited. If they're a cell therapy candidate, you can do standard of care lifileucel in the United States. The commercial name is Amtagvi, with a response rate of about 30%, but this is not an option for most patients. It's a very robust, very demanding modality. So we consider this for a proportion of our patients, maybe 20%. Another option is relatlimab nivolumab, but the odds of rela-nivo working, if ipi-nivo did not work, are low. It's about 12%, and that comes from the Relativity 020 study. Now, of course, if patients have limited disease, you might consider a standard of care oncolytic virus, such as TVEC, and we're always looking at clinical trials. Now, if a patient is BRAF mutation positive, which about 40 to 50% are, in addition to all the options I mentioned, you also have the option of a BRAF MEK inhibitor, which is a great option with a very high response rate, north of 70%. But the problem, of course, is your durability is not as long as we would want it to be. The median progression-free survival of, let's say, encorafenib binimetinib is 14.9 months. So if immunotherapy works, there's a very good chance it works very, very long term, even once you're done with treatment. That's not true of targeted therapy. Targeted therapy will probably work, but we know it's not going to work forever. Now, if you are a patient who got relatlimab, nivolumab, or Opdualag, the market name, in the frontline setting, or anti-PD-1 monotherapy, you have maybe a little bit more wiggle room. And what I mean by that is all the other options I mentioned are the same. But we know that if you get frontline rela-nivo, it would seem that our odds of being able to salvage with ipi-nivo are a little bit higher than the reverse. So ipi-nivo followed by rela-nivo doesn't work very well. There's about a 12% response rate. But on the other hand, if you get PD-1 or you get rela-nivo and you progress, ipi-nivo for salvage is pretty decent with a response rate somewhere between 20 and 30%. So with all of that, I hope I've set the stage to say that in the frontline setting, odds are you'll do great. But if you do not have that response in the frontline setting, we need more options in the second line plus setting, in particular for patients who have progressed on ipi-nivo, in particular for patients who are BRAF wild type. So with that, let's turn our attention to oncolytic immunotherapy. This is not a new idea. We have been trying to utilize different kinds of oncolytic viruses for a very long time, and the only regulatory, or the first regulatory approval we saw was in 2015 for TVEC, which is a herpes virus. The idea here, of course, is that if you are infecting a host with virus, the immune system will see that there is an infection, and while it's going after the infectious agent, will also go after the cancer. So that's the premise for oncolytic virotherapy. Now, RP1 is a newer isolate of HSV1 that was modified to express a fusogenic glycoprotein and immune-stimulating proteins. And the idea here is that you're activating both a local and a systemic anti-tumor response. The virus is engineered so that it will essentially leave healthy tissue, non-tumor tissue, untouched, undamaged. But it is infecting tumor tissue. And with this dysregulated host antiviral response, you're getting a robust viral replication, tumor lysis, you're dumping tumor antigen and neoantigen into the periphery, you're releasing these neoantigens that the immune system hopefully will then see and be switched on by, and it becomes a really iterative process. This was the IGNITE study, the phase 2 trial, and this was for patients who had failed anti-PD-1 immunotherapy. And there were 140 patients, all of whom had confirmed progression on anti-PD-1 with different contexts, which I'll come to. Patients were treated with RP1 for up to 8 cycles, and you were then continuing your immunotherapy from cycle 2 on. So think about it as your first RP1 with cycle 1 is sort of priming of the immune system. And then cycles 2 to 8, you're giving RP1 with nivolumab, but you stop the RP1 at cycle 8 and you continue with nivolumab only every 2 weeks. The primary objective was safety and tolerability, and the objective response rate. Secondary objectives are listed here, as you would expect for an oncology clinical trial. The criteria for prior anti-PD-1 failure are listed here. Patients must have progressed on 2 assessments at least 4 weeks apart. They must have had confirmed progression while receiving anti-PD-1. So you can't have, let's say, been on targeted therapy and then come on to this. You had to have been on PD-1. It had to have been received for at least 8 consecutive weeks. And like I said, it had to be your most immediate prior line of therapy. These are the efficacy data from IGNITE, and all patients had at least 12 months of follow-up. The objective response rate was 33.6%. And again, this is in 140 patients, and you can see here in the different columns the different contexts of PD-1 failure. So you had patients who had progressed on single-agent PD-1, patients who had progressed on Ipi/Nivo or CTLA-4 PD-1. This is of particular interest because this is our hardest population to treat, and the ORR there was about 28%. Patients also had primary resistance or secondary resistance. And so to me as an oncologist, when I looked at this data, I thought it is a heterogeneous population, but it is homogeneous in the way that matters most, which is this is truly a PD-1 failed population. The ORR is 33.6%, like I said. To put it in context, the ORR for second line plus, the current benchmark in the US, is probably 30% plus. That's where something needs to sit to be of interest. And that's really coming from these data, from the data for lifileucel, where the ORR was just north of 30%. This is a waterfall plot, so anything going up is not good. That means the tumor is growing. Anything going down is good. That means the tumor is shrinking. And you can see there is more down than up. And the thing I want to point out, and this was really very interesting because it was the first time I recall having seen this sort of data, which is to say that the injected in purple and the non-injected in pink tended to behave the same. So if I injected a patient's axilla with RP1 and they had a lung met, odds are the lung met was also going to shrink down, and that's a metastatic site that we didn't touch. And so, in other words, the responses are not only driven by injected lesions, and you are seeing responses at distal non-injected lesions. This is an example of a patient who had been treated with adjuvant nivolumab. She had then been treated with pembrolizumab in the metastatic setting. She was injected at a site in the forehead, and you can see that an uninjected tumor in the liver had very consistent reduction in size. And again, this was an uninjected hepatic lesion. The confirmatory IGNITE study is currently enrolling. This is IGNITE 3. And this is for patients with advanced cutaneous melanoma who progressed on anti-PD-1 and they are required to have progressed on anti-CTLA-4, or we have to say we don't think they're a candidate for CTLA-4 for whatever reason. Patients are then randomized to RP1 and nivolumab versus physician's choice. And there are several options that are available to us there. And the trial is currently globally enrolling. Now, I think this the primary endpoint, by the way, is overall survival. I think this is particularly important because while Replimune had submitted to the FDA, which is our regulatory agency in the States for approval of drugs, with the IGNITE phase 2 data, all the data I previously showed you, and frankly, many of us in the field, if not all of us in the field who are melanoma specialists, were in favor of the approval based on the safety and the ORR of 33%. The agency elected not to approve RP1. And so, unfortunately, this is not available to us as a standard of care option in the United States. And so, the only way we can get patients access to the drug, which we do think they are likely to benefit from or they may benefit from, is through this clinical trial. So again, this is still enrolling. Please keep this in mind. It is enrolling ex-US also. We're also interested in taking this into the much earlier phase of treatment. So one of my lab's research interests is earlier stage melanoma, hypoxia in the tumor, what this means for the sentinel node. But before taking us way off track with all of that, I'll just say that this is a trial of neoadjuvant RP1 in patients with clinical stage 2B or 2C melanoma. patients get 3 doses of RP1 in the neoadjuvant setting injected into the tumor site, and they then go to their standard of care surgery. The primary objective here is to determine the rate of sentinel lymph node positivity. The trial has enrolled very well. We're almost done enrolling at our site. So let's look at a case. This is a gentleman of mine whom I've been taking care of for some time. He's a 78-year-old male. He's pretty healthy, but he has some Parkinson's that's well controlled. He had rapidly progressive, unresectable BRAF wild-type melanoma behind the left ear. It was really quite bulky with matted in-transit metastases that became one large tumor. His disease continued to rapidly progress despite my giving him 4 cycles of Ipi/Nivo. He elected to enroll on a clinical trial that included RP1. And what you can see here, believe it or not, is what the tumor looked like after treatment. And it looked a lot better after treatment than it had before, but there was still all of this pigmentation. And I had this very clear sense that while he was measuring a stable disease, I didn't think that was an accurate representation, because I had seen the tumor go from very large, fungating and bleeding to completely flattening out. And so what I then did was to biopsy 2 sites of the tumor in clinic. And in brief, you can see that there was dermal melanophages and dumping of pigment, but there was really no viable tumor at all. And we looked in many, many deep sections. And so this is a patient whom we said had a pathologic complete response after 8 injections of RP1. He continues on nivolumab. I actually saw him in clinic a few weeks ago. It continues to look even better. It's now regressed, and it's looking like a light blue as the pigment is dissolving. This is another clinical trial that I've been very heavily involved in. This is VET-T3-TGI. It's a novel virus. This is a trial that is still enrolling. And it's different than other viruses in the sense that, first of all, this is a Western reserve vaccinia virus, and there is a therapeutic payload of TGF-beta inhibitor and IL-12. We also inject directly into the tumor. These are some very early data that we have seen. Again, this is not published. This is very early. But what I want to show is that we have seen partial responses in patients who have been heavily pretreated, including this patient who had progressed on 5 prior lines of therapy. We're starting to do some of the translational or correlative work. And what you can see here is that patients, first of all, have not only favorable modulation of the tumor microenvironment in the injected sites, but we're also seeing a more brisk lymphocytic infiltrate in non-injected sites. And I think that's very interesting to see. This is another patient whom I have treated who had failed 4 prior lines of therapy, targeted therapy, immunotherapy doublet, and he has been doing very well. And we actually just saw him in clinic, and his response continues to deepen over time. So that's the first basket that I alluded to. That's oncolytic immunotherapy or oncolytic virotherapy. Let's turn our attention to the second bucket, which is cell therapy. And in the United States, we have had since February of 2024 regulatory approval for lifileucel. The market name is Amtagvi. And just, I know we have a very varied audience. I want to make sure we're all on the same page. So what this means is that we identify a patient. They have to have progressed on immunotherapy. If they're BRAF mutation positive, they have to have received BRAF BRAF targeted therapy. We then identify the tumor that we want to resect. The patient goes to the OR. The tumor goes to the manufacturer, which is Iovance. And over there, what they do is they essentially will separate the immune cells from the tumor. They will expand the immune cell repertoire, and then they ship the product back to us. Once we have the product in hand, we then admit the patient to receive non-myeloablative lymphodepleting chemotherapy. So they will get 7 days total of chemotherapy with cyclophosphamide and fludarabine. So then when the patient comes in, like I'm admitting a patient on Wednesday, that will be her day -7. And so from day -7 to day 0, she's receiving chemotherapy. Day 0, she receives the cell product, the TIL infusion, and then they will receive up to 6 doses of high-dose interleukin-2 on day +1, day +2, and then you are waiting for count recovery and, of course, hoping that there's no severe toxicity in the interim due to this myelosuppression. I want to point out that when we were running the clinical trial, the process time was 22 days, so 3 weeks. In the real world, we see that there are 5 weeks required for the product to be made. And so for any of you who have treated melanoma, you know that a patient whose disease is progressing, their disease is not always going to give you a 5-week runway to do all of this. Some patients will become clinically unstable in that time. It's no longer appropriate to put them through all of this. So we think very carefully about which patients we offer this to. And this is why early on, when I was talking about the treatment landscape, I said this is a great option. It's an option we use all the time, but it's not an option for every patient. And this is why more options are needed. These are the data that we saw from cohorts 2 and 4, which were using the same cell product of the pivotal lifileucel study. And you can see that the overall response rate in the 2 cohorts was 31.4%, including 6% complete response and 1 in 4 or 25% having a partial response. So let's look at another clinical vignette. This is a young man whom I have been treating in clinic for quite some time. He is 28 years old, and he presented with rapidly progressive melanoma of the right axilla. By the time I met him, he had already gone to surgery. He had had a wide local excision and sentinel nodes, which tracked to the axilla and the groin. So he had T4B and 2A, very high-risk disease. And soon after starting him on adjuvant PD-1, we had, of course, confirmed that his scans were clear. We started him on adjuvant PD-1, and he very, very rapidly progresses. And so then we were really scrambling in terms of what to do next. Anytime a patient with melanoma progresses, my own practice is to get another MRI of the brain, because we know there is such a high incidence, unfortunately, of brain metastasis with this disease. So we did that. We started him on dual checkpoint blockade with Ipi/Nivo while we waited to get information on his BRAF mutation status and HLA status to inform clinical trial decision-making. As soon as I started him on Ipi/Nivo, he developed 2 cranial nerve palsies in nerves 2 and 6, and he had continued progression. By this time, I had his BRAF mutation testing. We started him on targeted therapy, but he was the rare patient who very quickly progressed on targeted therapy. So, and you can see here for this patient, ctDNA has been a very good marker of his disease, as has his LDH. He went from 400 to more than double in a matter of 2 weeks, and that's never good. So what we did, because he is so young, we wanted to treat him very aggressively. We harvested tumor. We put him through the lifileucel process, and you can see that he has had a good response with significant reduction, not only in his LDH, which has peaked at over 1,500 by the time I admitted him, but also his ctDNA went back to being undetectable. So cell therapies are really the cell therapy we've discussed is the tip of the iceberg. There are many next generation cell therapy products that are coming down the pike. One of the difficult things with cell therapy is our need to utilize high dose IL-2, which is very toxic. I'm sure any oncologist knows what I mean when I say it's sepsis in a bottle. And so what Obsidian are trying to do is to move away from this need for IL-2. Their cell product is engineered to express a membrane-bound IL-15, which is fused to a drug-responsive domain, and that is induced by acetazolamide. So if you've ever been hiking at high altitude, you may have taken acetazolamide. You know it's very easy to tolerate, and this basically triggers expression of the IL-15, which is how the cell product is activated, and you don't need to put patients through high-dose IL-2. We have seen early phase data from heavily pretreated patients with an impressive response rate of 44%. Very, very small numbers, only 9 patients were disclosed from the phase 1 study, but they had all progressed on Ipi/Nivo. And the trial is now running. This is a multi-center, the so-called AGNI-01 study. And I think hopefully more to come from this agent. And enrollment is still ongoing. We've also seen Immatics's Anzucel. This is a T-cell product that is essentially engineered to have this PRAME-specific T-cell receptor, and it will bind to PRAME on the melanoma tumor cells. And PRAME is almost universally expressed in melanoma, 95% in cutaneous, over 90% in uveal. And again, the reason that the HLA is important here is that the PRAME is shown on the tumor cell utilizing the HLA-A O201 machinery. So if the patient's not O201 positive, mechanistically, they're not showing PRAME in the way that is required here. And so this is why HLA is required. HLA O201 is required. So this was a phase 1 study for patients receiving Anzu-cel. This was not a melanoma-specific study. This was phase 1, solid tumors expressing PRAME. And you can see here that one of the key differences is that we did not require surgery to do this. We did leukapheresis to get the cell product. So it's a faster turnaround time of about 2 weeks. And you can see here in heavily pretreated patients with many different kinds of cancers, the response rate is about 48%. So that was really nice to see from the early phase data. And more recently, we've seen data from a melanoma cohort, a uveal melanoma cohort. So of course, very different than cutaneous melanoma. But the ORR is, I would say, unprecedented in this disease at 67%. And so this is running in phase 3 now. And this is the SUPREME trial, which is enrolling globally. And patients are randomized 1-to-1 to receive a one-time infusion of Anzu-cel versus investigator's choice. The investigator's choice can be immunotherapy or chemotherapy or even standard of care cell therapy product. So in the interest of time, I didn't really heavily get into bispecifics, but just for completion, I will note that there are bispecific T-cell engagers that have been used as standard of care for several years. For example, tebentafusp or Kimmtrak in uveal melanoma. That's a bispecific T-cell engager that binds CD3 on the T-cell and binds to GP100 on the melanoma cell. That same agent, tebentafusp, is in clinical trial for patients who have PD-1 failed melanoma. So that trial is actively enrolling. There's another T-cell engager, which is binding to PRAME on the melanoma cell, and that is called brenetafusp, and that is actively enrolling in the frontline setting. So I think a lot more to come in this space. So to try and put it all together, we are now in the era where biomarker testing doesn't only include molecular testing, BRAF, and then we have trials, of course, for NRAS. Hopefully down the line, we'll see NF1. So we do molecular testing, but we also now do HLA typing. ctDNA monitoring, which is not approved in melanoma and is certainly not a standard of care test, is helpful in some patients and certainly something that's used in the investigational setting. As cell therapies become less toxic, less demanding for the patient, we may be considering them more and more frequently. And I would urge you to always think about clinical trial, because the way we got from a median life expectancy of less than 6 months with metastatic melanoma to now 10 years plus, seeing 55% melanoma-specific survival with Ipi/Nivo is really through clinical trials. So we have great frontline options, but half of patients will progress. We need less toxic options in the second-line space. One major gap in the field is the lack of predictive biomarkers. We need to be able to predict who's going to benefit and who isn't. Imagine if I knew from the get that the patient in front of me is in the 50% who is just not going to benefit at all to immunotherapy. You might start with targeted therapy. You might start with cell therapy. I've tried to give you a flavor of all the major clinical trials that are pending readouts, certainly more to come there. So I will stop there, and I wanted to thank all of the patients that we see who really take part in all of these trials, all of our lab teams and our sources of funding support. Thank you so much, and I will be happy to try and answer any questions if time permits.
Thank you very much, Dr. Najar, for an informative talk. And I'm going to introduce our next speaker, Dr. Stephen O'Day, Chief Medical Officer at Agenus, who is going to talk about pioneering immunotherapy. Professor, the floor is yours.
Can you hear me?
Yeah.
Can you hear me?
Yes.
Can you see my slides?
Not yet.
Let's see. You have some suggestions?
Can you share your screen? Press H and it will share.
I'm pressing H.
No, but I still cannot see your slides. Dr. Steven, maybe we will take a 5-minute break until our technical team will figure this out. Thank you.
Dr. Stephen. Once again, I'm representing our next speaker, Dr. Stephen O'Day, Chief Medical Officer at Agenus, who is going to talk about pioneering immunotherapy. So, Dr. Stephen, you can start.
Can you hear me now?
Yes, and we
Okay,
can also
thank
see
you
your
so much.
screen.
I'm so sorry about the
No, that's
delay.
okay. That's totally okay.
Okay. So thank you for giving me the opportunity. After almost 35 years in the field of immunotherapy and melanoma, it's a great pleasure to sort of give you my overview of sort of lessons learned and what we've achieved in melanoma. And more importantly, in the last 5 years, I've been focusing as Chief Medical Officer at Agenus of the next generation of immunotherapy drugs to really address unmet needs in poorly immunogenic tumors. Let's see, I'm not able to advance here. Oh,
Dr. Stephen, you just can scroll down and we will see the pictures, or you can go to the full screen mode.
how do I?
On the right corner from the down part, there is a full screen mode. Right upper corner, and there is a present button. You can also press that one.
I'm sorry. Oh, here. It's nothing is enabling right now.
But you can still scroll down, and we can see the slides also that way.
It's not allowing me to scroll either.
Or you can try pressing right arrow. Maybe this way you can scroll down. Or you can manually click on the slide from the left part. When you see all your slides, you can manually click on each slide. This way, I think, will work.
Yeah, the screen is frozen at the moment, unfortunately.
Okay, once again, we are going to have a short break and we will come back. Dr. Stephen, you can start.
Okay. Okay. Can you hear me?
Yes, perfect.
Okay. I'm hearing an echo. Can you hear me now? No, it's echoing.
Yes, you can start.
Is there a way to stop the echo?
Excuse me, can you repeat?
I'm hearing an echo.
No, I'm not hearing that.
Okay. So when we think of oncology, we think of really malignant hematology and solid tumor oncology. And over the course of my career, obviously, I started in malignant hematology, and it's a very different paradigm where there's multi-drug chemosensitivity, high doses of chemotherapy, and bone marrow transplant have led to remarkable curative potential. However, in solid tumor oncology, it's been plagued by dominant tumor heterogeneity and really relative chemo and cytotoxic resistance with short responses and early multi-drug resistance. So the history of solid tumor oncology prior to the immunotherapy of melanoma was really marginal incremental benefit in median survivals, but non-curative setting in the metastatic setting. The melanoma model really was solid tumor immunology in a very different perspective than sort of cytotoxics. Melanoma was a highly immunogenic tumor due to its UV exposure and high TMB. In fact, there were rare immune spontaneous regressions, as well as characteristics of dormancy and late recurrences, all suggesting an immunologic effect. We also knew there was rapid progression during systemic immunosuppression of melanoma, highlighting really its close interaction with the immune system. And finally, non-specific immune responses resulted in tumor regression in melanoma early on. So we knew there was something going on in melanoma that looked very different than other solid tumors, which were in general poorly immunogenic. Now, when I started my career, and in the early 60s and 70s, prior to my training, really the life of melanoma patients was that they were on average 45 to 50 years. They endured very wide local excisions, extensive lymph node dissections, which were morbid. And then they had to watch and wait. And this was one of the most highly metastatic tumors known. And there was no effective adjuvant therapy or metastatic therapy because these tumors were primarily chemo and cytotoxic resistance. There was rapid regression from metastatic disease to death with early CNS predilection, which was a hallmark of melanoma. Median survival was 6 to 9 months, and 5-year survival was less than 5%. This was reality and what gave melanoma a bad name for cancer, really a heartbreaking situation prior to the advent of immunotherapy. Now, between 1980 and 2000, there was really tremendous pioneering work done by a number of major surgical oncologists as well as medical oncologists. And these were pioneers such as my mentor, Don Morton at UCLA, Steve Rosenberg at the NCI, Charles Balch, John Kirkwood, more recently Mike Atkins, and many, many others. And over the course of these 20 years, there was some really transformative work in which we were able to narrow the wide excision margin on the initial treatment, as well as this transformational procedure developed by Dr. Morton of sentinel lymph node staging, where we could test one lymph node, and if it was negative through careful sectioning, a completion morbid dissection was not necessary. And then in addition to this, there was pioneering work in sort of surgical resection of distant disease when biologically favorable. So a lot of effort was made in terms of metastatic, doubling time, sites of disease, and using surgery strategically for two reasons. One, because the biology made sense, but importantly, we didn't have any adjuvant or systemic treatment options. It was in this setting that really early immunotherapy arose, initially with non-specific BCG, both in the adjuvant setting and intralesionally, the first use of intralesional non-specific immunotherapy. Vaccines were used across a number of different settings and a number of different vaccines types. But again, none of these were strong enough to impact patients in any substantive way in terms of larger clinical trials. These were the eras where high-dose cytokines were used, interferon and interleukin-2, interferon in the adjuvant setting and interleukin-2 in the metastatic setting, early use of TIL cells with high-dose IL-2 at the NCI, and then early in my career, biochemotherapy. Now, with high-dose cytokines, we were able to cure a small number of patients at great cost with a year of interferon in the adjuvant setting, and we were able to cure 5 to 10% of patients with high-dose IL-2 in the metastatic setting. TIL cells also produced durable responses in a very small subgroup of patients. Biochemotherapy resulted in much higher response rates. However, early CNS death and the prevention and the inability to prevent CNS deaths really limited biochemotherapy. It was in this setting of high-dose cytokines and biochemotherapy with limited success that really the checkpoint revolution was really launched, and really the first revolution of IO in melanoma beginning approximately 25 years ago. Now, there are two really important checkpoints, CTLA-4 and PD-1, and people confuse them that PD-1 is just a better version of CTLA-4, but in fact, they're very, very different. They have different compartments and different kinetics and different roles in terms of T cell activation. CTLA-4 is in the periphery of the immune system. It's activating in lymph nodes, antigens, it's expanding T cell repertoires, building an army of T cells that then go to battle. And PD-1 is the fuel that keeps T cells from exhausting, particularly in the microenvironment. So these were two really seminal checkpoints that really launched the revolution in melanoma. Now, before we get into some of the details, I want to just raise, this is a picture of Jim Allison, the Nobel laureate for CTLA-4 from his early days of really talking about how he saw CTLA-4's ability to produce tail of the curves. And our seminal study of randomizing ipilimumab to a peptide vaccine really in 2010, which I was able to give the plenary session at ASCO, a randomized trial showing the benefit of CTLA-4, really was the hallmark of the beginning of the checkpoint revolution. Before I get into that trial, though, I want to go back to some of the early lessons that we learned from CTLA-4. Number one, the overall RECIST response rate was quite low in phase 2 trials. Really, only about 1 in 10 patients had objective responses. And yet, the disease control rate was about 1 in 4 patients. And these were the long-term survivals. These included stable disease and objective responders. And we ended up curing approximately 1 in 4 patients with single-agent CTLA-4. The trial, of course, really defined this, showing overlap of curves in the first 6 months as the army of T cells and the repertoire was expanding, and then separation with a median survival difference, but most importantly, a plateau without treatment beyond about 3 months. This was only 3 months of treatment, showing unsustained treatment-free survival and cure in approximately 1 in 4 patients. This was revolutionary because we were not treating the cancer. We were simply releasing this very important first break of immunity. We also learned that it took time for these responses to develop. And you can see here from one of our early patients, in the first 12 weeks, there was inflammation and even tumor growth. And then between 3 months and 6 months, tumor regression. And this really captured the kinetics of building the army of T cells and sending them to battle. But once they were engaged and tumor was eradicated, it was durable and complete over time. The same visuals were seen in the liver with early progression or pseudoprogression, as we called it at that time, at the first 12 weeks. And then without any further therapy, regression and complete resolution and cure over time. This had never been seen with prior cytotoxic therapies. So what were the lessons learned and transformations of CTLA-4? First of all, the kinetics of the immune response to build the army and repertoire of T cells took months, not weeks. There were deep, durable responses that were beyond complete responses, meaning partial and stable responses were durable. And toxicity was both friend and foe, meaning that it correlated with outcome. This was a very important lesson learned, that immune-related toxicity, if managed well, would correlate with better outcome for obvious reasons. Finally, more is not better, and actually early discontinuation for toxicity actually correlated with better long-term response. And this is because patients' immune system and toxicities titrated to their self, the self-titration. And there were actually, even when patients did progress, there were favorable patterns of progression, oligo progression, and local therapies that did not require further systemic therapy. Mostly the lessons learned from CTLA-4 is a limited exposure of releasing this primal breakpoint, checkpoint of immunity, led to long-term survival plateaus and cures in widespread melanoma. Now, over the course of the next 10 or 15 years, we added PD-1 drugs that in and of themselves in a hot tumor were very effective, again with 30% plateaus, and then combining the CTLA-4, which is the expansion of the T cells and repertoire, the building of the army, and then fueling the army with the PD-1. You can see now we are curing over 50% of patients with widespread melanoma, including brain metastasis. And this was really the phenomenal change we saw in the clinic, from everyone dying or to almost 50% or more of patients with long-term survival with advanced disease. Now, early on, there was some other seminal work as checkpoint were competing with targeted therapy, BRAF/MEK therapies, and other highly active therapy in melanoma. And then we had two dueling frontline treatments for melanoma, CTLA-4 PD-1 and BRAF/MEK combinations. And a very important DREAMseq trial suggested which was the best approach. And Mike Atkins led this trial. You can see in red the targeted therapy and in blue the combination immunotherapy. And despite early survival disadvantage to the immunotherapy for the first 6 months, it rapidly crossed and then plateaued with significant survival benefit when you initiated with IO and followed with the BRAF, as opposed to starting with the BRAF and following with the IO. And this was because of the durability of the responses to the PD-1 and the decrease in CNS metastasis with this approach. And this was the 5-year data from this. Despite similar response rates, you can see an absolute difference of 5-year survival when you started with the IO followed by the BRAF/MEK. And this is because duration response at 5 years to the IO was 75% versus 24%. And the 2-year CNS-free survival was almost 90% versus 60%. So immune therapy works in the brain, it's very durable over time, and is the initial first best treatment in BRAF mutant patients. Very shortly thereafter, we moved from the metastatic setting to the adjuvant setting, with CTLA-4 monotherapy established as beneficial in the adjuvant setting in high-risk melanoma. And then this was replaced with PD-1 monotherapy in either BRAF wild type or mutant, being superior to CTLA-4, and BRAF/MEK was an option in the adjuvant setting for BRAF mutant melanoma. But two very important melanoma patients, really seminal New England Journal publication, showed that perioperative and neoadjuvant was the best use of immunotherapy as opposed to pure adjuvant therapy. One was the SWOG study by Patel, and the other was the NADITA study by Blank. So as you see here, the SWOG study, this was with 3 doses of a PD-1 prior to surgery in high-risk melanoma, followed by 18 doses after versus all 21 doses after surgery. Just that limited exposure to a PD-1 with an intact tumor led to a substantial survival benefit. This perioperative PD-1 being better than adjuvant therapy. Very important, groundbreaking work showing that an intact tumor was important for the immune system in early stage disease. This was further confirmed in an ADENA study where neoadjuvant ipi-nivo compared to adjuvant therapy with PD-1, you can see substantial survival benefit from neoadjuvant ipi-nivo. And in approximately 60% of the patients who had complete or near complete responses or major pathologic responses, no adjuvant therapy was necessary. So this study has really established that a limited exposure of neoadjuvant therapy, if you obtain a deep, durable response, is sufficient to prevent recurrences substantially versus using it in the adjuvant setting. So that was the story of melanoma, using IO in the late stage and then moving it to neoadjuvant setting. But there was still a fundamental gap in the IO revolution. And this was the vast majority of tumors did not respond and were poorly immunogenic. And most people thought it was a PD-1 problem, but it really was, in my view, a priming and a CTLA-4 problem. Our first generation CTLA-4 simply were not effective enough at priming and building a T-cell repertoire in poorly immunogenic tumors. And the challenges of the TME were also clearly evident. In addition to deficits in priming and early activation, the hostile TME environments were also limiting our ability to move the IO revolution from melanoma to other tumors. But the field moved away from CTLA-4 and saw it as a more toxic version of PD-1 and continued to add non-CTLA-4 combinations to PD-1 in warm tumors with modest success, but really leaving behind poor tumors where without T cells infiltrating and recognition of the immune system, there really is no ability to drive T cell eradication. So how do we get to immunotherapy 2.0 beyond melanoma? Well, obviously I've alluded to it, but I really feel it's in building priming, and obviously mRNA vaccines are an important component to checkpoints, but also I've been working the last 5 years at Agenus with a next generation CTLA-4 that has multifunctional properties, both at the early priming and activation stage, but also in the TME. And the drug that we've been focusing on is botensilimab, and we call it not a next generation CTLA-4, but really a multifunctional immune activator. It has 3 point mutations in the Fc component of the CTLA-4, and this causes a more potent synapse with APCs and NK cells, leading to more priming, activation, and repertoire expansion, particularly in poorly immunogenic tumors. It also activates APCs and myeloid cells and repolarize them. Importantly, it has a profound Treg depleting ability in the TME, and it also blocks complement, which may have some important safety indications, particularly complement-mediated hypophysitis, which we essentially have abrogated with this approach. And in the next portion of the talk, I really want to show you we've treated a lot of patients now in many advanced poorly immunogenic tumors. I want to focus on our data in advanced colon cancer with the next generation CTLA-4 botensilimab combined with our PD-1. Here's a late line setting where we're combining botensilimab and balstilimab in patients who are refractory to multiple lines of therapy in MS-stable colorectal, a cold, poorly immunogenic tumor. Remember, 90 to 95% of colorectal cancer, when it metastasizes, is MS-stable. Only about 5 to 7% is MSI-high. Now, MSI-high colorectal cancer is highly receptive to immunotherapy, but MS-stable is not. And here's our data from our expanded phase 1 trial of 123 patients. In this setting, they have failed first, second, third line, sometimes fourth and fifth line chemotherapy and antibodies. And you can see that objective response rates now are 20% with RECIST. You can see the durability of the response, the disease control, and the prolonged stable disease. This is what good immunotherapy looked like in melanoma in its early days, and this is really a cold, poorly immunogenic tumor. Now, as we see our survival data, which will be updated with another year of follow-up at the ESMO GI conference this month, you can see our median survival is 20.9 months. Historically, these patients would have 10 to 14-month survival. So we appear to be more than doubling with this single-arm trial. And whether you're third line or fourth line, you still have very similar median survivals. And you can see the emergence of a plateau. And with another year follow-up, this will be more defined. This is the first solid tumor IO-only trial showing both a prolonged survival, but also importantly, evidence of plateaus with a CTLA-4 that is expanding T-cell repertoires. Toxicity has been similar to other checkpoints. The GI toxicity is our dominant toxicity. We do not see hypophysitis, and overall see less visceral toxicity. The main toxicity has been diarrhea, colitis, and we're managing this with bridging low-dose steroids and early TNF, which has been a very effective strategy to reversing colitis, and has been used by the melanoma community in a steroid-sensitive setting to limit high-dose steroids and prolonged steroid tapers. Now, moving with this same regimen, just as we did in melanoma, from late stage to early stage, has been really the remarkable story in the last year to year and a half. On the top is an MS-stable, locally advanced 8-centimeter tumor with bulky nodes, and with just 1 dose of BOT and 2 doses of BAL in the neoadjuvant setting, you can see a complete clinical regression at 7 weeks, and surgery showed a pathologic complete response. This is the power of the neoadjuvant setting with an effective IO. The difference here is this is a cold tumor that historically has not responded. Below is a hot tumor, a similar very rapid response as you'd expect, with 1 dose of BOT and 2 doses of BAL in 6 weeks. So this regimen works obviously in hot tumors, just like melanoma, but more importantly, this larger group of patients with cold, poorly immunogenic tumors, we're seeing some pretty remarkable neoadjuvant responses. This data on the left shows a series from the US study with whether you give 4 weeks of neoadjuvant BOT/BAL with an MS-stable locally advanced colon cancer, or 8 weeks. In the dark blue, you can see just with further time from 4 to 8 weeks, the deepening of these neoadjuvant responses. And on the right, you can see MSI-high tumors. We did treat some of those, and obviously those are highly immunosensitive. What's important here is about 40% of patients with locally advanced MS-stable cold tumors with 1 dose of BOT and several doses of BAL in 6 to 8 weeks are having deep or near complete responses. ctDNA is being cleared in these tumors very effectively, and relapses to date have not occurred, and longer follow-up is continuing, and we're very excited about the ability of these deep responses to prevent distant recurrence, just as they did in the NADINA and other melanoma studies. There was another study in Italy that has confirmed the same findings with either single agent BOT or combination in the neoadjuvant setting in MS-stable or MS-high. And you can see here that just with 4 to 5 weeks of treatment, you can see with combination therapy is better than single agent therapy. And we're seeing deep responses in both MS-stable and MS-high. And on the right here, you can see that there is, with the combination, we still have not seen recurrences. So in both of these neoadjuvant trials, one in the US and one in Italy, we are seeing cold tumors, MS-stable and MSI-high tumors with deep responses, clearance of ctDNA, and absence of distant recurrence events, now with follow-up of more than approaching 2 years. Adverse events have been very manageable in the neoadjuvant setting. We have not seen hypophysitis. The grade 3 toxicities have been limited and reversible, and surgeries have not been delayed. So in conclusion, I hope I've given you a sense that in melanoma, we've gone from a disease that gave cancer a bad name, but because of its immunologic sort of essence, and building on the frontier of decades of work with immunotherapy, initially with non-specific cytokines and vaccines, and then moving to the checkpoint revolution, we've really changed the dynamic in melanoma from a deadly disease with short survival to now curing the majority of patients with widespread disease. What we've learned is as we move from advanced to early settings, that the best time for immunotherapy to be cured is in early settings of the disease where an intact tumor is evident. And now over the last 5 years, I've really focused on Agenus's work with botensilimab, a multifunctional immune activator that's a CTLA-4 that's been modified to both prime better and impact the TME and soften the TME. And it's really this priming and activation and then softening of the TME with a combination of a PD-1 that is starting to transform really the colder tumors. And now as we move into the neoadjuvant setting, the data is getting even better. So a lot of excitement around the next phase and the next revolution of IO. Thank you.
Thank you very much, Dr. Steven. It was very interesting to learn about clinical trials that shaped treatment of melanoma and also about drugs who are shaping it right now. So I'm going to introduce our next speaker, Dr. Ayuba Hannatu Usman, who is a consultant radiation and clinical oncologist at National Hospital Abuja, CEO of the Cancer Consciousness Initiative. Her topic is How I Treat Melanoma in Nigeria. Dr. Ayuba, you can start.
Hello, can you hear me? Good afternoon, good morning, good evening. I'm Dr. Ayuba Hannatu Usman. Can you hear me from there? Thank you. Thank you.
Yes,
next
we can
slide,
hear you.
please. All right, next slide, please. I am Dr. Ayuba Hannatu Usman, consultant and clinical oncologist at the National Hospital Abuja, with clinical focus of providing radiation and clinical oncology work, radiation and systemic therapy for solid tumors, and health equity with passion for health equity and regional challenges research. So just the next slide. I've not finished speaking. Thank you. So I do a lot of research. I'm an active research contributor to the Abuja City Cancer Challenge. I'm also a passionate health equity researcher, in which I coordinate the Tele-Oncology Hub program. I'm also an associate editor of the Nigerian Journal of Oncology. And for leadership, I have Cancer Consciousness Initiative, and I'm the program leader of Hub, a network of 20+ patient navigators, a health system strengthening initiative that seeks to provide access to cancer care for underserved communities in the northeast of Nigeria. Next slide, please. Melanoma is a malignancy of the melanocytes in the body. Mostly it's seen in the skin. However, it can affect many other organs in the body. In high-income countries, it's more of the sun-exposed skin disease. In Nigeria, it's a trauma-related, non-solar disease-related disease, and it strikes more of the soles of the feet, the mucosa, eyes of the individual. The dominant type we see is the acral lentiginous melanoma on non-sun exposed sites, more at the plantar surfaces of the foot or the subungual area that's under the nail and also on the palmar surfaces. The key risk factors of this disease include repetitive trauma to that part of the body, chronic irritation, albinism, and occupational exposure, however, not UV radiation. Why it's missed? It's missed in our communities because it's mistaken in many climes for chronic ulcers, fungal infections, or warts. We even have some communities when they have normalized having skin ulcers. We call it gulando in the north. These are awareness areas that you have to always key in for early detection of this disease, because when this disease is missed, it now goes to a bigger stage, and early detection is key. This is a disease that is characterized by an aggressive nature, early recurrences, distant metastasis is melanoma is the third most common of the skin, followed by squamous cell carcinoma and Kaposi sarcoma in Nigeria. And it's Can I continue? Next, please. These numbers tell a grave story. Melanoma is the third most common skin malignancy in Nigeria. 80 to 85%, it causes 80 to 85% of skin malignancy deaths. Also, 88% of this disease, when assessed, these patients present at Clark stage 4 or 5, that's advanced disease. And the mean breast lobe thickness at diagnosis is more than 5 millimeters. 84% of patients have 4 millimeters and above breast lobe thickness. 67% of tumors are ulcerated at presentation, and it accounts for 31% of all skin malignancies and 4.5% of all malignancies skin cancers constitute. Then it accounts for 31% of skin malignancies. So the peak age in Nigeria, as we see, is within 60 to 69 years. That's the 5th to 7th decade. The sex ratio is male is to 1, 2:1. Male is to female ratio is 2:1. And then the most common, the acral lentiginous type. So the barriers to timely diagnosis that we always harp on are health system delays, multiple referrals to different hospitals, limited specialist availability in different centers. Patients are exposed to going to long distances just to be able to seek for specialist care. Stigma. In our society, people fear as he or she has a wound in the body. Also, these wounds or ulcers can stay for months and years with the individual just managing. Also, financial barriers. Our patients see a lot of cancer disparities, the cost of biopsy, the cost of even the histological assessment in some centers. Some patients can't pay out of pocket, imaging and travel just to go to access care. These travel patients are exposed to insecurity on the road, family dynamics are disrupted. And then when they go, the logistic barriers, the linguistic barriers, the financial barriers, all these contribute to our patients presenting late. Also, the low awareness, public literacy on melanoma in the darker skin types is extremely low. It is not seen as our disease. It's seen as a disease of the white man. Then for albinism risk, we have persons with albinism, and this increases the risk. That condition increases the risk, and that is why they should have targeted screening and skin protection programs for such vulnerable populations. Next slide, please. Also, misdiagnosis. That public health awareness will go a long way in removing that barrier. For the diagnostic pathway at National Hospital Abuja, many of our patients present via different routes. Some come through the dermatology clinic, some come from the general surgery clinic or department, some come from the plastic surgeon clinic. However, these patients are triaged and then they are all referred for biopsies, which we prefer excisional biopsy, and then with these biopsy samples taken by the NCCN guidelines. We have an NDT team at the National Hospital, and we always discuss with them when they have such issues to follow the guidelines. The histological assessment, they always make sure they give us that information, the breast load thickness, the ulceration status, the mitotic rate, the margin status, the lymphovascular and perineural invasion values, CLACS, level of penetration, and the breast load. All these are what we look at in the histology report. Then the imaging. For the imaging, we utilize the CT scans, chest and abdominopelvic, CTs. However, we also use chest X-rays, abdominopelvic ultrasound scans, depending on where we want to assay or check, and then the PET-CT for systemic staging, MRI for selected cases. For molecular testing, the BRAF mutation testing is not available in Nigeria. So the individual has to self-fund for the testing and for the medications. And this is a critical gap affecting targeted therapy eligibility. It's often limited by cost and third-party laboratory logistics in Nigeria. Next slide. Unfortunately. Next slide. For the surgical interventions that we carry out, the standard of care for the primary lesion, we aim for 1 to 3 centimeters margin for lesions that are more than 2 millimeters thickness. The sentinel lymph node is technically challenging in our setting. We don't have a gamma camera at the National Hospital. However, we follow the guidelines on completion and therapeutic lymph dissection principles with the resources we have at hand. For the surgeries, when limb amputations are indicated, this is considered for advanced acral lesions where limb preservation is not feasible. That may have to be carried out. If it involves the globe and it is reviewed and seen that it's confined, patient is counseled and patient may have to have an enucleation. For skin cover options, the plastic surgeons carry out the primary closure when needed, or skin grafting or flap rotation as appropriate. We have an MDT team with the radiation and clinical oncologists, the plastic surgeons, general surgeons, radiologists, and oncology nurses, nuclear medicine. We have a rich community of radiation and clinical oncologists, and I really appreciate our chief consultants, Dr. Festus Ibenoba, my coach and trainer, Dr. Oyeshegun, my coach and trainer. They are all our chief consultants, and we have so many other senior colleagues in the country and abroad, and we always reach out to them whenever we have cases like melanoma, because we hear about TILs, we hear about adoptive cell therapies, we hear and even the immunotherapy medications. So we have this very wonderful community in which we, as soon as we have such cases, we
So we are having some technical problems. We are going to continue in a second. Your screen actually is frozen and we cannot hear you. I think you have some connection problems.
Biotech is moving fast. New breakthroughs, major clinical updates, company moves, regulatory decisions, and industry shifts are happening all the time. But keeping up with what actually matters can be difficult. That's where OncoDaily Biotech comes in. We bring you timely, relevant, and engaging biotech news in one place. From innovation in cancer care to broader developments across the biotech space, including research progress, funding news, partnerships, emerging technologies, and the stories shaping the future of medicine. Whether you're a healthcare professional, researcher, biotech leader, investor, or simply someone who wants to stay informed, OncoDaily Biotech helps you stay connected to the news that matters. Follow OncoDaily Biotech and join a growing community exploring the future of biotech one update at a time. Artificial intelligence is quietly reshaping oncology, not in theory, but in how we think, how we work, and how we decide. Across the world, researchers and clinicians are moving with it. Different places, the same moment. A pause, a realization, a decision, and then they move. On May 30 in Chicago, during the ASCO 2026 annual meeting, these paths come together. OncoDaily Grand Rounds, AI and Oncology Edition, organized by OncoDaily with ZS as exclusive partner. Become part of the AI oncology community. Register now.
Dr. Ayuba, can you hear us?
Thank you very much.
Yes.
Thank you, Sona.
So you are back, and please continue.
Yes. All right. So next slide, please, for the radiation treatment. For the radiation therapy at National Hospital, we also give adjuvant radiotherapy, this following nodal dissection in high-risk patients, targeting regional basins to reduce locoregional recurrence. We also give palliative radiotherapy for unresectable disease, nodal satellite or in-transit disease, and for residual local disease and previously treated sites. Then brain metastasis, whole brain radiotherapy, and stereotactic approaches used for CNS involvement, which is a common presentation at advanced stage. And for painful bone metastasis, palliative painful bony deposits is a critical component of our holistic pain management approach. And we utilize our linear accelerators at the National Hospital, providing precise conformal radiation therapy. Next slide, please. The systemic treatment gap we have, the global standard of care talks about giving nivolumab and ipilimumab or nivolumab monotherapy or pembrolizumab. This is extremely limited in our setting entirely when patients have to pay out of pocket. Every treatment is like a financial negotiation. Then targeted therapy. For the BRAF and MEK inhibitors, it's available only when patients can self-fund for
Dr. Ayuba, can you hear us? Sorry, but I'm not hearing you. Not hearing you. No, sorry. I cannot hear you. Sorry, but still I cannot hear you. Maybe you can check your microphone.
Hello, can you hear me now? Hello,
Yes,
can you hear me now? Hello, can you hear me now? Hello, can you hear me now?
yes, but I cannot disconnect from the other laptop. I think I'm hearing myself.
Okay, can you hear me now? Okay, can you hear me now?
Yes.
So the radiation therapy at National Hospital, we give adjuvant radiotherapy, palliative.
Dr. Ayuba, I think the issue is with the laptop because with the previous one, I was able to hear you, but with this one, again.
On my tablet and the other computer. Can you hear me now? To finish. Hello. Hello.
Yes, I think now is okay. Can you once again?
Yes, so next slide. The systemic treatment gap in Nigeria is glaring. The Nigerian reality, patients can't afford the immunotherapy and the targeted therapy. So most times we pivot to the systemic chemotherapy. Dacarbazine is one of our most common first-line agents using the Dartmouth regimen, and we use the temozolomide. However, when patients can afford the we encourage them to use the immunotherapy. So out-of-pocket expenditure is the single largest barrier to modern therapy. No health insurance covers immunotherapy, and there are no patient assistance programs that exist for melanoma in Nigeria. Next slide, please. Thank you very much, Sona. Thank you all for understanding the challenges we have with the network here. Thank you very much.
It's okay.
Next slide, please.
Glad you are back.
In the National Hospital, we also carry out palliative and supportive care. We look at all the domains of care. From the biology, we understand how this disease is aggressive and of treatment that should be given, and we give it as per the guidelines. Then for the physical symptoms, patients may have diarrhea, vomiting, pain, wound, issues with the wound. We manage them all by the guidelines, ensuring that all the drugs needed for these patients are given as per the guidelines. For this psychosocial support, we encourage the family, we counsel the patient with the family members, and they understand the condition of the disease, so they are able to give support to their patient. We also give emotional support. Our oncology nurses speak with our patients. We have a patient navigation arrangement in the department, and this goes a long way to help patients navigate barriers to cancer care. We also encourage spiritual management in all the domains of care: bio, physical, psychosocial, and spiritual. For the spiritual, we have faith leaders and some community clergymen that pray for patients. However, we also encourage the patient to seek for the family, community, and their own men of God to pray for them. So we all ensure that we look at all those domains of care, and we manage our patients looking at all these domains, ensuring these patients are managed. For the wound care, we have the oncology nurses. We have a wound care arrangement. The nurses make sure they clean the wounds, cover them well. Whenever we have torrential bleeding wounds with fungation, exudate, they call us, the doctors, and we supervise with them. These wounds are made clean, and the patients have better quality of life. For the pain management, we follow the WHO pain management ladder. We have adjuvants and analgesia in the hospital, and the syrup morphine, which is compounded from the stock that is brought from the Federal Ministry of Health. So our patients are able to receive pain care, wound care, psychosocial support, and all the palliative care and supportive care that the patients need. Next slide, please. So the multidisciplinary collaboration at national board meetings ensure that every patient gets an individualized plan despite the resource constraints. The dermatologist, the histopathologist, the surgical oncologist, the radiation and clinical oncologist, the radiologist, the oncology pharmacist, we all work together to ensure that these patients get the best that the context can give by the guidelines. Next slide, please. These are the many faces of melanoma. You can see the left side. This is a sole of a footballer's foot with a noted plantar melanoma. The next picture shows radiation treatment plan. It's a palliative radiotherapy treatment plan in process for a patient with advanced orbital disease with brain metastasis and painful bony deposits. The picture above at the mucosal site there shows that shows metastatic lymph node of the inguinal region in a patient with a plantar melanoma primary. And then the last picture here shows the mucosal melanoma of a patient in the ward. Next slide, please. The systemic barriers include costs. We talked about the cost of immunotherapy in our setting. We don't have any patient assistance programs for melanoma immunotherapy or targeted therapies, and there are no clinical trials available. So every treatment decision is a financial negotiation. For access, specialist oncology care is concentrated in a handful of urban centers. Patients have to travel hundreds of kilometers for diagnosis and treatment. BRAF testing requires third-party laboratories sentinel lymph node is technically and logistically challenging. And that is why, because with the access challenge we have for cancer care, I am a very passionate oncologist with health equity always at heart. And that was why we organized initiatives providing patient navigation, virtual MDTs, on giving oncology specialists care to patients in underserved communities, in which we carry out with telemedicine consultations and telemonitoring. And this is a very key intervention in our health system. For awareness, public literacy on melanoma in darker skin types is extremely low, and healthcare providers at the primary level frequently miss these signs. Melanoma is not prioritized in all the national health policy or cancer protocols. Next slide, please. So this is my case presentation. I present a 30-year-old a 30-year-old female who was diagnosed with left uveal melanoma. She had an enucleation, stage 2A, confined to the globe, class 2. No adjuvant local treatment was given. This patient was followed up for 5 years abroad, where she was working with regular ophthalmic follow-ups and CT scans, and there was no evidence of metastasis. However, in the fifth year, CT scans revealed a solitary mass in the liver, 8 hepatic segment. A liver biopsy confirmed melanoma metastasis, and the disease was initially managed at once. This patient had neoadjuvant immunotherapy, nivolumab and ipilimumab. She had 3 cycles followed by 6 cycles of nivolumab. She underwent a liver-directed therapy, that's the transarterial chemoembolization. This was performed, and she had 3 more cycles of nivolumab. Then she was laid off. She returned to Nigeria with no job, and she felt very helpless. When this patient came to my consulting room, her and her parents, we reviewed her staging investigations. She was frantically trembling. She was trembling. She was anxious. She was worried about her fate. What would her fate be? There is no work, no job for her to carry out. She can't fund immunotherapy. Looking at her parents, her mother and father in the consulting room, she was trembling very. And then we encouraged her to look at the brighter side. You have a loving, supportive family. This was how we encouraged her throughout this her journey. She then underwent 3 adjuvant cycles of nivolumab here in Nigeria, and we monitored the liver lesion. Next slide, please. We monitored her with MRIs, and the MRI showed tumor response. There was mild liver, the lesion had regressed mildly when she had returned to Nigeria after the test. However, by the guidelines, she needed more systemic treatment. The liver lesion as of March 2026 showed 4.25 by 3.7 centimeters homogeneous, no cavitation. And the last dose was in October 2025, in which I give her nivolumab. I even increased the dose from 190 to 240 milligram. So this shows you the access challenge our patients have. The outcome of cancer should not be defined by where she was abroad. You could see she had the treatment by the guidelines. She had the enucleation. It was a confined disease. They followed her up for 5 years, no default. When there was a lesion, the metastatic lesion was seen. She was commenced on neoadjuvant immunotherapy. She had the liver-directed therapy. She had the adjuvant immunotherapy. And then coming to Nigeria now, financial toxicity is a big challenge. She can't access immunotherapy despite this tumor is responding to treatment, laid off during treatment, and no patient assistance program to turn to. And then resilience. We had to, because she had severe anxiety disorder, we had severe counseling sessions with her and her parents, and I referred her to see a clinical psychologist in the hospital and also at the Project Pink Blue Psychological Trust. We also gave her a link for the NHIA insurance gift ship. Also, she underwent ophthalmic reviews. I also linked her up with the Nigerian Cancer Society, Cancer Coalition of Cancer Survivors, Dr. Bejide, may so rest in peace. All this social integration, I felt it would help with us, that psychosocial support. And then she always told me, Dr. Ayuba, you keep joining me with these cancer survivors, and I've not seen anyone that has survived melanoma. I told her, I said, you and pharmacist Hawa Idris are our melanoma champions. Don't worry, you have been lucky. You were able to receive the immunotherapy at the right time by the guidelines, and you see, you're here with us. And by God's grace, you're going to be getting better by the day. However, now she has gotten a job. I practically had to be her patient navigator. Her parents call me, what do we do with this? And then we guide her. And now she's able to secure a job, but she still cannot fund immunotherapy. This is the access challenge that is visible in the Nigerian reality. Next slide, please. And that is why psychosocial support is very important. She's responding to treatment. She cannot afford the next dose. This is not a rare edge case. This is the standard experience for melanoma patients in Nigeria. So what can drug manufacturers do? Patient assistance programs, tiered pricing, compassionate use access. What can international oncologists do? We are extending our hands to collaboration, to research, to capacity building of our healthcare workers, to supporting telemedicine programs, especially these ones that we carry out for underserved communities. We are trying to see that as much as possible, we are able to break that vicious cycle. Those barriers, reducing them as much as possible. What can policymakers do? Government subsidized immunotherapy, national melanoma strategy, the NHIA coverage, and also enabling so many other programs, the National Cancer Intervention Fund, the National Institute for Cancer Research and Training. So much health system strengthening is already in place, but we need more. We need more to be able to boost and support the care of such patients. Next slide, please. So the vision for improvement, early detection, public health campaigns on acral skin literacy, community screening, telepathology, telemedicine to extend reach, early referral pathways from primary care, research and partnerships, encouraging clinical trials, research to understand melanoma in our populations and the drugs that work more for our African populations. Also, data and registry, we have to strengthen our data, our cancer registries, the Abuja Cancer Registry, to be able to track real-world outcomes, encourage collaboration across Federal Ministry of Health, NICRAD, National Cancer Control Plan, the Nigerian Cancer Society, pharma groups, NGOs, and research consortia. This is something that collaboration, multi-sectoral involvement is needed. And also government subsidized immunotherapy, equity, national melanoma awareness strategy, the NHI expansion to cover oncology, biologics, and no more out of pocket life or death decisions. Next slide, please. I do the science of caring for cancer patients, and I also do the art of cancer advocacy. This picture by the left shows the kickoff of our melanoma awareness campaign at the Mega Taraba Pinktober October 2025 Mega Rally and Town Hall meeting. There, our global ambassador, pharmacist Hawa Baba Idris, should be speaking with you. She spoke to the whole town hall filled with policymakers, community leaders, market women, students, healthcare workers, where she talked about skin cancer, melanoma, how it looks in the black skin, the kind of barriers she faced, and how she was able to manage. By the right is me, myself, and my team at the Tele-Oncology Hub FMC Jalingo. This is the telemedicine program that I coordinate, ensuring that we do telemedicine provider to provider telemedicine consultations, virtual MDTs to discuss patients, telemonitoring and patient navigation. And this has gone a long way to provide access to cancer care to individuals, people, populations in underserved communities in some collaborating centers in the Northeast. This kind of health system strengthening initiative is very important to break that vicious cycle. Patients go through a lot of health system barriers to able to access oncology care. And these are innovations that will go a long way to break that vicious cycle. Next slide, please. We also infused the melanoma awareness in our program because we have the hospital-based program and the community patient navigation. We are able to guide our community patient navigators to report when they see ulcers or wounds in the community. They take the picture images and send to us, and at the MDT we discuss, and these patients are now advised and referred to the hospitals where they are reviewed. By the left is our mega rally, the Taraba Pinktober 2025, in which we have our melanoma ambassador, pharmacist Hawa Idris, myself, and Dr. Nicholas, our MDT coordinator, because we know that we have to engage the community. We have to raise awareness about these conditions. We have plenty of people in the communities with different kind of lesions that are covering it out of fear of social isolation and stigma, and leaving such diseases to go very advanced before they present at the hospital. We extend our hands to collaborations, to clinical trials, to research opportunities, to be able to understand melanoma and to work on how we can really improve outcomes together. Thank you very much. The picture credit goes to Dr. Ibinoba, Festus Ibinoba. Some of these pictures we co-manage the patients with him. He's my chief consultant and co-trainer, and my other mentors, teachers. The picture credit goes to our Tele-Oncology Hub Archives and CCI. Appreciation to our National Hospital MDT team. Appreciation goes to our colleagues that we always call out for, and we discuss patients, and they're always there to support. Appreciation to my patients, cancer patients and survivors and their families, for providing that emotional support, for being there for their patients. You are doing a great job. Thank you very much. And appreciation to the Federal Ministry of Health, the National Cancer Control Plan, Abuja City Cancer Challenge, National Cancer Intervention Fund, the Nigerian Cancer Society, the NICRAT, National Institute for Cancer Research and Training. You are all doing a good job, but we need more and more and more health system strengthening to be able to support our patients. And together we'll improve melanoma outcomes in Nigeria. Thank you very much.
Hopefully. Thank you, Dr. Ayuba, for sharing insights from Nigeria. And I'm going to represent our next speaker, Hawa Papa Idris. She is a global melanoma ambassador and melanoma awareness campaign coordinator at the Cancer Consciousness Initiative. She's going to share her inspiring story about surviving melanoma. So you can start. Sorry, but I think we'll all again have the same issue. I'm not hearing you. I can't hear you, no. I think you can change the laptops with Dr. Ayuba. Okay, welcome back. But again, can you unmute the other laptop so we can hear the echo?
Hello?
Yes. Hello? Yes,
Okay.
everything's okay.
Okay. Okay. Let me open my slides here. Okay.
Okay, so now we are sharing your slides.
Okay. So, good afternoon, everybody. My name is Hawa Idris, and I'm a melanoma survivor. So I am a pharmacist, and before this disease, I was just an ordinary pharmacist going about my business of taking care of patients, of being an ordinary mother, taking care of our family, and just generally doing life. Then in the year 2021, I noticed a little speck on my toe and got diagnosed with melanoma, and that changed the course of my life. So I went through it and got treated, and somehow decided to hold the hand of patients that are going through it and help them through it. So turned my personal struggle into advocacy for cancer patients, especially for melanoma patients. So the next slide, please. Next slide, please. So what started as very little black dots on the heel of my left foot grew. I didn't notice it, honestly. It was just there. It was something that was just on my foot. I didn't think nothing of it. It started growing, however, and became a larger patch. And even then, it didn't bother me. In my community, such a patch is actually something that we kind of carry with pride. It is called the ink of God. And I thought that was what it was. But it was growing. It didn't bother me. It only started to bother me when the middle of it started hardening. It grew and it hardened and darkened. And all the ABCDEs of melanoma, all the classical signs, it showed the classical signs, but still, I had no idea what it was. It grew, hardened, and it started becoming itchy and full, and I paid more attention to it and started favoring the site if I go to salons for a pedicure and things like that. Then it broke and started exudating, and that was when I became really bothered, and I showed it to my general doctor, told her this was what I noticed on my foot. She wasn't worried at all. She told me not to bother, to just go on applying penicillin, which I was already doing, but it wasn't getting better. So one day I showed it to one of my colleagues at work, and I said, please check out what is growing on my foot. He looked at it and he controlled his emotions and told me that I should very quickly look for a surgeon that will take care of that, will look at it. So I saw a surgeon, and immediately the surgeon scheduled an excision biopsy. I went to the theater. I think 3 days later, I was at the theater, and I only became apprehensive at the theater because the nurse asked me if I was there for excision biopsy. Now, hearing the word biopsy now made me become alarmed and scared, because I knew biopsies had a lot to do with cancer. At that point, I didn't know that every tissue removed had to be biopsied anyway. But it was removed, and I was coming to the hospital every day for dressings. It took about 3 weeks or more before the result of the biopsy came out. I was at the hospital for the dressing, so I went to the lab and got my results, sat somewhere and read it. I didn't take it to the doctor, I read it myself. And the sentence popped out to me, invasive melanoma. And the word malignant showed up, and I had to convince myself, okay, I was like, between malignant and benign, which one is the bad guy? I convinced myself malignant was the good guy. So I walked on to the nurse to dress it. While I sat down and the nurse was dressing my foot, it occurred to me that definitely malignant is the bad guy. So, and usually when I'm there addressing, the nurse and myself, we exchange banter and we laugh. But that particular day, I was very quiet. So she tried to crack jokes and I was still very quiet. So she asked me, Hajia, what is wrong? I couldn't talk, to be honest. She asked have you gotten your results? And I said, yes. And it was at that point, but unfortunately, both myself and the nurse started crying. So next slide, please. So these are the next slide, please. These are the pictures of my left foot. The first picture on the left was the nodule when it was exudating and when it had become just before the excision biopsy. Then the next picture is a day after the excision biopsy, and the last picture when the wound had healed. Next slide. Next slide, please. So clinical, the surgeon, no, the previous slide, please. The surgeon did a very wide clinical surgery. The previous slide, please. Slides. Surgery, immunotherapy, and vigilance. Thank you very much there. No, previous slide, please. Back. One more. Yes, there. So clinical surgery. The surgeon did a wide excision of the area, and after the wound healed, I was referred to the oncologist. Unfortunately, the oncologist I saw did not have any structure for my treatment because she kept on sending me back to the surgeon. The surgeon kept sending me back to her. I went back and forth about 4 times, and I got tired, and I sat her down on the last visit and asked her what to metastasize to the inguinal region. So I told her asked her how do we do that, and she said I needed either to get a sample from there and do a biopsy or go for a PET scan. At that point, no PET scan in Nigeria. At that time, there was no PET scan in Nigeria. She told me that the best I could get a PET scan was either or in Ghana. So I asked her if I were to go to Egypt and do the PET scan and bring the result back, would you be able to have a structure for my treatment? And she said yes. So, but by the time I was able to gather some funds, get my savings, sell off some things, and went to Cairo, my son and I decided that since I was already in Cairo, I should just go ahead and explore treatment in Cairo. So the oncologist in Cairo prescribed a wider excision, so they had to widen the margin of the excision, and they did that. And I went through. They also removed some of my inguinal lymph nodes because after the PET scan they said that they saw some signs of the cancer at the inguinal region. So they took out my inguinal lymph nodes, and all of that was sent for biopsy, and it came out that there was no cancer at the inguinal region. So we're all very happy, celebrated and everything. I went back home for 2 weeks and came back, and they prescribed radiotherapy at the hill. That's at the primary site of the cancer. I did that for about 2 weeks, and I went back home. Unfortunately, about 3 months after I went back home, I noticed a growth at my inguinal region again. So I was worried. I went back to see my surgeon. I spoke to my surgeon in Cairo, and he said it was most likely fluid, but it became painful. So I went back to my surgeon in Nigeria, and he said he will see if it was, he used a syringe and tried to draw fluid. Unfortunately, there was no fluid coming out. So he scanned, and the radiologist assured us that it was the cancer. So I had to now start trying again to go back to Cairo. Due to some diplomatic issues, I couldn't go back to Cairo. I waited and tried to get a visa for Cairo, and I couldn't. So I started looking towards India. I spoke to them and I was told to come, and immediately I landed in India. The following day, I was taken into surgery, and the tumor was removed. And according to the doctor, all of my lymph nodes at the inguinal region were all removed. And I stayed in India to treat the wound and everything. And after about 2 weeks after that surgery, the drain just refused to dry.
Yes.
Sorry, your voice is muted. We can't hear you. Yes. Can you hear us? Because your voice is muted and we can't hear you. I guess it's some connection issue.
You hear me? Hello? Hello?
Yes, you're all right.
You can hear me?
You can continue.
Okay.
Thank you.
All right. All right. So treatment complications that I encountered. I remember during the treatment, I had to deal with some physical weakness, the problem of the drain that just refused to dry, and making daily activity very challenging, and also the fact that I was isolated. I was not at home. I had to travel abroad where I had nobody. So it was lonely. And I also had my leg just continued to swell because of the removal of the lymph nodes. My left leg, I still to this day have to wear stockings. I have to wear compression socks. So I also, the financial strain was tremendous because I at a point, I wondered how I was going to survive after cancer, because everything that I had to go into treating cancer and struggling to survive for cancer. Ongoing medical dependency, from compression garments to specialist reviews. The medical calendar never ends. Lymphatic complications. Lymph node removal causes lymphedema, which is a painful swelling that requires its own long-term management. Even though I have found relief from the use of compression socks and also from unconventional methods like the use of castor oil, I noticed that castor oil really helps in bringing down the lymphedema. Immune side effects. Immunotherapy can trigger autoimmune responses. And after immunotherapy, I developed some very interesting allergies that before I never had. For example, can't tolerate honey now, and honey used to be a staple of my diet. I can't tolerate fried eggs and things like that. And cumulative burden, I've spoken about the physical, emotional, and financial pressures compound as complications multiply. Next slide, please. The psychological weight of cancer. No one tells you about the battles you fight inside your own mind. The fear is unending. Every little patch I see on my skin now scares me. I have had about more than 12 points on my body cut off and taken for biopsy. Every little patch I see now scares me, and I have to go and I see my dermatologist, and sometimes he argues with me. No, it's not. I said, no, just take. I would always insist, take it off, let's go and biopsy. So I have about more than 12 scars on my body now from points or any discoloration I see, I take it, and I insist on having it biopsied. Constant medical uncertainty. I live under constant fear of the cancer coming back. I think this perhaps the worst weight of cancer that I carry. And anxiety, each time you're going for a scan, there's this anxiety that you go with, and having to go through PET scan, the whole machine thingy, and having to wait for your result, the period of waiting for your result, of being told, you wonder what the result is going to be. The loneliness and isolation, even though you're surrounded by love. Everybody, if you are stuck treating cancer, while the rest of the world, your friends and family are continue living their lives. And at a point, I called one of my friends when I was in India and asked her, Diane, it seems you guys have forgotten about me. You guys are going on your picnics, having your fun, and you've forgotten that I'm right here on my own. So the intense loneliness of cancer treatment. And perhaps the most serious stress of cancer treatments is the financial stress. Here in Nigeria, there's hardly any system in place to help cancer patients. Next slide, please. Next slide. So Dr. Anato has spoken about access and equity, the financial barriers to treatment, how expensive Pembro is. In India, while I was there, for the Indian patients, they had a system, the Ministry of Health. If you buy one vial of Pembro, the government will buy the second one for you. I tried to key into that. I wrote their Ministry of Health. I also wrote their Minister of Health. I spoke to the head of the hospital where I was getting my treatment, but they insisted I wasn't a citizen and I was not going to be able to participate in that. So, and there's no such thing. I even wrote the company that produces Pembro. I told them I was a pharmacist, and if they had any assistant that they could give me, if they could give me a discount, also they also declined, and I had to keep buying Pembro out of pocket. And because of that, I lost everything that I had. I had to depend on the goodwill of strangers and family and friends to complete my treatment. There's also the gap of innovation. There's hardly, when I was during my treatment, some of my friends that lived in the US, they actually called me and tried to get me into one clinical trial that was going on in the US, but that was not possible because I was not there, and I couldn't travel there. By then, I was financially exhausted and I couldn't even make any trip to India or anything like that. I also did a bit of reading and I heard about TIL treatment, something about using my lymphocytes and I don't know, manipulating them and being given back to me so that they can help fight disease. That also is completely unavailable in Nigeria. And the presence of critical, effective, and safe drugs also is a bit much more difficult to assess drugs, quality drugs in Nigeria. I remember my first dose of Pembro while I was in a hospital in Lagos, I had to pay a lot, almost double what I pay in India for it. So there's that gap also. And there's also the awareness deficit. That part is thinking to myself, what if I gotten this thing when it was just that little patch? Perhaps I wouldn't have
Biotech is moving fast. New breakthroughs, major clinical updates, company moves, regulatory decisions, and industry shifts are happening all the time. But keeping up with what actually matters can be difficult. That's where OncoDaily Biotech comes in. We bring you timely, relevant, and engaging biotech news in one place. From innovation in cancer care to broader developments across the biotech space, including research progress, funding news, partnerships, emerging technologies, and the stories shaping the future of medicine. Whether you're a healthcare professional, researcher, biotech leader, investor, or simply someone who wants to stay informed, OncoDaily Biotech helps you stay connected to the news that matters. Follow OncoDaily Biotech and join a growing community exploring the future of biotech one update at a time.
Come and remove this, Dr. Hannah.
We can hear you. You can go on.
Can you hear me now?
Yes, yes.
So let's go to the next slide, the power of we. Yes, so having gone through cancer, having finished my treatment, and I now do constant scanning and everything, I met up with Dr. Hannatu, or Dr. Hannatu met up with me, either way, and she encouraged me greatly to try and help other people going through cancer. And as a result, I have become a very strong advocate for people going through cancer. I have become a very passionate patient navigator, officially and unofficially. And recently, I had a sister that had to go through cancer, and I held her hand, and we went through treatment. Unfortunately, she lost the battle. And this was myself and members of my family in that picture, my brothers and my sisters taking a walk in the last Pinktober campaign in Jalingo in honor of our sister. So I'm committed to raising awareness in communities that have never heard of melanoma, that advocating for people when they see discoloration on any part of their skin to speak up and to see the doctors and ensure that it is assessed and dealt with, and encouraging regular skin screening and early detection. When I finished my treatment, I remember, as embarrassing as it was, I had to see a dermatologist that examined me from head to toe. That was quite an experience. It was quite embarrassing, but I do that now on the regular because I know what it means to catch it early. Next slide. So this is me, and next slide, please. I'm almost through with my presentation. This is myself and Dr. Hannatu at the very first kickoff of the melanoma awareness campaign, where I told my story to a whole community in the Taraba state of Nigeria. I spoke about my experience. I told about what I went through and how it can get really difficult if it is not caught early. Next slide. Next slide, please. During the fight for cancer, I put together this slide to highlight what is needed when one is fighting cancer. So one is in need of social support for the patients. Also, the caregivers also need some kind of support. Structured quality care. I spoke about how the very first oncologist I saw really had well, she has an idea, but there was no structure to the treatment. And as a result, both myself and her appeared kind of confused until I had to leave and go abroad to get some standardized and structured treatment. It seems now things are getting better with doctors like Dr. Hannatu. I noticed that they are more structured, and they have a system to it, and they have a whole team, looking after cancer patients. I spoke about also getting reliable access to effective evidence-based therapies, including immunotherapy and targeted agents like the TILs. Also, patient involvement. I remember when I got to India, the doctor he actually gave me a choice, either to do some, I think the oncologists call it adjuvant and non-adjuvant. He asked if I could do the surgery before the chemo, or if I wanted to take some chemo. Because I wanted the cancer out of my body immediately, I asked him to please do the surgery, and then we can do whatever is needed afterwards. So he did the surgery first, and then we proceeded with radiotherapy and immunotherapy afterwards. Next slide, please. So I got this generally just from AI, the survival that depending on the early and the stages of detection. Early detection, there's a 98% survival if it is detected very early, stage 1. When it gets to stage 3, which was where I was diagnosed at, the survival is at 63%, so I was one of the very lucky ones. And there's a rising survival immunotherapy, and immunotherapy is now changing the outcomes of survival. Survival is highly stage dependent, while immunotherapy is raising metastatic survival rates. Catching melanoma early remains our most powerful weapon. My journey from stage 3 towards full survivorship is a testament to the intersection of science and timing. I am a living proof that it is possible. I would advocate that clinicians, oncologists, all of the MDT that is in charge of treating cancer, to treat the human, not just the lesion. In the data of our survival, we do not forget the texture of our lives. Encouraging clinicians to move from tumor-centered discussions to patient-centered care, where the whole person is seen, heard, and treated. I hope that as I advocate, next slide, please. As I advocate for, next slide. As I advocate for melanoma and for cancer, generally, I hope that my advocacy will promote skill literacy, know the ABCDE of melanoma. Also, I'm hoping that there's some kind of equity in treatment of melanoma and other cancers, that the equity gap is somehow closed up a little bit, that those that have it good will also look down to those of us that are having it not so good and lend a hand and lift us up. Also, that I'm hoping my advocacy will foster innovation, advocate for support, research into adoptive cell therapies, TILs, and the next generation treatment in Nigeria, empower further advocacy. I hope that we'll formally integrate survivor voices into clinical decision-making and policy design. Next slide, please. So I would like to, next slide, please. I would like to thank first Dr. Hanatu for including me in this, for me to come to this symposium and tell my story. And I also very sincerely like to thank OncoDaily for organizing this and also for letting me come and tell my story of melanoma survivorship. Thank you very much. Thank you.
Thank you very much for your presentation. Sorry for this little break. And our next speaker is Adil Daoud, who is a medical oncologist specializing in melanoma and skin cancers and serves as co-director of Melanoma Center. You represent us triplets vs doublets. Dr. Daoud, stage is yours.
Hi, I'm excited to present today, and I'm just trying to figure out how to share my slides. I have a PowerPoint presentation.
There is a button in the middle.
Should I do screen share?
Yes. Or you can just click on H, letter H on your keyboard.
And then it's asked to share, allowed to share window. Is that right?
Yes. Yeah, that is.
Share screen. And then trying to. Share entire screen.
On the video button, and next to them is the screen share button.
Oh, I see that.
Yes.
Yeah.
Click on it, and I guess
that's a H.
Yes, or click on H.
Share screen. And then share entire screen. Trying to presentations. I'm seeing if I can upload my presentation. Okay. Okay, it looks like it's uploading my presentation.
Mm-hmm.
And
I guess it's.
Can you see? I can see that it's going through. Yeah. Sorry, it's just taking a minute to.
Yeah, no problem. Take your time. I guess it's MacBook, so why the letter H not working, because it's I guess it's only for Windows laptops and Windows PCs.
Yeah, maybe it is only for. Yeah, it's I have a Mac, so that's probably why it's not working. But it looks like it's uploading. Okay, it's a PowerPoint file. Okay, and I see that it's uploaded. Presentation has been added. Okay, so great. And then to forward my slides, I just press. Oh, not sure why that happened, but okay. And then to forward the slides, I just press plus or next. Okay, I got it.
Mm-hmm. Thank you.
Okay, great. So I'm excited to present. I'm thankful. Thanks for Melanoma Global Day and OnCare to inviting me to present this talk on frontline therapy in advanced metastatic melanoma. And the question that I was asked to address is the triplets versus doublets and sequencing PD-1, CTLA-4, and LAG-3. So let's just take a step back and look at checkpoints. So, we talk about checkpoints as the critical points that you need to overcome for successful immunotherapy. And so currently, our thinking is that if you look at tumors, most tumors, will naturally, deliver tumor antigens into the tumor microenvironment. And then these tumor antigens, in the presence of DAMPs and PAMs, will excite the attention of dendritic cells or antigen-presenting cells. And then those dendritic cells literally grab pieces of tumor membrane from tumor cells and then mature and present that antigen in lymph nodes. They basically migrate towards lymph nodes. And so a lot of the checkpoints that we talk about are actually co-stimulatory checkpoints, and especially CTLA-4 is like a typical example, but LAG-3 plays a role, PD-1 plays a role, and the TNF receptor superfamily like 4-1BB, OX40, GITR, all of these play roles. And then once your antigen presenting cell gets the attention of a T cell, that T cell basically migrates into the tumor microenvironment. And then in the tumor microenvironment, you have a further set of checkpoints, and PD-1, PD-L1, that's the classic example, but adenosine receptor, there are other checkpoints too, along with licensing that happens to T cells that also needs the presence of antigen presenting cells. And then at that point, the T cell basically, physically kills tumor cells, and then the cycle begins again. And so if you look at T cell exhaustion, it is basically the way depicted in this slide from made several years ago. So what we think is that when naive T cells are stimulated by antigens and dendritic cells, like I showed in the previous slide, in the case of infections like flu and etc., what happens is that T cells will basically become memory T cells, and that's what vaccines do. That's what acute infections do. But in the case of cancer, we don't think that happens very often. In metastatic cancer, what happens is that T cells basically lose the capacity to make interleukin 2, TNF, and then ultimately interferon gamma, and then acquire these checkpoint molecules on their surface, like CTLA4, PD1, LAG3, etc. And so these checkpoint molecules essentially, are what you're inhibiting when you give checkpoint inhibitors. And so one thing that is very clear in immunotherapy is that PD-L1 expression is a fundamental property of tumors. And if you look at, for example, melanoma, and this is a paper from many years ago now, but if you look at PD-L1 expression, the higher the PD-L1 expression, the more responses you get. So like if you look at APS 0 or 1, you're going to have a response like maybe in 10% of patients. If you look at PD-L1 expression of 4+, that's kind of like somewhere between these two slides here, with PD-L1 expression present on practically all cells, you can get a maximum of 70% response to just a single agent PD-1. So that is that appears to be true in multiple tumor types and multiple immunotherapy settings. The other thing that has emerged in many studies over the last 10 years is the importance of other factors, and that includes things like gender, obesity, microbiome. There's been elegant studies done by Dr. Wargo and Dr. Gajewski, showing basically that tumor microbiome is a powerful impact on immunotherapy response. Tumor bulk seems to be an adverse factor. Age. Years ago, I thought that, if you had told me that older people would have a harder time with immunotherapy, checkpoint immunotherapy, I would have believed that. But basically what data has shown us is that it's the opposite. And we are not totally sure why that is, but the older you are, the more likely you are to have a response to immunotherapy. And then what we've shown in our group is the impact of liver metastasis. This is from 2017, a paper that Paul Tomei and our group published, and basically shows that liver metastases has a really adverse effect. And then things like male sex, beneficial ECOG 0, LDH has an adverse effect. But you could see that things like brain metastasis, lung metastasis really don't make a huge difference to immunotherapy response. So one of the pivotal studies we did back, again, about almost 10 years ago now, was extracting T cells from patients and looking to see what exactly was predictive of immune response. And basically what we showed is that the CTLA4 high, PD1 high T cells, so in other words, exhausted T cells, highly correlated with immune response. And you could see that in this very first histogram here. And you could see that positive cells, the more exhausted T cells you have, the more likely you are to have a response. And vice versa, the bystander cells, the CTLA4 low, PD1 low cells, don't seem to have an impact. And as a matter of fact, are enriched in non-responders. And things like regulatory T cells, etc., don't make a huge difference. And I believe this is a pivotal observation, because when we think of exhausted T cells, we often think like, oh yeah, these are cells that have run out of gas. But actually, those are the killer T cells that you need to have in the tumor. And this just shows that same paper. A lot of non-responders look like that. They don't have a lot of these PD1 high, CTLA4 high T cells. You could see that this patient had a neck melanoma had progression after treatment. And then this patient was a responder pre-treatment. You could see this axillary lesion totally disappeared, had 64% of all the CD8 T cells in his tumor were exhausted T cells. And so I believe this is a highly reproducible observation that has held for many, many years now. And so with that, let's look at Checkmate 67. That's the study, that's a pivotal study in our field that looked at a combination of nivolumab plus ipilimumab versus nivolumab alone versus ipi alone. And you could see this is, 6-year survival numbers. You could see that initially there isn't a huge difference between nivo, ipi, and nivo, but as time goes by, you see more and more of a difference. And you can see that as of 6 years and even longer, you're seeing a persistent difference, so that you could see that 50% of people on nivo ipi are alive versus 43% on nivo alone and 23% on ipi alone. So really profound difference stretching out many years. And interestingly, although this was definitely not the point of the study, you could see that the BRAF mutant patients have quite a benefit from treatment versus the BRAF wild type patients. So surprising, because this treatment is obviously not targeted towards mutations at all, but kind of showing that there's some interesting biology going on. Now, let's look at Relativity 47. That's a study that's the pivotal study that looked at the combination of nivolumab plus relatlimab, which is the LAG-3 agonist, versus nivolumab alone. So what's the difference here? Well, looking at the progression-free survival, you could see there's a huge difference. The difference is 4.63 months for nivo mono versus 10.12 months for nivo rela. You could see that in this Kaplan-Meier progression-free survival curve. The hazard ratio is 0.75 and p-value is pretty significant. And what is LAG-3? We don't fully know what it is, or we don't fully know why it is present on CD4 and CD8 T cells. And basically, it seems like a duplicated CD4 receptor, and its function in the tumor microenvironment and at co-stimulatory checkpoint situations seems to be binding to some of these ligands like galectin or L-sectin or FGL1. And these ligands, a lot of which are sugar containing or carbohydrate ligands, are present in the liver, they're present in cancer cells, and it seems like it's limits T cell activation. And where is LAG-3 present? It's not just present on exhausted T cells, which is what we were talking about a second ago. It's also present on NK cells, on regulatory T cells, and various other immune cells as well. And in the body, you can see that in lymphoid cells, basically, in the heart and in the pancreas, in a pretty significant proportion of patients. And what is the data? So a lot of our data comes from this study, the nivo plus relatlimab monotherapy study, which was basically looking at this combination of advanced tumors. And the study had many patients, over 400 patients, and multiple subgroups. And so one of the observations that was made that was super interesting was that if you had high LAG-3 levels, there was a higher chance of response versus patients with low LAG-3 levels. And you could see the spider plots, much more durable responses with high LAG-3 patients with this combination, which makes sense because you're inhibiting LAG-3 activation with this relatlimab antibody. And so when you look at the updated progression-free survival, that makes sense that we just talked about this. And if you look at the overall survival, I think there is an emerging difference, although it is not statistically significant at this point. You can see that the hazard ratio was 0.8 and the p-value missed statistical significance at its original analysis point. If you look at who exactly benefits from the LAG-3 combo, surprisingly in the relativity 47, LAG-3 expression was not a significant factor. But what was significant is basically the lack of PD-L1. So we talked about before how PD-L1 expression and PD-1 monotherapy response is highly correlated. But here, what you're seeing is that LAG-3 plus Nivo-Rela combo works most strongly as compared to Nivo mono, patients who don't have LAG-3. BRAF expression or BRAF mutation status did not matter, and other factors were not significantly predictive of response. So basically, lack of PD-L1 expression seems to be a big factor. Now, when you look at the relativity 020 study, so this is looking at the combination of LAG-3 plus PD-1 and looking specifically at cohort D. So these are patients who are pre-treated with PD-1. You can see that your response rate was 12%. So not nothing in the post-PD-1 setting. And if you look at other factors like PD-L1 positive versus PD-L1 negative, you can see that there isn't a huge difference between the two. And prior BRAF, not a huge difference. But you could see that all across the board with high LDH, presence of liver metastasis, all of these other factors in mucosal, acral, cutaneous, all of them, you do get some benefit from the combination of Rela and Nivo, even in patients who have progressed on prior PD-1, even if they had prior CTLA-4 therapy as part of their prior regimens. And if you look at the adverse events for relativity 020, if you look at the grade 3 or 4 adverse events, treatment-related adverse events is about 15% in D1 and then about 12% in D2. So definitely present, but a relatively low number. So with that, all of the data that we have, if you put it all together, you kind of get this type of graph. If you look at response rate on the x-axis and TRA, treatment-related adverse events on the y-axis, you can see that in Checkmate 67, the IPI arm, you have about 30% adverse events, 18 to 19% response. Similar for Keynote 006 IPI arm. But then if you go on to the right, you can see that Pembro mono, you get about 40% response rates. Checkmate 67, Nivo mono is about 43%. And Rela Nivo, you get about 43%. And then and Checkmate 511, the different Nivo IPI arms, somewhere between 45 and 50%. And then Checkmate 67, the classic Nivo arm, is about 53%, with also about 58% grade 3-4 adverse events. So that's the kind of landscape of treatments that we have currently. So what about just doing all of it at the same time? What about if you do a combination of all 3 checkpoints right up front? And so that was the Relativity 48 study. And so essentially, patients with advanced untreated melanoma given Nivo 480, Rela 160, which is the standard dose, with a lower dose of IPI given every 8 weeks. So significantly lower doses of IPI, and that is predominantly because of toxicity reasons. And below it shows the expansions. And so here's the demographics. Pretty standard phase 1-2 demographics. And if you look at PD-L1, typical for a lot of BMS trials, about 26% of patients had high PD-L1, and then 30% of patients had liver metastasis. And here's the response rate. And so looking at the response rate by investigator assessment, 59%, by BICR, blinded independent central review, 52%. And if you look at the CR percentage, which is an important number, 17% by investigator and 22% by BICR. So relatively similar in whether you look at investigator assessment or independent central review. And here's the waterfall plot. Looking at some of the, so these are patients who had liver metastasis, these are patients who had baseline brain metastasis. So kind of typical for a lot of patients who've had upfront combination immunotherapy. And here's the progression-free survival. Again, very typical for combination immunotherapy, showing a nice flattening of the curve, extending out to almost 4 years. And survival also looking very impressive, 72% survival up to 4 years. What about the adverse events? Now remember, the IPI dose here was significantly reduced to 1 mg per kg. If you look at grade 3/4s, it's 59%. And if you look at treatment-related adverse events, it's 39%. So pretty respectable number. And you're seeing some lipase increases and 4% of patients who had severe diarrhea. And then looking more microscopically at the immune-related adverse events, you could see 11% grade 3/4 colitis, some nephritis signal. And then patients who discontinued treatment due to toxicity still managed to have a very impressive progression-free survival, which is, I think, typical or something that we are used to seeing with immunotherapy. And so if you put all of this together and put the triple regimen along with the Checkmate 67 and Checkmate 511, which are the dual regimens, you end up with this purple dot here, which is actually in a pretty similar place as the dual regimen. And so let's take a look at how these regimens, let's look specifically at Ipi-Nivo, Nivo or Pembro mono, and relatlimab plus Nivo, and look at it versus PD-L1 positivity. So if you look at PD-L1 positivity and an objective response, you could see that at the higher levels of PD-L1 positivity, really all regimens, including Pembro or Nivo mono, are doing a pretty good job, and the response rate is going to be pretty high. The problem we have in melanoma, crucially, is at the low levels. I'd say from 0 to 2 is where we're currently struggling. And the biggest improvement we've seen is with both with Ipi-Nivo and Rela-Nivo in this low PD-L1 group of patients. And so I think here is where we are needing some assistance. And from the data that we are seeing so far, I don't know if we're really adding that much by doing the triple therapy at the lower PD-L1 levels, but I'm looking forward to seeing some more data which maybe would shed light on this issue, So I would say in conclusion that the Rela-Nivo Ipi has acceptable toxicity. I would say that the Rela-Nivo plus Ipi has similar activity to conventional ipi-nivo at this first glance. And I don't see a compelling advantage at this moment for triple combo therapy in the, with the dose of ipi reduced as much as we've seen. And I think given the fact that Nivo is giving you 12% response in the second line setting, including in patients who have had prior CTLA-4, I think it is reasonable to try doublets and sequential therapy at this point. And I definitely think there's room for experimentation and room for exploration. But with that, I'm going to end and again thank the organizers and thank you all for listening.
Thank you, Dr. Daud, for your presentation, and especially for its immunology introduction part, because it's my all-time favorite. So thank you so much.
Thanks a lot.
Okay, thanks a lot. And let me introduce our next speaker. Lilit Karapetyan she is an assistant member of Department of Cutaneous Oncology at Moffitt Cancer Center and assistant professor at the University of South Florida. Also, she is a recipient of the ASCO Young Investigator Award and the Melanoma Research Foundation Career Development Award. And she will represent us adoptive cell therapy in advanced melanoma. So, Dr. Karapetyan, the stage is yours. You can start.
I'm upload my presentation. It's still problem.
Dr. Karapetyan, but your voice is breaking. Can you please check your connection?
Yeah, I have you here.
Maybe it's from your earphones. I don't know, because your voice is breaking and it's
I can
now you are on mute. You muted the voice.
I am
No, it's the same. Can you please try without earphones, because we can't hear you.
About now. Can you hear?
We hear you, but it's the same way. Your voice is breaking. It's very slow and breaking.
Can you hear me now?
Yes. Your voice is clear now. Thank you.
Okay,
Sorry.
sure. So let me just so are you able to see my slides?
You are in. Yes, we see your slides. You can start.
I was just trying to go to full screen, like, okay. So I wanted to talk today about adaptive cell therapy for advanced melanoma and really focusing the advances and clinical impact. Something is like, I'm trying to scroll to the next slide, but it doesn't allow me.
Would you like us to share your slides?
Yeah, absolutely. You have that. Perhaps will be best.
Wait,
I'm going to stop share.
1 sec, please. 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 1 sec, ple
I can also try this way with the uploading one. It's in the system uploaded. If you want to go ahead with that one. Okay.
Yes, we can see you now. Thank you.
Yeah, right. So I wanted to start with talk really highlighting all of the work that has been done in National Cancer Institute, and really to point out that development of, in general, like tumor-infiltrating lymphocyte therapy, with the first discovery of interleukin-2 and its impact on survival of melanoma around 1980s, followed with actually murine models of identification of a TIL therapy impact. And finally, as you can see here, with the 2024, with the FDA approval of a first product, I really wanted to highlight that it took a long time to have any cell therapy approved for solid cancer like melanoma, but also a lot of the work that National Cancer Institute surgical branch did to really get this to the point. So I really wanted to highlight that TIL therapy consists of three important parts, and that includes lymphodepleting chemotherapy, generally done with cyclophosphamide and fludarabine, followed by TIL infusion and high-dose interleukin-2. And all of these three parts are critical for successful execution of the cell infusion. And before even we really go into the product administration or lymphodepleting chemotherapy, I also would love to highlight that everything starts from the tumor expansion from a surgically accessible side of the tumor, which usually is like around, as you can see in the figure, which represents a subcutaneous nodule, and which is called a tumor harvest. And then once tumors are explanted, they are being grown for ex vivo expansion. And usually, per standard of care, we use IL-2 for expansion protocols in a pre-rep, and additional modifications are being done in several clinical trials to really increase the TIL yield and quality of expanded TIL. But the general thought process is why we do is because, as you can see on the H&E, we have a melanoma tumor and then a lot of TIL surrounding the tumor microenvironment. We provide an opportunity for TIL to grow ex vivo outside of tumor microenvironment, where we do not have that negative impact of the tumor releasing factors, and provide the expanded growth. So usually the manufacturing lasts around 4 to 6 weeks, and once the product is ready, patients are able to receive the product. And when we follow in general for the treatment schema, it's important to highlight that treatment starts from lymphodepleting chemotherapy, which usually requires inpatient hospitalization, considering the high dose of the cyclophosphamide and fludarabine. Generally lasts around 5 days, sometimes can be provided over 7 days, followed by what they call day 0, which is usually the TIL product administration, which usually happens over 1 day, sometimes depending on a protocol, especially during the phase 1 development, we may actually provide a product infusion over 2 consecutive days. And after the TIL product is administered, usually patients receive high-dose interleukin-2, which is 600 units per kilogram. Really high dose comes around 50 million per patient or less, and it's being administered every 8 to 12 hours, up to 6 doses currently as tolerated. So when we look at the pivotal trial result that really led to the FDA approval of what we call now lifileucel, you can see here that in the pool cohort of around 150 patients, objective response rate was around 31%. And these are really a lot of partial responses, but there is also a lot of disease control, as you can see from this waterfall plot, patients receiving like what they call now lifileucel. And this is a study that actually led for the approval of lifileucel. And then we followed these patients for a much longer time. Now we can speak more about like patterns of responses. And you can see here in a swimmer plot that a lot of the times these responses are actually present during the first assessment, which is around like 6 weeks. Here's why we have a lot of these partial responders or CR starting from week 6, and proportion of those are actually very durable. And then investigators presented 5-year follow-up data about the trial. We can see that median duration of response was around 36.5 months, which does highlight that this provides a durable responses to a proportion of patients that we treat. And furthermore, when we look at the overall survival data, and especially highlighting that these are patients who already progressed on conventional immune checkpoint inhibitor therapy, we can see a median overall survival of 13.9 months, and highlighting really 5-year overall survival rate of 20%, which is very meaningful for patients who already progressed on first-line PD-1 therapy. I wanted to highlight that these efforts really have been not only in US and especially the European investigators and at Netherlands Cancer Institute specifically have done major advancement in the field. And a really important study to highlight was to compare TIL therapy to ipilimumab, which was more elegant trial in terms of the design as a randomized control trial. And when patients received TIL, as you can see here, they demonstrated improvement in progression-free survival with a hazard ratio of 0.5. And when we look at really the response rates, they were clearly meaningfully increased in patients receiving TIL therapy, both from perspective of objective response rate of 49% versus 21%, and a complete response rate of 20% versus 7%. While a lot of us would say that, especially in US, the control arm of ipilimumab is not really commonly used at the moment. I think it's important to acknowledge that within this trial, the superiority was clearly demonstrated for the TIL, and it's currently being used in Europe as well as a sort of post standard of care product. And then lastly, I really wanted to highlight that we at Moffitt Cancer Center have done this for more than 10 years. And really for our evaluation, I wanted to highlight that when other immunotherapy agents were approved, there has been several trials done with a TIL only or TIL combined with ipilimumab, nivolumab, or targeted therapy. And as you can see here, the durable responses, which we define as a response lasting a year and longer, was 36%, which is very meaningful. And if you look at the further follow-up, around like 10-year follow-up, a significant proportion of these responders remained without disease progression. So a lot of these efforts really led to approval of lifileucel for advanced melanoma, and specifically highlighting it's an accelerated approval and designed for patients who progressed on PD-1 therapy, as well as if patient has a BRAF mutant melanoma, they may receive or BRAF targeting agents as well. So I wanted to specify is that assessment of patients for TIL therapy is very particular, and a lot of times it relates to patient-related factor as well as disease or tumor-related factors. So we do evaluate patient performance status, medical comorbidities, what we call a vital organ testing. Patients undergo pulmonary functional testing, echocardiogram, and sometimes cardiac stress tests as indicated. We evaluate their bone marrow reserve, infectious workup, and obviously it's very important to evaluate any presence of immunosuppressive medications. which largely may be present because of previous adverse events due to immune checkpoint inhibitors. And then it's equally important to think about the disease type, like whether the patient has large tumor burden, where is the disease located, like does the patient have bleeding bowel metastases, does the patient have harvestable disease, kinetics of disease progression. Really, like rapidly progressing tumors are not good for cell therapy because it does take around 4 to 6 weeks for manufacturing. And obviously also the bridging therapy, which we provide between the tumor harvest and the cell infusion. So I do want to highlight that after approval, we executed the real-world evidence study of TIL administered for advanced melanoma patients. Moffitt and other centers are highlighted here. And we really wanted to ask a question now. We know that TIL works for clinical trials. How does it perform in real-world settings? Specifically, many years passed from original trial, and a landscape of first-line therapy also have changed for patients with melanoma. And we designed a real-world study. Patients underwent tumor harvest. Some of them received optional bridging therapy, followed by regular lymphodepleting chemotherapy, lifileucel infusion, and high-dose IL-2. And we can see here that even in a real-world setting, a response rate actually was quite remarkable with 44%, with a disease control rate of 73%. And even though the follow-up is short, we can appreciate that a significant proportion of those remained without disease progression. And a lot of these responses were seen already during the first follow-up. Sort of very similar as we see in a clinical trial performance. And really, I want to highlight this case, like it's almost a lot of the times very remarkable what we see with a single cell infusion, as this is a patient of mine who received targeted therapy as well as immunotherapy with ipi-nivo before, and had a quite extensive disease, as you can see. And then a week 6 PET-CT already reveals almost complete response, and patient continues now around 2-year follow-up with remarkable response to the therapy. So this is definitely very meaningful for patients, especially that they do not have to come for repetitive therapeutic approaches like continuous infusion of ICI therapy. And we further look like what are important things really predicting a response. And something that was really important to think about is the prior lines of therapy. For patients who received 2 and less prior lines of therapy, response rates were higher, around 52%. Similarly, patients who seem to have a less like a distant metastasis or lower LDH, they had a higher response rate. Responses were really present in several subtypes of melanoma, including like acral and mucosal, and also present in both BRAF mutant and BRAF wild type patients. I think what we learned from this slide that really the patients with less prior lines of therapy, less burden of a disease, tend to benefit more from this type of therapy. And with the preliminary evaluation of survival follow-up, we do see median PFS of 4.4 months. And overall survival data, there is a lot of censoring, but the median overall survival was 10.2 months. And notably for both PFS and OS, patients who received 2 and less prior lines of therapy, they tend to have a longer PFS and OS. And to really conclude this talk, I want to highlight about adverse events as well. First, really to highlight that adverse events after TIL therapy are more predominant during first 14 days of the therapy. And I would say most of those are really related to either to chemotherapy like Cy/Flu or a high dose interleukin-2. And to speak more about this, like you can see that based on a large pivotal study, most side effects were cytopenias, actually, thrombocytopenia, anemia, neutropenia, febrile neutropenia, some metabolic disturbances, and really some organ function changes like transaminitis, metabolic changes, edema, hypoxia, hypotension, which are really more driven by IL-2. There are only like 3 unique TIL-related adverse events that we evaluate in patients, and some of them may actually appear a little longer after day 14, like uveitis, vitiligo, and sensorineural hearing loss or disequilibrium, and those are really important to assess during the long-term follow-up. And lastly, to tell about the IL-2, IL-2 is a very high dose IL-2 here, and usually patients receive it inpatient. And some of the reasons I have highlighted here for discontinuation. And you can see that a lot of times this is a combination, like patients having inflammatory symptoms like fever, chills, but also some cardiovascular reasons, arrhythmias, some hypoxia, metabolic disturbances, and also patient refusal, because sometimes these side effects can be really difficult to handle by the patients. And some of us already think about these issues, like especially for lymphodepletion side effects. We at Moffitt actually established a protocol of reducing cyclophosphamide dose, as you see here, 40 milligram per kilogram, and selected population of patients who are, for example, age of 70 and above. They have recent bowel metastases or brain metastases. Some of them require like continuous antiplatelet therapy, anticoagulating therapy. And also when we start first day of cyclophosphamide, if patients have difficulty tolerating that, we may discontinue it for day +4. One of the major concerns we have when we change lymphodepletion is to ask whether the responses actually still remain there. And you can see here, although small study, we do show here that response rate was still 44%, very reasonable, and a lot of these responses were continuing during the follow-up. While we still need to investigate this regimen further, I think this does allow treatment of patients who would otherwise be disqualified from high-dose cyclophosphamide therapy. So with this, I wanted to conclude my talk that TIL therapy provides durable clinical benefit in advanced melanoma after PD-1 failure, and we've shown this both in clinical trials as well as in real-world practice. Considering the benefit really in low disease burden, it's important to refer patients earlier. Generally, toxicities are predictable, manageable, and primarily driven by ILD chemo or IL-2. And successful TIL therapy does require multidisciplinary coordination and also careful patient selection due to a high incidence of acute side effects within first 14 days of therapy. With this, I would like to acknowledge our team and thank you for your invitation. If you could please help me to take out my slides.
Thank you, Dr. Karapetyan, for your there is another slides? I'm sorry. Or
no, I'm done. I was trying
okay,
to.
Perfect. Thank you so much. Thanks for your presentation. Thanks so much. And let me introduce our next speaker. Dr. Philip Friedlander, who will represent us how I treat melanoma in USA. Dr. Friedlander, the stage is yours, please.
Thank you, and I hope you're able to hear me okay.
Yeah.
And I'm gonna thank you for the invitation. I'm gonna screen share. Are you able to see that or no?
Not yet. There is a button in the middle. There is a microphone, video, and screen share button. Click on it and you can share your screen.
Okay. The microphone, screen share.
Microphone, video, and screen share. The middle button.
Yeah. Let's see if this works. No, it's saying share, but it's. No.
Let me 1 second. Let me check with technical team. also you can try the click the H, letter H on your keyboard. Maybe it will help.
Share that.
H, yes.
Yeah, it's showing me choose what you want to share, but it's not my screen that it's. And I don't know what I'm. It doesn't look like I'm going to be sharing. Because my, I have my what I want to share here, but it's not going straight to my screen window. Oh, here. I think I figured it out. Let me see if this works. Do you see something now?
Yeah, perfect. We see your slides. You can start.
All right, so I'm gonna just slideshow.
Yeah.
Are you still able to see it?
Yes. We are seeing your slides. You can start. Thank you.
Great, thank you. So I'm going to give a general overview of for cutaneous melanoma of the general approach of treatment throughout the United States, realizing there are many caveats and different personalized styles. And I'm going to start with discussing stage 4 disease. And this is data from survival curves from 2009, where one can see very poor long-term survival and the location of metastasis modulated survival rates. And similarly, if one had an elevated LDH, that conferred worsened survival. And again, this is from presented in 2009, and it was reflective of the fact that we only had for stage 4 melanoma 2 FDA-approved options, neither of which had proven overall survival benefit. The carbazine chemotherapy was under 20% response rates and usually non-durable, and interleukin-2, which could engender in approximately 5% of patients pathologic complete response in the select patients who could tolerate, who could have the cardiopulmonary reserve to be able to tolerate interleukin-2. And so at that time point, choosing a therapy option was much more limited in terms of decision making, and clinical trials remain an important option for patients to consider and recommend, all the more so back at that time period. But more recently, we have a lot more treatments that are FDA, Food and Drug Administration, approved in the United States for the treatment of stage 4 melanoma, agents that are immunotherapy-based, checkpoint inhibitors, and also if there's a BRAF, V600 BRAF mutation, targeted therapies, 3 different combinations of BRAF plus MEK inhibitors. This also was discussed in a prior presentation, tumor-infiltrating lymphocyte therapy in select patients, and TVEC, intratumorally injected oncolytic herpes virus generated to secrete GM-CSF in very select patients. So one can imagine that as we have more treatment options, how to approach treating a patient is a lot more complicated in terms of decision making. And so for stage 4 melanoma, when one looks at first-line systemic therapy, there are many factors. This isn't an exhaustive list, but one looks at patient-specific factors, comorbidities, performance status, patient's personal preferences on how to approach treatment of the cancer, tumor-specific factors, the extent and the symptoms related to metastases, the location of metastases, such as in the brain or in the liver, the growth rate of the tumor, the mutational profile of the tumor, if there's a BRAF mutation or KIT mutation, serum LDH, which is poorly negative, has a worsened prognosis as examples. And more recently, and I'll discuss as the next later in the talk, is adjuvant and neoadjuvant therapy in stage 2, 3, and resected stage 4 melanoma, and prior therapy that was received adjuvantly and neoadjuvantly, and the time from treatment to recurrence all factor into first-line systemic therapy choices. And we have several broad buckets. anti-PD-1 based immunotherapy regimens as a monotherapy, which was the first FDA approvals, as nivolumab or pembrolizumab, ipilimumab, CTLA-4 blockade with nivolumab, and then Opdualag, LAG-3 inhibition, which was discussed in a prior presentation, relatlimab in combination with nivolumab. And then if there's a V600 E or K BRAF mutation targeted therapy with a combination of BRAF and MEK inhibitors. BRAF inhibitors are FDA approved in single agents, trametinib and MEK inhibitor also, but there's less toxicity and more efficacy with the combinations. And then other immunotherapies, the tumor-infiltrating lymphocytes and TVEC, and then other such as cytotoxic chemotherapy with no proven survival benefit, or a palliative approach. And obviously, throughout all of the treatment decision makings, the option of determining eligibility for appropriate clinical trials. And here's data from 3 initial studies published in the New England Journal of Medicine showing efficacy of pembrolizumab, nivolumab in the majority, in many patients where only a small subset have upfront progression. And then you can see on the right with nivolumab plus ipilimumab deeper and more rapid responses. And this led to ultimately the Checkmate 067 study, where 945 previously untreated patients with stage 4 melanoma were treated with CTLA-4 blockade alone with ipilimumab, or PD-1 inhibitor alone with nivolumab, or the combination with 3 milligrams per kilogram of ipilimumab and 1 milligram per kilogram of nivolumab every 3 weeks for 4 treatments, followed by nivolumab maintenance for up to 2 years, looking at co-primary endpoints of progression-free survival and overall survival. And this study was designed to power the anti-PD-1 arms to the CTLA-4 arm. And one can see with a minimum of 10-year follow-up that the median overall survival with ipilimumab CTLA-4 blockade was approximately 20 months, with PD-1 inhibitor alone 37 months, and with the combination 72 months. And when one looks at response rates, the response rates 58-59% with the combination and 45% with nivolumab alone, while approximately 20% with ipilimumab. And melanoma-specific survival median was not reached over 120 months with the combination versus 49.4 months with nivolumab alone versus 22 months with ipilimumab. So this established that first-line checkpoint inhibitor-based immunotherapy should be anti-PD-1 based as a backbone, as opposed to CTLA-4 monotherapy, as ipilimumab monotherapy was FDA approved in 2011 as an initial checkpoint inhibitor, given survival benefits. While there's more efficacy in this study seen in terms of median overall survival and response rate to the combination arm relative to nivolumab alone, it comes at the price of a higher grade 3, 4 immune-mediated toxicities, while with nivolumab alone, it was 24% in this study and 59%, so the majority of patients with the combination arm. If one was alive and was progression-free at 3 years, there was excellent 10-year melanoma-specific survival in patients, so durability. And treatment stopped after 2 years of treatment with the maintenance nivolumab. And the high toxicity rate raises a concern one has to consider when approaching a patient about, is this a patient who could tolerate toxicity, if high-grade toxicity if develops. The other combination is the LAG-3 inhibition with nivolumab in the Relativity 047 study, which was discussed earlier, versus nivolumab alone, where there were recurrence-free survival benefits and survival benefits for the combination of patients. We do not have prospective randomized relatlimab plus nivolumab randomized against ipilimumab and nivolumab. But there was a progression-free survival benefit in multiple subgroups, including those with elevated LDH, aqueous melanomas, and PD-L1 expression level is important. And patients had less than 1% PD-L1 expression. There was no difference in progression-free survival. Similarly, in earlier studies preceding Relativity 047, while there was some efficacy with second-line or later-line anti-LAG-3 therapy, it's not as efficacious as when used upfront. And we'll get back to the immunotherapy in a moment. In patients that have a BRAF mutation, and that's approximately 40% of patients have a V600 BRAF mutation, particularly patients who have melanomas arising in a non-chronic sun-damaged skin, but can occur in other subtypes. Then blocking BRAF and then downstream MEK has clinical efficacy, and there are 3 FDA-approved combinations, and here on this slide is data showing additive benefit of adding BRAF plus MEK inhibition versus BRAF inhibition alone. For example, in the COMBI-D study, there was response rates with BRAF plus MEK inhibitors approximates 70%, while with BRAF inhibitor alone, it approximates 50% in these studies. The Columbus study, using the BRAF inhibitor encorafenib and the MEK inhibitor binimetinib, showed added benefit over encorafenib alone. But this study also compared 2 different BRAF inhibitor monotherapies, encorafenib and vemurafenib, and numerically they were better outcomes in terms of response and survival with encorafenib. And this is only an option in patients who have a V600 BRAF mutation. So if you have a patient with stage 4 melanoma who has a V600 BRAF mutation, and you have upfront choice between BRAF MEK inhibition versus anti-PD-1 based immunotherapy, how to choose. This led to the phase 3 DreamSeq trial, the ECOG-ACRIN EA6134 study, where patients who had a V600E or K BRAF mutation, unresectable stage 3, it should reach stage 3, or stage 4 melanoma, or treatment naive for metastatic disease, were randomized upfront to ipilimumab plus nivolumab, or to dabrafenib plus trametinib, and then crossover on progression. Primary endpoint was 2-year overall survival, and 73 patients went on to step 2, where received the alternate therapy. And this study was stopped early by the Data Safety Monitoring Committee because of statistically significant benefit to starting first line with immunotherapy. It was 71.8% 2-year overall survival with immunotherapy first versus 51.5% with the BRAF MEK inhibitor targeted therapy first. And similarly, median duration of response is also was statistically better. And so based on this data, a standard approach is to use anti-PD-1 based immunotherapy first line over BRAF MEK inhibitor targeted therapy for the treatment of patients with V600E or K stage unresectable stage 3 or stage 4 melanoma. One always has to consider, though, patient-specific factors, comorbidities. Does one have an organ transplant or active autoimmune disease to make a personalized decision? Later lines of therapy, if one has a V600E or K BRAF mutation and progressed on first-line anti-PD-1 based therapy, then a standard approach would be BRAF MEK inhibitor therapy. Other things to consider are TIL-based therapy, but as I'll show in a later slide, and it was discussed previously, the approval in the United States is based on having prior BRAF targeted therapy in patients that have readily injectable disease, such as, let's say, multiple intransit lesions on the leg. T-vector oncolytic herpes virus can be an option. Cytotoxic chemotherapy is very palliative and considered if there's really no other, alternative, but yet a patient who one would wants to continue therapy and is appropriate from a performance status to be able to consider continue therapy. Patients with wild type BRAF consider TILs as second-line therapy if an appropriate candidate. If one had ipilimumab and nivolumab first, then relatlimab, nivolumab can be considered, but efficacy will be low, and then the T-VEC and cytotoxic chemotherapy in select patients. If one received nivolumab or relatlimab up front, then consider ipilimumab and nivolumab as a next-line therapy versus TIL-based therapy. When one thinks of TIL-based therapy, this is a therapy that's an option for a select group of patients. Tumor has to be harvested, and it could take months approximately to create a TIL product. And then patient receives lymphodepletion, as discussed earlier, with cyclophosphamide and fludarabine, then the TIL infusion, and then interleukin-2. And one needs to be able to have a bridging, potentially need bridging therapy as product is made, and felt to have the cardiopulmonary reserve and to be able to tolerate treatment safely. As discussed earlier, efficacy seems to depend on having lower volumes of disease, earlier lines of therapy, where in those settings, response rates from real-world analyses could approximate 50%. Later line group of patients, approximately 33% of patients. So lifileucel is approved in the United States for patients previously treated with an anti-PD-1 blocking antibody and a V600 BRAF mutation positive, a BRAF inhibitor with or without a mechanism inhibitor, which led to the accelerated approval based on overall response rate, with continued approval contingent on confirmatory trials. And so this is not currently a first-line treatment option in the United States. But patients now who present with stage 2B, 2C, and stage 3 melanoma often are receiving adjuvant and or neoadjuvant therapy. Here's the data from the Checkmate 238 study in patients with stage 3B or 3C melanoma, showing relapse-free survival benefits to a year of adjuvant nivolumab compared to ipilimumab with less toxicity. And that's become a standard of care. Pembrolizumab also is FDA approved for a year of adjuvant treatment. In that study, stage 3A patients with deposits of a millimeter or greater in the central lymph node were also included. So we would consider adjuvant PD-1 inhibitors in patients with stage 3 melanoma, especially if there's at least in stage 3A patients a millimeter deposit of melanoma in the metastasis. In stage 2B and 2C melanoma patients, there are also relapse-free, survival benefits to pembrolizumab over placebo, and then efficacy also seen with nivolumab in this setting. So now patients who have stage 2B and 2C melanoma and stage 3 are considered for a year of adjuvant anti-PD-1 based therapy. One has to balance, especially in the stage 2B patients, other patient-specific factors relative and toxicity risks of PD-1 inhibitors relative to potential benefits. We do not have proof of overall survival benefit, and that might be because treatment of patients who do not receive adjuvantly may be salvaged by anti-PD-1 based regimens in this context of recurrence. Similarly, adjuvant BRAF inhibition with dabrafenib and trametinib showed survival benefits with a year of therapy. And this is a consideration also if patients have V600 BRF mutation. There was worse outcome actually if one had a V600K mutation. Adjuvantly, we do not have the randomized data of the dabrafenib trametinib versus nivolumab or pembrolizumab, but there's a higher high-grade toxicity rate with dabrafenib and trametinib, but readily reversible by holding treatment, while with anti-PD-1 therapy, there's risk for permanent toxicity such as endocrinopathies as an example. And so we have, in the United States, FDA approvals for stage 3 melanoma of ipilimumab, nivolumab, pembrolizumab, and if patients have BRAF V600 mutation, dabrafenib, trametinib, and then pembrolizumab and nivolumab for stage 2B and C melanoma. We did not see survival benefits when studied ipilimumab and nivolumab and belamab and nivolumab, and they're not FDA approved adjuvantly, and BRAF MEK inhibitor combinations other than dabrafenib trametinib are not also formally FDA approved. But there's recent data, not FDA approved, but now used based on this data in clinical practice with neoadjuvant immunotherapy, where there's earlier time to systemic therapy and able to directly assess anti-tumor response and potentially shed antigen in the context of treatment because macroscopic tumors in place to try to better generate an anti-tumor response and potentially avoid a lymphadenectomy or decrease the surgical morbidity or increase a R0 resection rate. There are risks with any neoadjuvant approach of a prohibitive toxicity that could delay or prevent surgery or refractory tumor that rapidly grows and becomes unresectable. And the SWOG 1801 study randomized patients with stage 3B to 4C resectable melanoma to 3 doses of pembrolizumab PD-1 inhibition followed by surgery and then complete a year of therapy with 15 doses every 3 weeks apart after surgery versus purely adjuvant approach where all 18 doses are given after surgery. And there was events-free survival benefits to the neoadjuvant approach where 3-year event-free survival was 68% versus 56% was the adjuvant. Then there's also the NADINA study where patients with macroscopic stage 3 melanoma, and in this study in transit metastases were allowed. One received 2 doses of ipilimumab plus nivolumab with approximately 1 mg per kg of ipilimumab, 80 milligram flat dose, and then nivolumab at 240 mg. It shouldn't say per kg. And then surgery, and then a response adaptive adjuvant therapy approach versus surgery followed by adjuvant nivolumab for 12 cycles. And there was an event-free survival benefit with the neoadjuvant approach, 83.7% had 12 months event-free survival versus 57% with a purely adjuvant approach, and 24 months event-free survival with 77% versus 56%, and hazard ratio for progression, recurrence, and death 0.32. 59% of patients in the neoadjuvant group had a major pathologic response, and only 2.4% had progression, and 26% had no response, was greater than 50% residual viable tumor. An estimated 24 months recurrence-free survival was 95% if there was a major pathologic response, 69% if there was a pathologic response, and 48% if there was no response. And high-grade toxicity, grade 3 or higher immune-mediated toxicity was approximately 29.7% in the neoadjuvant group versus 14.7% in the adjuvant group, but not the 59% we see with the ipilimumab 3 mg per kg, nivolumab 1 mg per kg we use in stage 4, FDA-approved stage 4 setting. And so for patients who have macroscopic stage 3 disease, in transit disease or regional or lymph nodes, then based on this data, an option, well, not FDA approved formally, but an option is to use the 2 cycles of neoadjuvant nivolumab. And if there is a complete response or near complete response, to follow expectantly, while if there is less of a response, then if there's a BRAF mutation, V600 BRAF mutation, to adjuvantly administer dabrafenib and trametinib, and if there is not, then to administer adjuvantly the nivolumab. And if one looks at the NCCN guidelines, as practiced in the United States, there's from a category 1 adjuvant systemic therapy options of nivolumab, pembrolizumab, and dabrafenib and trametinib with V600 BRAF mutation. And then if there is a clinically evident resectable stage 3 melanoma with nodal basin disease or isolated in transit disease, then the category 1 is nivolumab and ipilimumab, and other preferred regimen based on the SWOG data is the pembrolizumab and other potential regimens that one could be considered for. Some data is LAG3 plus PD-1 inhibition alone neoadjuvantly, or BRAF MEK inhibition. So when one now has stage 4, a patient with stage 4 melanoma, one always continues to consider clinical trials that factor in comorbidities, but also very important is prior adjuvant and neoadjuvant therapy. For example, if a patient had neoadjuvant PD-1 CTLA-4 blockade and then did not have a response and became stage 4 shortly after, and has a BRAF mutation, to use that. If one's wild type BRAF, to consider TIL therapies at that point. And there are times that one could have a BRAF mutation, and despite the DreamSeq data, the tumor is very symptomatic, rapidly growing, and at times consider using BRAF MEK inhibitor for a limited period of time to get control of the tumor with an intent to transition to BRAF, to PD-1 based therapy such as ipilimumab and nivolumab. If one has brain metastases, there's data to strongly support combination CTLA-4 PD-1 blockade as the immunotherapy of choice. And so I want to thank everyone for providing the opportunity to discuss this today. Thank you.
Thanks, Dr. Friedlander, for your presentation. Thank you so much. And now we are going to our closing panel discussion. The topic is the future of melanoma care, challenges, innovations, and global perspectives. And moderator will be Dr. Barbara Ma, co-chair.
So thank you again to all our speakers for an outstanding symposium. And I think that what was particularly striking today was not only how rapidly the field continues to evolve scientifically, but also how broad the discussion has become, because we went through many, many different topics, including immune-related adverse events, brain and leptomeningeal disease, survivorship, global care delivery, AI, and adjuvant therapies, and also personalized cell therapies. So what I'd like to begin is a broad question for the panel. So if we look ahead 5 to 10 years, what do you think will represent the single biggest shift in melanoma care? Anyone want to take that one first?
I would
Sure.
say, this is Adil Daud. I would say that, for me, I think it's like understanding that, melanoma, like breast cancer or like lung cancer, is just fracturing into a whole lot of different entities. And, we realize that, if you're PD-L1 positive, or if you have liver mets, or if you whatever conditions, those are treated differently. And I feel like, there's this model of myeloma where, you have like quadruplet therapy in the upfront setting, versus the more like the different model of breast cancer where, you've got HER2 positive disease and ER/PR positive. So I feel like melanoma is going more in that direction, where you're getting these different disease entities, and trying to figure out how we can have those, have those very specific types of treatments,
I think we're going to see more personalized cell products. There's been exciting data from TIL therapies, as we sort of discussed today, as well as from some of these upcoming trials that are pending to read out, like the V940-001 or Interpath-001, where we're using personalized mRNA vaccine products to help patients bring their own neoantigens to bear on immunotherapy. And continuing to progress in this direction of personalization and tapping into the resources within each patient's T-cell repertoire are going to be transformative, and make this a very biopsy and autologous-driven cancer science.
So in my perspective, as somebody from Europe and Germany, I need to say that even in 5 years, I think we are talking about 52% melanoma-specific survival. The hurdle is very high of ipilimumab, nivolumab, and I guess for the entire population as first-line treatment will be very difficult to reach this particular hurdle. So I believe also, like Adil, in shifting towards slicing the disease melanoma into sub-entities. And I strongly believe in cell-based therapies, although they're expensive. The personalization is very expensive. And in Germany, we have, for the first time since 1 year, for the first time in my 38-year-old career, the discussion on the pricing, and these kind of drugs like the TILs are not making it to us. So because they are extremely expensive, I'm very much looking forward to the price of a personalized mRNA vaccine. And in very many countries, it might not be used in all comers.
And then what I'm really looking forward to, Joseph Markowitz from Moffitt Cancer Center, is yes, the TIL, the personalization, but really how do we stratify people up front? How do we tell who is going to respond to our currently approved therapies versus who will not? Because if we really can say who will not respond to our current therapies, then these are patients that potentially can go on TIL and other more personalized types of therapies up front in the clinical trial setting.
Yeah, so a lot of panelists pointed out that we really are headed towards personalization, and also bringing up cell therapy. So I would say cell therapy is probably the most personalized, and melanoma is leading the way, well, for across other solid tumors as well. But it's really melanoma where it became more investigational promise to full clinical reality. So what do you think are the biggest remaining barriers in terms of translating cell therapy to other places? Like, there is the point of how there are global disparities. What are some of the barriers you see to translating cell therapy across more broadly?
Maybe I think it is intrinsically. Sorry. I was just going to say it's intrinsically expensive, and the fact that you have to do the, upfront lymphodepletion, that's just a super expensive thing. And my personal opinion on cell therapy is that I think if you truly have no exhausted T cells left in the tumor, and you're truly PD-1 refractory, it's unlikely that cell therapy will help. But I know that's the minority viewpoint.
So maybe I can jump in here at Steve O'Day. It's nice to be with this group again. Obviously melanoma is a hot tumor that we are now curing over 50% of patients, and Axel and Adil and I have been around a long, long time. And certainly in the refractory setting, we have our challenges and right now, and there are some limited activities. But I still think the bigger opportunity going forward is, why are 50% of melanomas, a hot tumor, not responding at the outset? And that's the group, and that also in the vast majority of solid tumors, obviously, that are poorly immunogenic, have never been part of this revolution. And so the real issue to me is not salvage therapy, but how do we actually make priming and activation recognition at the outset better, even for hot tumors, but obviously cold tumors that have, and obviously CTLA-4 is a priming agent, vaccines certainly with mRNA, and I've been focusing this scope of my career in next generation CTLA-4s that really expand T cell repertoires and work better at priming and diversifying. So obviously, to me, that's really certainly earlier treatment and recognizing which tumors, even hot tumors like melanoma, are resistant from the outset, and how do we have better agents at the beginning that will capture that? Because once you develop a primed, activated response to TILs and infiltrating T cells, whatever route you go, I mean, the magic happens downstream, and it seems to me that that's where we need to be focusing, where I've been thinking a lot about it in recent years. But nice to be with everybody again.
And thank you. And to follow up on that, the paper that we published back in March timeframe in the Nature of Precision Oncology, it's really the immune microenvironment, whether it's, it does not, it matters what are the immune cells there that really determine whether someone's going to respond or not. So someone can have an immune microenvironment and then completely not respond. So that's to the comment earlier, that once we can figure out who's not going to respond, then they can go on to some of these more novel types of therapies. Because if we could have a 95, 99% chance versus something like TIL or something of these sorts, where we think that the chance is higher, the question is also that we always have to have clinical equipoise when it comes to clinical trials in order to move the needle forward.
I think one of the biggest hurdles in our field and sort of the glaring omission in melanoma is the absence of meaningful biomarkers. I think the point made about tumor microenvironment is real, and I'd like to see things like interferon gamma signatures come to clinical reality and use. As mentioned, it's a lot more than just the T cells. It's the myeloid-derived suppressor cells. It's the other immune inhibitory environment that we have to tap into and sort of screen out from these tumors to allow the T cells their activation. I think more work to sort of work against the negatives in that space are going to further potentiate what we can do in that. And we just need novel biomarkers that are going to help drive the way towards, again, personalized decision-making, who we expose to the toxicities of intense T cell activation, and